We begin the second day of the conference of the AOK network with the first presentation by Dr. Nathalie Chapak from Bogota, Colombia. She'll be speaking on KMC and brain development, a plea for starting KMC as soon and as long as possible. Nathalie Charpak is actually a French citizen who migrated to Colombia and was the initial founder and director of Kangaroo Foundation, during which she initiated a lot of the research work that we see having follow-up studies now. She has initiated one of the first RCTs on. Okay, and I have just come to know that we have to wish her a happy birthday. Many happy returns of the day, Dr. Nathalie. We'll soon have you speaking to us. She has received the French, I think, Legion of Honor Award, and most recently the National Neurology Forum Lifetime Achievement Award. So I give you Dr. Nathalie Chapak. You're free to share your slides and begin your presentation. We can't hear. We can't hear you, Azet, so just hold on.
Yes. So good morning. Good morning to everybody. First of all, I'd like to say how sorry I am not to long-term friends from the Kangaroo Adventure. United Nations did a public have not changed in any region of the world in the past decade. That's incredible. Because despite of technological advances in neonatal care, it didn't change. Why? So we have an increase of multiple pregnancies secondary to medically assisted reproduction technique. It's true. And we have increase of what we can call induced or medically decided C-section and prematurity, C-section before 37, in face of a severe pathology of the pregnant woman, but sometimes not so severe pathology, especially in South America. And it's really a big problem. And I will continue saying it's not that only now we are realizing that prematurity is responsible not only for the big and major motor sequela, mainly in early childhood, but also for the minor long-term sequela. Yes, when they are adult, problem of coordination of behavior, cognitive problem, learning problem, hyperactivity, school failure, aggressiveness. And we must be very conscious that misuse of technology reduce mortality but increases long-term sequela. And neonatologists, they just love there is a tendency to say the smaller immature premature. Yes, it seems that the smaller is 212 grams, like this one or this one. So how is there is a problem? No. How is the KMC intervention in 2023? So the KMC is resuscitation can be done, at least can be begun in KMC, and if not possible, can be done in a warmer, and the baby can come back to the KMC position. WHO is asking to do kangaroo mother care since delivery and to continue not to separate the mother and the baby up to the neonatal unit if the baby is hospitalized. Referral to other hospital can be done in kangaroo. Extrauterine transition of a stable baby can be done in kangaroo with the mother.
ये तुम्हें
But
पता है
that,
यहाँ से
so KMC kangaroo can be done in intensive care, in intermediate care, and for us at least, kangaroo word, we don't use it in Colombia, but in a lot of countries it's used. And after the kangaroo word is a step, and the baby will go home in kangaroo position with a follow-up in a KMC program. Kangaroo follow-up up to 40 weeks, then a high-risk follow-up. So everybody, you know this position paper of WHO on kangaroo, the implementation strategy guide for scaling kangaroo mother care at a country scale. I will just say something, at least for South America. It's not going to be easy because there is a cost. You have a lot of high-tech and very good high technology neonatal unit, and it's not easy to put a bed. I will say that in a lot of them, it's impossible. So they are waiting when they are going to modify or to rebuild the unit at this moment to put a bed near the intensive care, the baby who is in intensive care. It's not so easy and it's a high cost. So we continue to do research in the Kangaroo Foundation. We are particularly interested in the brain. We just finished to send a grant because we need some support to continue our analysis, but we are very interested too to share with everybody the result of the follow-up in the kangaroo mother care program, and we just began another kind of analysis with this follow-up and big database of 57,000 babies followed in ambulatory care in Colombia. So for me, kangaroo, 3 components: kangaroo position, kangaroo nutrition early discharge, in kangaroo position with a follow-up. Target population, all preterm and low birth weight infant, all of them, 2-step, inpatient and outpatient kangaroo. There is resistance. We could say that kangaroo is the oldest innovation in health, in neonatology that we know. I mean, perhaps why? So perhaps we must think a little bit and think how to recognize the kangaroo families as experts in caring for their premature lobus weight infants once trained. I believe that here you have the biggest resistance to do kangaroo mother care at birth and in the neonatal intensive care unit than in the kangaroo world. We must accept their autonomy. Yes, we must empower the family. What means that? Feeling ready, that's emotional, but being ready, it's operational. And we have to work on these two aspects. Parents, considered before as spectators, are now the main providers of the care of their fragile infant. Health professionals, as us, are responsible to teach and support them during the hospital stay. Parents are not visitors. Yes, everywhere, anywhere. And we must include the father in the kangaroo mother care. So the studies, I will tackle that too, sorry. So the study indicate that a impoverished environment raise the likelihood of cognitive deficit. So post-birth interventions have to aim for an environment fostering sensory stimulation for premature infant and their brain. Not working. No. I'm sorry. I think I make a mistake. I will let that so I can do it with mine. Okay, so kangaroo mother care is the perfect sensory stimuli. Permanent stimulation of the neurosensory system of this premature. So you are going to do vestibular stimulation, tactile stimulation, olfactory stimulation, auditory stimulation, visual stimulation, and proprioceptive stimulation. Yes, with the contention in the kangaroo position in the elastic band. So I really am sure that kangaroo is the perfect sensory stimuli that we must use to stimulate this brain. And you must remember that this brain is with us in a very delicate period. I will say that now it's from 2025 to 41, when you have the growth of the axon and the connection of the synapse. So there we are responsible of this baby. So here you know this photo, two twins, 26 weeks, intubated in intensive care unit. And it's an old photo. How to do that, to try to be close to that if we cannot do it in the same way. That's the problem. Yes, knowing that the sequels, that very premature infant, but we must know that even a healthy infant will have problem with prematurity. Yes, neurological deficit, neurodevelopmental lesion, emotional problems, risk factor for psychiatric illness, and to know that 40 to 60% of the children with lobus weight will require specialized educational support during their school year. So we must be conscious that prematurity, even in the absence of complication during the transition to extraterritorial life, implies an alteration of brain organization and maturation. So look at this paper. I invite you to read it, 2023, defining the neurological consequence of preterm birth. Yes, and I think everybody knows Joseph Volpe. So we must understand that with the preterm birth, we have an injury. Then, because the baby is premature, is with us, is in the intensive care unit or neonatal unit, you will have a development of the brain on the injury. So you have the injury, then the development of the brain on this injury. So you have in one way 2 times. Yes, and you have things that you can see with the resonance, like hemorrhage, white matter injury, but you have things that you cannot see with resonance. And you will have altered development during the development, especially we can look at the volumes. So we will have things that we can look with resonance, decrease in volumes, in hippocampus, amygdala, cerebellum, in the deep nuclear gray matter, but you have things that you will not see. And you have factors that are going to impact here: immaturity, inflammation, pain, medication, environment. That's a beautiful paper to understand the injury of the developing premature brain. So I will show you some new neuroimage exploratory result that we did after reading these papers. So cortical gray matter volume, I already presented that to you, but just to explain you how at the model, we are controlling now by fragility rash and by gender. Yes, this one is gender, birth sex, so is gender, because I have more boys in the kangaroo group and who survive, because it's a survivor cohort. And the fragility rash here, the first one, you have 22 variables inside to control of the perinatal period. So you can see here the duration of the kangaroo position. This one, dur PC, is the duration of the kangaroo position. So here is the gray. You can see that less fragile, more volumes. You can see that more kangaroo position, more volumes. The kangaroo position is in days. So here I looked at the subcortical gray matter at 20 years, in infant, in adult of 20 years, but they were hospitalized during the neonatal period because of prematurity or lupus red infant. Then we look, it's new on brain, we look at the brain amygdala, because the brain amygdala play a very important role in social development and neural control of emotion, especially fear and emotion. So these structures are very vulnerable to injury in a premature birth. So what we looked here, we controlled by fragility and gender, and we saw, well, we saw that more day in IQ, less volume. And despite being in the NICU, more kangaroo position in days, more volumes. Less internalization, more volumes. Internalization and externalization, it's a measure that we are doing with a test whose name is ABCL, and that the parents' perception to look at the emotion, how the young is managing the emotion. Yes, and you can see you have less internalization when you have more volumes. And we look with externalization too. It is not. Sorry. Well, let me do it here. Yes. So here you have externalization, and it's exactly the same results. Less days in NICU, more volumes. And you have an interaction between the days in IQ and the days in kangaroo position. When you put the two, you have more volumes. And we have less externalization, more volumes. Yes, that was the amygdala. And we look at the hippocampus volume and memory, because the hippocampus is very sensitive to hypoxia. Smaller volume in preterm infant compared to term infants, because we are used to find that. Yes, but the right hippocampus is very involved in visuospatial memory processes, assessed with the VME test that we did at 20 years, while the left hippocampus, the dominant, is involved in verbal memory process assessed with the CVLT test, El California Verbal Learning Test. So we did the same with intensive care unit, interaction with kangaroo, days in kangaroo, and we look at the intrusion. We control by fragility and gender. We look at the intrusion, less intrusion, better memory and more volume of the hippocampus. So you can see here the same results. It was very interesting. We have to continue to do this analysis. And we look to visual memory with a VME, higher point in VME, it's better. So you can see that we have exactly the same result with the interaction between days of NICU and a time and days in a kangaroo position. I look to, just by curiosity, between days of mechanical ventilation and the posterior cuerpo callosum volume, and I found a high correlation. I was a little bit surprised. And that's the last one. I looked to the fiber length of the corpus callosum. The corpus callosum is the fiber that you have between the two hemispheres. Yes. So I look at this fiber, the length, and the test of motricity, fine motor skill, in infants hospitalized during the neonatal period. And I found it was very interesting that if the length, that the fiber has a better length, you will have a shorter test. The 9-hole peg test, when it's shorter, it's better. Yes, and I control anyway with fragility and gender, and you can see how is moving the duration of the kangaroo position. So here, what I want to show you is another thing. I took 4 of these babies with a very long 9-hole peg test, more than 25 seconds, very bad, and who did not have a good length of the fiber, because I wanted to see if it's a reality. And look at that. Look at this fiber, at the number of the fiber. Look at the aspect of these cuerpo callosum. The last one is, you don't see, but on the side, we don't have any fiber. So I say, so perhaps it's true that there is a signification there. So I took the best one with a longer fiber and very good average of the test of the 9-hole peg test to look if the cuerpo callosum was different. And you can see here that yes, it is different. So what I want to transmit to you is just that what we are doing when we have the baby, the premature baby in our neonatal unit, have consequence at 20 years. We cannot see what happened, but here in this study, we can look and we can find things like this. So I will repeat that kangaroo position is a neuroprotective drug. We must think in a brain surfactant, has a pulmonary surfactant, has a colostrum with a long-term impact on the brain development, dose dependent on volume of gray matter, and early initiation and duration of kangaroo is very important. So we must avoid, if it's possible, any separation. And of course, at the beginning, we are feeling insecurity, fear of extubating in intensive care unit. So the importance of the protocol to be involved and to be convinced of the short and long-term benefits of kangaroo. to collaborate with parents, and to recognize the role of parental association. So thank you very much. Attention, fragile brain in development. Let's protect them. Thank you very much. I don't know if you have questions.
Thank you, ma'am, for a wonderful presentation. If there are any questions from the audience, so no questions. So I have a question for you, Dr. Natali. The graphs, etc., you done in our software, like analysis. What analysis was done through which the graphs were beautiful, the ones which you used to explain.
I'm sorry, I didn't listen clearly what you asked.
Your
Analysis is based using what software?
I cannot listen you.
Uh, can you tell us what software you used for analysis?
Oh, the software. You mean the aspect we use? The name is Bravis. It's a tool who was developed to integrate the clinical data and the neuroimage and the DTI and the functional result. A very interesting tool who was developed for this study. A beautiful tool.
Thank you very much, ma'am. Thank you very much, and we are very thankful to you for presenting live from Colombia. We will proceed with the next session. You can be logged in.
Okay.
You have a question?
No question.
Yeah. We wish you a very happy birthday. And
Is that
is that
correct?
correct?
Thank you very much.
Special
Special
thanks.
thanks.
Thank you
Thank you
from
for
everyone. Thanks a lot.
Thank you very much.
Yeah, special
Okay,
thanks.
bye-bye.
I'm gonna leave to you. I'll leave to you.
That was a wonderful session. Next, we have session on debate on a few gray areas of KMC. For referring this session, I would like to invite Dr. Sushma Nangia, Director, Professor and Head of Neonatology, LH Medical College, New Delhi. Dr. Ruchi Nanavati, Professor of Neonatology, KEM Mumbai. Okay. Dr. Kumutha, Dr. Ruchi Nanavati, okay. Then we'd like to invite Dr. Kumutha, Dr. Sheila Iyer, Dr. Maria Estelita. Please come on the dais. Chair.
Morning, everyone. We are here for the much awaited session on few gray areas on KMC. and we are going to have debates, and I can see we have 7 topics. So the first debate is on KMC need not be restricted to only small babies. And for the topic, we have Dr. Ramesh Chaudhary to start the inning. And against this, we have Dr. Suman Rao. So I request Dr. Ramesh Chaudhary to start his session. And I request each one of you to restrict to the time allotted to you, because otherwise we have, a very cramped program and also very, very important topics. So let's give time to everyone. Thank you very much. I think there are 6 minutes for each speaker, so that makes 12 minutes. 4 minutes. It made to 4 minutes now. So 4 minutes for each speaker. So 1 or 2 to 2 minutes for the referees to give the feedback. So 4 to 5 minutes. So madam is kind enough to give you 1 more minute. So 5 minutes and 2 to 3 minutes for the referees. So let's start with Dr. Ramesh Chaudhary.
Hello, good morning one and all. Our topic is KMC need not to be restricted to sick and small. It means that it can be extended to all the babies. Don't you think that problems are faced by the term babies as well? They have several problems like birth asphyxia, infection, secondary apneas, feed intolerance, the prolonged hospitalization because of all these things. And what makes us human? It is our brain that is going to make us as human. And we know that genes are supplied by the parents. But the environment what we create as parents, that is the architect of our brain. And even for the term babies, brain is not developed fully. So everyone, before speaking to me, they were pressing for intact survival. That is survival as a human, not as we just discharge the baby from the NICU. So building the brain is just not like building a home. We need so many delicate efforts. And what a newborn wants at birth, right at birth, he needs a thermal care. He needs a care in a stabilized, unstressful environment. He needs a good nutrition, that is the mother's milk. Then he needs to be prevented from the infections. Then on the top of that, mothers as well needs to be protected from all the disorders like stress, anxiety, and that too, our objective is to decrease the healthcare cost. And we must stick to do not harm policy. And just answer me, which domain is not covered by the most human way of the science, that is the kangaroo mother care. So why not to extend this benefit to term babies as well? Because they are equally fragile, they are vulnerable for the infections, and I think we are in the KMC for last so many years, and intense KMC for last 72 hours. Who don't know the benefits of the KMC? I think everyone must be aware, well aware, from the brain to the infection to the nutrition, every aspect is covered. And tell me one benefit that is transmittable exclusively to the preterm only. Which benefit is not needed by the term baby and which is exclusively transmittable to the preterm, selectively transmittable. Every benefit will be transmitted to the term babies as well. So when we separate a baby right at birth, if we don't provide the skin-to-skin cover, it creates stress for all the babies. There are chances of hospital-acquired infection. It is possible that they may be nutritionally deprived. There may be behavioral issues for the babies, mothers, families, father, dysbiosis, immune dysregulation, and healthcare equipment-related hazards like burns and et al. So we have enough evidence now. Early skin-to-skin contact for mothers and their healthy newborn infants for the term. This study is from the term. And evidence support that use of skin-to-skin is promoting breastfeeding. Again, a study, RCT, published in Journal of Child Psychology. Effects of daily full-term skin-to-skin contact, behavior and cognition at age 3. Secondary outcomes, finding indicates that daily early skin-to-skin contact in full terms may foster child's behavioral development. Again a trial, it also says that reduced infant total crying duration and the crying bout length. And it is saying clearly that more the skin-to-skin minutes with associated less infant crying and longer total sleep duration. These
You have 1 minute
all
more.
studies. No, it's 4 minutes.
1 minute more.
Yes, my clock is running. So benefits of KMC is for the parents as well.
You are supposed to debate only with Suman, not with the referee.
No.
So it helps mother to stay away from the depression, postpartum depression, anxiety, maternal distress, and all the things. So friends, I request you all, let's KMC as soon as possible and as long as possible, and let baby and mother decide when to stop it. 5 minutes. Thank you.
I request Dr. Suman to start her talk. Debate.
Good morning, everyone. And Dr. Ramesh Chowdhury was at the forefront of the walk today. And his nara was KMC for every baby, everywhere. And that is what Dr. Ramesh is saying. Yes, we are all KMC champions. That's why we are here. We are all actually KMC fanatics. And we need to be fanatics to take this forward. Can I have my slide set, please? And therefore, we would like to believe that KMC is the answer for every problem in the world. But unfortunately, that's not true. So, though we say that, can you please get it for me? So though we would like to say that KMC is for every baby everywhere, it makes a great slogan. I'm sure people would be impressed. But unfortunately, the time is not right. We are not there yet. And why do I want to say it? This is not only for debate. I really want to make a statement here that we need to understand what is kangaroo mother care. Kangaroo mother care, in its toto, is continuous, prolonged skin-to-skin, exclusive breastfeeding, and there's another component which many of us have conveniently left off, early discharge and adequate follow-up. So I would like to highlight the word that KMC is continuous and prolonged skin-to-skin contact. And that is what is the recommendation. And now it has come out very clear that it has to be a minimum of 8 to 24 hours in a day. It's not just any skin-to-skin contact. And therefore, when something is so intensive, we need to be focused. We need to look at our babies who are at risk. If you start looking at all of them, you're going to get distracted. And here we are talking about 5 times, if you say for every baby everywhere. You're talking about all the babies, and we are not focused. We know that our problem is in our small babies. We are talking about a high impact of mortality reduction. We're not talking about increased sleep. We know all of us manage with less sleep, right? I'm sure we have hardly slept for 6 hours last night. So I would like to say, let's be focused. KMC is needed by the small babies, and gone are the days where you used to say KMC is no cost, no effort. We all know the effort we put in to make KMC a success. And now that we are saying KMC is for intensive care, more of a challenge. It's about time, it's about space, it's about cost, it's about intensive counseling, and our emotions are also, we know the cost of our emotions when we counsel. And therefore, do you want to extend it to this nice chubby baby? Do you think this baby will remain in skin to skin for 24 hours a day? Do you think the mother can ambulate with a 3.5 kg baby otherwise? So feasibility is a big question. And let me bring you back to this discussion we have been having since yesterday. KMC is not skin-to-skin contact. And if you are going to say that, you're going to dilute it. Skin-to-skin contact, my friend, you showed us that baby sleeps. We need to give it to every baby. Agreed. Let's make that happen. Even 60 to 90 minutes is a problem. Yesterday we saw at the award function, we are barely managing 20 minutes after birth. Let's focus on that. If you're now going to say KMC, it's a challenge, there is no evidence beyond the first few days. And tolerance is a question. We know that when do we stop KMC? When the baby becomes term, generally. Babies wriggle out. So do you think that baby is going to stay there for so long throughout the newborn period? And then the big question is, why should we do it? Do we have any evidence for every baby everywhere? Evidence
Suman, you
is
have
only,
1 minute.
evidence is only for skin-to-skin contact at birth. No evidence for KMC. Whereas for KMC, you have a high, big impact, and that is mortality reduction, which has been climbing 40%. Now with immediate KMC, it's 50%. So let's not add to confusion. Let's keep KMC for focused for the babies who deserve it. At most, we'll say for all small, vulnerable infant. And let's not dilute the power of this intervention, because when you spread anything thin, it's going to be of poor quality. And therefore, I would also like to highlight our current indicator, which we showed yesterday, where our target is 90%, is proportion of all low birth weight babies. Suppose you make this for all babies, and you achieve 90%, but if your 10% who fall out are the small ones, where are you left? So, this is the reality. What my friend wants to do is equality, but that's not enough. What we need is equity. And therefore, I think we need to keep focused for the small baby. But I have a disclaimer here. We used to say KMC for less than 2,000 grams. Now we had this large study which showed that even for those babies, it makes a big impact in 30% reduction in mortality. I would ask my friend to lead a big trial which shows 30% reduction in mortality for every baby everywhere, and then I'm converted. Till then, KMC for the small babies, don't dilute it. Thank you very much.
Thank you, Suman. I'm supposed to be the judge and giving the judgment. See, there are few points I would second with Suman. See, who are the babies who really benefit KMC? And have we given that 100% advantage to those children? And are we ready to take up a few more children who might be on the cusp of benefiting? But if you say KMC for all children, actually it was cleverly worded by Madam, need not be restricted. See, she's not saying that it has to be given to all babies. So we have to take it in that sense. I think first our priority is to give it to children who are vulnerable, who are eligible, and let us have coverage above 90%. And not only that, the quality of KMC provided also should be taken care of, and the element of follow-up, that is one thing which is very much lacking in our country especially, and I think we should focus on it. Either are we going to give home-based newborn care or community care or home-based young child care, we have to take it. And I think at least, especially our country is ready, not ready for all babies. Let us put at least SSC for all babies, at least for 60 to 90 minutes, and maybe KMC might be a tall order. Let us provide it for vulnerable and eligible children as of now. Thank you. We'll move on to the next topic. Thank you. So the next topic is it possible to provide early skin-to-skin contact and early initiation of breastfeeding in cesarean delivered babies? So to talk about it, for Dr. Parul Kotwala from India. Obviously, he is the one who has to give us the answer.
Hello. So I thought this is a question to me, in fact. Well, a very good morning to you all. The title itself precludes any debate, I believe, because everyone would say it is possible to provide. So let us look at some of the issues involved. Kangaroo mother care has evolved a lot. Initially, it was for preterm baby. Subsequently, it was proposed for all vaginal birth deliveries. And now we are pushing for all cesarean babies as well, where mother is well. So things have evolved, and we have found that it is beneficial. And that is why we are extending its use. So we know that immediate or early skin-to-skin contact after cesarean has many benefits. It may increase breastfeeding initiation, decrease the time to first breastfeed, reduce formula supplementation, increase bonding, and maintain temperature of the newborn. And some very recent studies have, of course, confirmed this. This was published last year only. And you can see early initiation from 27.7% to more than 90 minutes of skin-to-skin, it increases to 74%. All parameters, time to exhibit feeding cues, that also increases from 34 minutes to 19 minutes. It reduces. The baby gives cues much earlier. Time to initiate breastfeeding also is reduced significantly. Then exclusive breastfeeding proportion increases, and mixed feeling about hospital discharge, mixed feeding is also reduced significantly. So skin-to-skin has all the benefits, and the most positive is this, that 74% had early breastfeeding. This is a dated data, but in USA, they have increased from 43% to 59% in cesarean section. In 2013, unfortunately, we do not have current data, but I believe it is hovering around 80%, and that is perhaps enough. We can't extend it to 100%. So issues are that this is again data that it reduces initiation. Cesarean itself, it is a surgical procedure, and it has some negative impact also because of the pain, the medications, anesthesia, and logistics, because you need special person in the operation room. We need isolation of the lower part where the surgery is being performed. Those are things, but we can address to them. They are more of logistics. And newer techniques of cesarean have reduced pain. The recovery is very fast, and that is why it has become very easy. The most cesareans are performed under regional anesthesia. So patients are awake and conscious. And I'm just sharing with you, even in very rural area, cesareans which we performed in a workshop, patients are ambulating after 4 hours. So pain is not an issue. 24 hours after cesarean, you can see the lady is smiling with her baby. So cesarean is a special situation versus vaginal birth. So whether to do or not is not a question. It is possible. What we need to debate is how best we can do it. And we should debate only that part, that how we should change and alter. We can make use of the father, or a transverse position of the baby rather than vertical, because then otherwise it comes very close to the surgical field. So many institutes in India have also shown that this is doable. This is in rural area in Telangana. The Gujarat experience also published in Lancet. So we need to confirm this, that it is doable, but we need to find solutions of the issue. We need to sit down and find practical solutions regarding our situations, because we have diverse locations of delivery, single person maternity care, public hospitals, private large institutions. Protocols and guidelines which are feasible and affordable can be designed, and video sessions to train the staff and the patients also may be most useful. So it is possible to provide early skin-to-skin contact.
1 minute more.
and early initiation of breastfeeding in cesarean babies. Only thing is how to do it we can debate upon. Thank you.
To talk against is Dr. Munjal Pandya.
Thank you so much, respected Vani Madam and all the organizers for this opportunity. Actually, for me, this is something, I call it a huge task to call day a night, but let's try my best. When it comes to this particular debate, I would say that I may not be Arjun, but he is my Dronacharya. So I think I'm really sorry for taking this 4.5 minutes to disagree with you, sir, with regards to this particular topic. I have been his student and I am still his student. So I'll try my best to prove that I am his student. So when it comes to this particular debate, I would say that this information provided in next few slides are purely to consolidate my notion that I am given. I have not chosen that. And all the information provided in this particular thing is in good faith. And we would obviously go for something that is based on scientific evidence. And this few slides are just to prove the point. When it comes to skin-to-skin contact, we know that it is an immediate skin-to-skin contact until the end of first breastfeeding. Now that is what we call as skin-to-skin contact or early skin-to-skin contact, if we go with the definition. As sir said, there are a few challenges. He has mentioned few of the points. We have that screen between the head end and the abdominal part most of the times. When it comes to showing the baby, it is able to, for us to show the baby or gender of the baby and then whatever happens afterwards. But then who will hold the baby close to the chest of mother? When it comes to public hospital, we are not going to rely on the paramedical staff that we are having. Most of the times, they do not listen to us most of the times. And when it comes to private hospitals, we need to have some extra person doing this job of holding this baby close to the mother's chest. So we know breast crawling is possible. We know everything is possible. But then who would be able to make it sure that it is secure enough to make it possible? Pain component. We said during cesarean section, the patient would be under spinal anesthesia most of the times, but then pain would be there. Stretching pain would be there. When it comes to general anesthesia, she is not awake enough to have that particular skin-to-skin contact with regards to the baby having, mother's chest. This again is a possibility. Not all the operation theater tables would be, comfortable enough to have the security of baby when we are putting the baby on the, mother's chest. So again, this is a possible threat we are dealing with regards to skin-to-skin contact. When it comes to general anesthesia, there are many points. Patient becomes conscious after extubation. She may take like 20-30 minutes to come out of it, fully come out of it. Again, it will be some more time to regain all the motor tone when it comes to holding the baby. So obviously when we are talking about skin-to-skin contact, we are obviously talking about the affection between mother and, or the bond between mother and baby. So when it comes to not gaining full motor contact and still having that baby on mother's chest is a huge risk. When it comes to pain, we know that spinal anesthesia will have 6 hours of window. After 6 hours, she will start to have that particular pain component. But when it comes to general anesthesia, she would immediately start feeling the pain. Whatever analgesics you would be able to provide her with, still she will be able to feel the pain because it is under general anesthesia. And one more point with regards to general anesthetic agent is when it comes to breastfeeding, the agents are being transmitted through breast milk. So for next 24 hours, the baby needs to be monitored properly. So these are the points we need to keep in mind before jumping onto early skin-to-skin or early breastfeeding. The second component, that is early initiation of breastfeeding. This is the paper published in 2022. It says that within first hour of delivery by cesarean section, that is, you term as early initiation of breastfeeding. This is the picture, obviously, as we said. On operation table, I do not think it is possible to have this particular thing. And when it comes to shifting the patient from operation table to ward, it would take at least 30 to 45 minutes. So definitely within first hour, cesarean section baby, I'm not really sure whether it is possible for us to have that particular secure outcome. The same paper had this particular image. The success rate of EIBF was just around 40 to 45%. And the major contributor of that particular zone was cesarean section delivery. So obviously we are dealing with something where we need to secure that particular segment. These are the factors, and many of the factors would coincide with cesarean section delivery. One of them would be like uncomfortable position. The other thing would be anesthesia. Next thing would be exertion. We are not talking about always elective cesarean section. There would be emergency cesarean section as well, where patient would have been exhausted and then we are subjecting her to cesarean section. So these are the factors. And public and private, I already told that number of doctors would be an issue in private nursing home. That would be just one obstetrician taking care of all the things. While doing cesarean section, he or she may not be able to focus on that particular skin-to-skin contact. And if we go back from cesarean section, the antenatal counseling, are we actually doing it on routine basis? How many of us would be doing it as an obstetrician? This is in Gujarati, parane preet na thai. We can force upon something, majorly low, but anything. If we are talking about that, we know that healthy food is good. But when it comes to market capitalization of fast food restaurant, we are not seeing any of the healthy food restaurant on global aspect or sphere. So there is huge gap between what needs to be done and what is done, and there lies the gray zone of comfort. And obviously, we are able to delineate about what is possible and what is actually doable. And that is why I would say it is not possible for all the cesarean section babies. Thank you. Thank you.
Thank you, Dr. Munjal, on putting the mothers and the obstetricians' perspective in early skin-to-skin contact not possible. Probably, I think the audience over here, or many of us who've been, or when it got initiated, because as pediatricians, the brunt of problem of feeding is maximum in C-section. And we have to do everything feasible that an LSCS delivered baby goes successfully home on exclusive breastfeeding. So probably, definitely the verdict is going to be, as Dr. Parul put it, yes, maybe we will not be able to achieve the 100% that we would be able to achieve in a normal vaginal delivery. But in a C-section, how do we do it and how do we escalate? Probably it's one of the things which we really have to do it. And we have been doing it in public hospital with daily 15 C-sections taking place. Yes, all those problems you showed are there. And we have also had debate with our colleagues over there, your counterparts. But what we managed is one nursing staff from SNCU, our NICU, accompanies the resident for all C-section call. And the baby who is absolutely well, does not require anything, then the sister assess. As you said, the screen helps us. And exactly the skin-to-skin contact doesn't become the vertical way as we would do it in normal vaginal delivery. It's more horizontal. And definitely the baby is so alert and active that the baby is put on breast directly at that point. Yes, some of those concepts which we have had for skin-to-skin contact, mother, and most of the mothers who are on spinal or epidural, they are able to see the baby's face immediately and make it. Exception is those maternal cases where you have a lot of emergencies. Otherwise, I think verdict would be, it is possible, feasible, and it should be our teamwork that we get it as high as possible. Maybe it may not be 100%, but I think there is no excuse to not to try for it. Yes.
In Lakshya program, see, they have advised birth companion. See, please, we request the obstetrician to allow birth companions even in the operation theatre. Only if you allow that, that's going to happen. Many of the private hospitals in India have started doing that, and I was the birth companion for my daughter-in-law's surgery in cesarean section. And I was able to do this with the help of the neonatologist. So please let us start doing it now. The obstetricians change their mind. Even in way back when I was in Australia 30 years back, at that time the partner or somebody was allowed inside a theatre, operation theatre. I know they could vouch all our Western counterpart. I think we are ready for that. We should do it. Yes, sir.
I think we have to initiate it and start it in some of the public hospitals also. It's not in all public hospitals the birth companion concept is accepted. In fact, I would say in most of the public hospitals, including medical colleges, the birth companion practice is not done, and I think it's a high time now that we start doing it.
We have
Sorry? So someone else could be. Someone else could be. Someone else could be. Yeah. Yeah. And yeah. 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 Yeah, yeah. Actually, yeah, as what you said, there are a lot of logistic issues in practicing this, and most of the times in the public hospital, you don't have the area which is cordoned off for the delivery for a single mother. So if as you know, in our hospital, when the mother is delivering, there are 5-6 other mothers who are delivering, and there is no separation. The stables are next to each other. So for a relative or any other birth companion to allow them becomes logistically difficult and may not be suitable.
I just have a simple request. We're all listening to the debate. Can you ask us to put up our hands who won before you do it?
Yeah.
Thank you.
Let's have an audience poll.
I have a comment. I think for the doula, I think there's a Cochrane systematic review which says that this is one intervention which has the maximum positive effects if you compare to any other interventions. I think that should have been discussed. Yeah.
Yeah. So now the court orders to, those who are for it, raise your hands. Yeah. And those who are against the concept, raise the hand. So we have only 2 hands for the against. So the final
You're saying against Srinivas.
Our insistence is for early breastfeeding also.
So we'll have to stop. Yeah.
I think we would, I think otherwise we will not be able to go to our next stop. Yeah. Yes, ma'am. So I think some other point we will debate it and we'll go over to the next point.
KMC transport of newborns is not suitable for very small and sick babies. For you have changed, is it? I thought, okay, I thought Mangala Bharati was talking against. No, for us, then Mangala Bharati, can we ask Svetal to speak first?
Yeah, very well, ma'am.
Okay, she's for. We'll
Slide, please.
This is number 3.
Number 3, so which I will do, yeah.
Transport.
Yeah, your time starts now.
Thank you so much. Good morning, one and all. First, I am speaking for KMC Transport for the for the small and sick newborn. So all of us know what is the best transport. The best transport is in utero transport. So what is in utero transport? The baby is with the mother? Yes? So in utero transport, if in utero transport is the best transport, what another transport can be the best transport? When the baby is very close to mother. The babies are transported when they are sick. See the incubators, the mother is taking in the lap. Mother is there, but the baby is not so close to the mother. So what does the data says in neonatal transport? 220 transfers into the tertiary unit of Delhi, 77% private vehicles, ambulance, rickshaw, and what was the morbidities? Hypothermia, hypoxia, hypoglycemia. They also required a ventilation, and some of the neonates, we see they come brought dead. During the transport only, they could not make the breath. So let us see how the KMC is acceptable. Kangaroo mother care is a recommendation from WHO. Since yesterday we have the same thing that 2016 review says kangaroo mother care is recommended by WHO, and 40% relative reduction in the mortality at discharge is seen. These Cochrane review highlighted insufficient evidence to recommend early onset continuous KMC before stabilization. And so what could be the benefit? What are the evidences? The evidence says KMC transport is analog to the in utero transport, and we say in utero transport is the best transport. So 31 KMC transfers of this was done on the stable, term and preterm newborn, and this is that there is a stabilization of the vitals. So if the KMC transport helps in stabilization of the vitals, why can't we extend to the sick newborns? So there is an RCT for Philippines, and we have a member from Philippines over here. They have done the study, and they have proved that KMC transport is better than the incubator transport. There was reduction in the hypothermia, hypoglycemia, tachypnea, tachycardia, hyperglycemia when the babies were transported in the KMC position. There are also multicentric RCTs for immediate KMC. Yesterday, the day we have discussed, what is immediate KMC? We want zero separation. So why can't we give KMC transport? It is one of the chain of zero separation. As soon as the baby is delivered, we are talking about skin-to-skin contact. We are talking for the cesarean sections, right? And if you want to continue the zero transport, yesterday there was a beautiful picture from the Philippines, the transport from labor room to NICU, the baby is transported in the KMC position, right? So we can definitely think of scaling up our KMC transport to the sick and small newborns. As I said, zero separation. At birth, skin-to-skin contact, immediate KMC. If you want to shift to the NICU, now we are talking, don't shift to NICU. Have mother and baby together. Have an MNICU. Transport in whenever there is a referral unit from PHC, we were also talking about the peripheral units. So from there, if the baby has to come to the tertiary care, we can offer zero separation by transporting in a KMC position. We have further talked about that we want home KMC for their better weight gain, for their better neurobehavioral outcome. We want home KMC. So we can transport in KMC. Same the immediate KMC studies. And we all know the benefits of the KMC transport. So these are the few studies which I have highlighted. There was one good study from Sweden. The mothers said the parental experience they have done. See, this was a very good, which I like to replicate in my setup. Mothers with the incubator transport group were concerned before and during the transport and found it stressful to be separated from their infant. And last 20 seconds, whenever there is something happens in the family, the mother holds her baby and run out if there is any accident. Have you seen the mother never leaves the baby. Even if the baby is sick, mother will sleep together the baby. She will not put the baby in the cradle and roam around. So that is the human instinct for zero separation. Thank you.
Yeah, I now request Dr. Mangala Bharti to put forward his points. But the topic given is KMC transport of newborns is not suitable for small and sick babies. And I think Shwetal has told us that it is possible. The topic for you was not suitable. So now let's see what Mangala Bharti. You switched, but the heading says KMC transport is not suitable. And you have said KMC transport is suitable. So now let's see what Mangala Bharti has said.
Such a beautiful more slides, please. I thought there is some hypothermia here as well. He's trying to correct that. Yeah. So, okay. So I think my time starts now. So I was just crossing any number of times. I was enjoying crossing this beautiful Atal Bridge. But what Sashivani Madam has asked me to do is cross the Sabarmati River like this. So they're pretty sure that actually there was a confusion earlier, and the judges have also understood that. My opponent kept on calling me and messaging me, please understand you are talking against KMC. You are not going to talk for KMC. I understood. And to make the situation more worse, I think there was some, I think people wanted audience also to vote. And thanks to Dr. Suman for actually using the right phrase. I understand the whole jury or all KMC fanatics. I'm talking to KMC fanatics. More worse, I didn't, if you're looking at the judges, I don't know what word to use above fanatics when you talk about KMC. But having said that, so this is my situation now, right? We are in a country of Mahatma. So even it is Kasab, we have to try him. So there has to be a lawyer. So all that I'm repeatedly saying here, and please patiently hear the lawyer's version, what he has to say about Kasab before making your decision. Okay, so jokes apart, see, no doubt KMC is a wonderful intervention. We started about low birth weight babies. There was a very clear definition. It is meant for LBW babies, and I'm not sure whether we use the terms even ELBW anywhere when we talked about KMC. For stable low birth weight babies, it's a wonderful intervention. I think the people involved in IKMC are all, many of them are sitting here. Such a wonderful study with small babies, 1 to 1.8 kg. Some of them might have been stable, many of them are unstable. That was not a criteria for this study. And a very significant number, 25% relative risk in reduction in mortality. So, I think we are also aware of another study, EKMC, which is going on in Gambia. Again, so people are trying to look at KMC even before, little bit even advanced than KMC as far as the criteria is concerned. So KMC for a pre-stabilized preterm, even before stabilization, what is the role of KMC there? So that brings us to this specific topic. So what about when we talk about transport of sick and small babies, very small. The word used is there, not just small, very small babies. That is the context, and I would like to discuss mainly in the Indian context. So a lot of information came from the IKMC study. But again, a surprise, even, see, this is a wordings taken directly from the IKMC study. So we look at it, so even though they tried their best, 20% of the babies, around 1/5 of those babies actually, they were not able to recruit because those babies were very sick and the team felt they were not candidates for KMC. But I looked for what was the criteria used to say who is very sick and who is moderate sick and all. That is not clear, but 20%, 1/5 of the babies people felt they are not good candidates for starting in early KMC. And this is the EKMC protocol going on. If you look at it, they are all again, even though they're saying they're trying it in a pre-stable babies, when you're talking about babies with a higher respiratory rate, significant FO2 requirement, little bit difficult in maintaining saturations and all, they are categorizing them as babies with severe form of instability, and they're excluding from the study. So all that I'm trying to say, even though we say we have some studies to be done in LBW, little unstable, we are talking only about mild to moderate form of instability. Nowhere the severely unstable or more sick babies have been included in any of the trials that have been conducted so far. So, and we know a lot about, okay, the concepts are very good, okay, it provides stabilization. I'm not getting into that. But when it comes to implementation, really, I won't go into that. All that I wanted to say really was that, see, MNCU, we are actually, as an institution, very much, we're all convinced and we want to work towards MNCU, but we know the difficulties. When it comes to transport, it's a very time-constrained setting, very short time available. Lot of issues are different from even from an IKMC setting. Look at how much space you have available to accommodate both the mother and the baby there, and then within that small space, if you are transported by an ambulance. Look at the kind of equipment which is available. Do we have a backup? In IKMC, there is always, I assume there is a backup. If something fails in KMC, they can fall back to the routine kind of equipment. What do you do in case of transport? How much stuff you can accommodate? How trained are the staff in the Indian scenario to handle that, to assess whether this baby can be continued on KMC or it's time that we should stop and go back? and again, how good are our systems right now in terms of neonatal transport. I'll just finish 20 seconds more. People have looked into, so they have just realized well, and they have understood that, say, this study, it highlighted the amount of resources and effort that is needed even to bring in IKMC. It said easily you can do, but if you want to bring in IKMC, a lot of resources and time has to be invested to make it happen. It's not an easy joke. And again, another study which has looked into berries, these are my final slides. All that I'm trying to say is that the more, in neonatology, we are more and more moving towards non-invasive modes. We know it's very good for the baby, but we also realize the moment we bring in non-invasiveness, it's more HR resource intensive. We need more people to make decisions, more trained people to make decisions. It's not such an easy job. So if you're failing to make a plan to implement who are those so-called sick babies who are going to get IMC, I'm very sure that we are going to fail there. It might where. So let us focus on improving our existing manpower, resources, everything in all these transport scenarios, and then think about or bring in doing KMC to those small and sick babies doing transport. Let's take one step at a time. Let's get IKMC done in the facility first, and then see whether we will be able to extend it to the transport setting. Thanks for the opportunity. I will stop here.
Thank you, Dr. Mangala Bharti. As suggested, we would like to know from the Janta that who is for KMC transport of newborn is not suitable for small and sick babies. Please raise your hands. Not suitable. Yeah, I think it's, the topic, even the, both the candidates were not clear about, what topic, there was overlapping. And we want to know that what is the opinion regarding against that KMC transport is not suitable for very small and sick babies. So we have a lot of people who have not opined at all, This is, many have not opined on.
So there seems to be still grey, madam. We have not resolved it. Not resolved it.
It still remains a grey area, and as said by Dr. Mangala Bharti, that, many times we have to look at how much staff is available. We have to take the decision on case base that what is staff is available, how sick is the baby, how unstable is the baby, and how far you have to go for neonatal transport. And depending on that, one can take decision whether you are going to transport in KMC position or you are going to transport in a conventional manner. So I think I'll ask Dr. Shashivani to give the last word on this.
We are talking about those babies who are in the facilities. Now, I have another angle to it. Many times our babies are referred from the periphery. And periphery, when there is no other alternatives, this should be allowed. That is the contention here. Because we don't have this possibility, we have not studied the thing, but we have personal experience that lot of babies have to be referred from the periphery to the hospitals, and they are very sick, very small, they should be allowed. That is the only contention.
Madam, we agree with you. Instead of coming in an auto rickshaw or some car just wrapped in a cloth, they can come be transported in KMC. Yes, she wants to have the last word.
Who are against no KMC transport. So it can be catchy. I'm sure if you revise the question, who are not for KMC transport, you will see more hands. When you put that double statement, everybody just did not say anything. So maybe you would like to ask it again. And I guess the other term is suitable. Suitable versus feasible are two different things. So that is where decisions can change. So the statement I propose be revised a little bit and then get another vote. Maybe we will have better answers. Thank you.
Yeah, thank you everyone. Yes. We agree with that. There is no two opinions about that. So with this, we go to the next debate, and it's on planned early discharge and regular follow-up is an integral part of KMC. And to debate for and against, we have two people from the same unit saying for and against it. So we have Dr. Kirtana from KM Hospital, Mumbai, talking for planned early discharge and regular follow-up.
So good morning, everyone. I quickly want to thank Shashivani ma'am and Nanavati ma'am for giving me this opportunity. Coming to the topic, why planned early discharge and regular follow-up should be an integral part of KMC. Let's see what do the evidence say. So one of the earliest study which looked into this component, the third component of KMC, that is early discharge and regular follow-up. One was the earliest study was Chapak et al. In their study, they looked into this component and they found definitely kangaroo mother care reduced the number of days in hospital and diminished the overcrowding of the neonatal unit, which is a particular problem in developing hospitals. And if you see specifically for less than 1,200 grams birth weight and 1,200 to 1,500 grams, you can see here the kangaroo mother care group reduced the hospitalization days by 8.6 days was the mean hospital stay, versus the 14.84 days in the control group, and 7 days in the kangaroo mother care and the 10.9 days in the control group. And they also found that the early discharge under KMC did not increase the readmission rates due to metabolic and non-infectious respiratory complications. Saying that the next important evidence I want to say is the Cochrane review. With looking onto the other outcomes of the KMC, they also looked at the early discharge part, and they found intermittent KMC resulted a reduction of a duration of hospitalization about 1.6 days, and they took around considered 11 studies in it, and one of the study was Chapak et al. And the other was Catania et al. Of 1998, where they found that the 11 days was the mean hospital stay versus 13 days in conventional group. And today in the morning talk also, Chapak madam said that the kangaroo mother care, it reduced around 10 days hospitalization for kangaroo mother care versus the conventional. And this is the Cochrane review, which they looked at the outcome of the length of the hospital stay, which they considered the 11 studies, and it was favoring the kangaroo mother care group. And the next important was and they also looked at the early onset KMC and the late onset KMC, and they found statistically significant improvement in the length of hospital stay. And however, there was only one study which was, they would be able to consider to look this topic. And then the recent systemic review and the meta-analysis was the Narciso et al. At 2021, where they looked only the effectiveness of the KMC over the hospitalization period of the preterm and low birth weight. And they found definitely there was a reduction in the length of the hospital stay. And they consider around 12 studies out of the 800 plus citations, around 12 studies were eligible for that. And looking at the 12 studies, the net effect, as you can see here, was definitely favoring the kangaroo mother care group. Saying all this, the kangaroo mother care leads for early weight gain, early physiological stability, and thus meets our hospital unit policies discharge criteria. And then I would like to say that saying that few precautions definitely has to be taken when we are planning early discharge and regular follow-up, like counseling the mother, counseling the family before discharge, strengthening the understanding and the skills necessary for the newborn care, guidance when and where to seek follow-up, regular follow-up, emphasizing the importance of it, notifying the community health workers, and the most important for best outcome to come out of it, the KMC with early discharge, is the home environment. The mothers should go back to a warm and smoke-free environment, and she should have support for her everyday tasks. And where there's no follow-up services and hospital is far away, it should not be discharged. And importance is the planned early discharge helps in transition the preterm from a hospital to home environment. It helps, it continues, promotes the family-centered care and reduces the risk of hospital-acquired infections. And it engages the community in the care of the preterm infant. It's a full community engagement for creating a supportive environment, and it empowers the family. Concluding, KMC, especially early KMC in particular, supports and enables early discharge. It equips for the family-centered care. It equips the parents and the members with necessary skills for essential newborn care before they leave the hospital, discharging the patients early and ensuring consistent follow-up, provide an alternative to extended hospital stays. And it is a very important cost-effective strategy. An ICU giving continuous prolonged KMC with exclusive breastfeeding leads to the planned early discharge and regular follow-up, and thus there is reduced length of hospital stay and reduced cost of medical care. There are many evidence, few of the evidence says the significant reduction of cost of medical care in kangaroo mother care group versus the conventional group. And then, and saying all this, planned early discharge and follow-up is an integral component of KMC in optimizing the outcomes for the low birth weight infants. Thank you.
So thank you, Dr. Kirtana. Let us now listen to Dr. Anita Bahari Krishna for her views against planned early discharge and regular follow-up as an integral part of KMC.
Very good morning, everyone. First of all, let me thank the Kangaroo Mother Care Foundation, Dr. Shashivani Madam, to give me this opportunity. And though I am coming from the same institute Kirtana is working, where Kangaroo Mother Care was started, pioneered in one of the regional institutes in India by Dr. Rekha Udani Madam, supported by Dr. Ruchi Nanavati Madam, and followed up by me, I am given the Herculean task to speak against early discharge and follow-up. So I will try. Kirtana has very well supported early discharge and follow-up. So now I will try to show the evidences which say there are hindrances for the same. So planned early discharge and regular follow-up may not be an integral part of KMC. But which are the evidences? What are the experiences we'll just share? So the policy of early discharge of stable low birth weight infants depends on maternal infant adaptation for the same and consistent satisfactory weight gain for the babies, availability of family support, and also assurance of successful follow-up of the babies. This is by the WHO guidelines, but fulfillment of this policy is a great challenge, in both developed countries and also in developing countries. So what are the evidences say? This is a study that was published in 1993 in Pediatrics, which has looked in 100 babies less than 2 kilogram for early discharge and follow-up while the baby is on KMC. They found persistent episodes of apnea being a great hindrance for babies who are less than 1,500 grams for early discharge. So that was the main concern in that study. Similarly, the impact of season and also discharge policy on complications and growth of KMC babies was also studied in Mozambique. They also found that during the cold season after discharge, there were serious complications, including death, which are higher risk, which we can see that p-value is 0.02, which was very significant. And also there were more readmission rate, which also was significant, p is 0.04. And they found that even the cold climate affected these babies. So that was also a worrying opportunity of babies getting sick, getting readmitted, and having high mortality, while the babies who are low birth weight being discharged and followed up later in KMC. Safety, effectiveness, and barriers to follow up using an early discharge policy in a resource-poor setting was also analyzed, which found that, you can see that 17% babies died while on follow-up. And outcome was unknown, that is, loss to follow-up was around 9%. And outpatient mortality was also around very much significant, that is like p-value was 0.01. So while the babies were discharged early and followed up, these were the complications that was noticed in this study. Early or timely discharge in KMC care, what are the evidence and experience, was looked by Mendoza et al. They found that the factors, these following factors were found by them as the main hindrance for follow-up. That is maternal occupation, which was significant, lower maternal educational level, and older gestational age of the babies, then the mothers won't come for follow-up, larger weight of the birth weight of the babies, non-ownership, because in cities like Mumbai, where we are currently practicing neonatology, there is a lot of admissions where the people are coming from outside the state. So the residents outside city. These are the main factors which was found as hindrance for follow-up of these babies. Barriers for KMC acceptance and practice in southern Ethiopia was also reviewed. But they found that a comprehensive approach with systematic interventions and support for the both mother, family, community, facility level, because some of them even don't have the facility for a regular follow-up. Like we have got a KMC center in our institute, but many of the places don't have a KMC center to follow up. So that is also one of the main factors hindering the follow-up of these babies. Resistance to implementing KMC in developing countries and proposed solutions was also done by Chapak et al. We have just seen her talk recently, so just the first talk of this session. And what they found that the early discharge component, including ambulatory follow-up, was found most difficult to implement. What their study found was it was difficult to implement this follow-up policy. Now we can see what are the risk factors for length of NICU stay. Though the babies are on KMC, they are low birth weight, they may need long stay in NICU. We can't do early discharge. Which are the factors? This was looked by Fu et al. They found that babies with low birth weight, those with late onset sepsis, those with low gestational age, sepsis, because we know that in low and middle income countries, sepsis is one of the factors which hinder the baby's early discharge. NEC, and also BPD, that is chronic lung disease, and retinopathy of prematurity. So all these factors prevent the early discharge of these babies. Early NICU discharge of very low birth weight was critically analyzed and reviewed by Merritt et al. They found that those babies who are between 700 to 1,000 grams, even if they are discharged and followed up, they are very straight line, because there is no any change in the weight gain pattern of babies while on KMC. Disparities negatively influence the baby's discharge. So caregiving also can be costly. We also know there's a chance for mother and father to come with the baby for a long period of time traveling. All these expenses were also looked into, and they found that a complex array of mental, emotional, physical, and structural factors play a role hindering the KMC discharge and follow-up. So this is another systematic review which is looking the same. So my key points include, each NICU has independent guidelines or protocol-based neonatal care. So some of the NICU discharge at 1.3 kilo, some will discharge at 1.4 kilo, some will stay. In private practices, they keep the baby till 1.7 kilogram. Prolonged NICU stay in preterm babies for prematurity-related conditions include apnea, ROP, chronic lung diseases, neurological abnormalities which has oromotor feeding problems which prolong the NICU stay, sepsis which need prolonged antibiotic therapy, ambulatory care need frequent travel and its expenses has to be borne by the parents. Loss to follow-up also happen. There is a lack of structured follow-up care centers in low and middle income countries like India. There is a lack of shortage of community healthcare workers for post-discharge follow-up. Given the fact that low birth weight babies are discharged early from the health facility, the fear of placing the baby and family at high risk of morbidity and mortality underline the decision for many parents to keep the baby longer in the health facility. That is my experience. And there is lack of family support also sometimes happen. There is failure to pick up danger signs. If you discharge at 1.2 kilo baby, there is a chance that danger signs are not picked by parents and baby is brought dead to the same treating facility. So in this scenario, why not we support mother and newborn care units rather than early discharge? Thank you.
Thank you very much. The arguments of both the doctor for the KMC, for early discharge, as well as the argument from our hesitant opposition, were all very good. So actually, if you will think about it, implementation of KMC actually empowers already the mother and the family to take care of the baby, so they're actually ready to have an earlier discharge. But as mentioned by our hesitant opposition, she said the model or the infrastructure for regular follow-up may not be in place, and that is one of the things that we have to look into. Actually, in our hospital, we now have the ambulatory KMC clinic, and we found out several factors that would prevent the mothers from following up, like lack of transport allowance, lack of person to take care of the other kids. And then we found out that our government actually can provide transport allowance to these families, and we were able to somehow increase our follow-up rate. I would be very interested to see this kind of debate in the General Pediatric Convention, because I think it would be far more interesting, because as mentioned by our previous speaker. We're all KMC fanatics here, so somehow we know what should be the answer. But I am hoping that this can be also be done in the general pediatric convention. So for those who are for early planned discharge and regular follow-up, please raise your hands. Okay. Can you raise your hands again? I will not count, but it seems like about majority. What about those who are against? Okay, okay. Would you give us would you want to?
KMC, then a lot of babies are not going to get KMC. That is the reason for keeping it out of the WHO definition for KMC. I'm not arguing against early discharge with KMC, but being an integral part of the definition is what we argued against and successfully kept it out of it. Again, not against early discharge, just against it being an integral part of definition of KMC. Thank you.
Thank you. Dr. Suman Rao?
My main reason for not for early discharge and regular follow-up, because I think in India we're not ready. We are still trying to get 48 hours of hospital stay for our small babies. Forget normal babies. Even for small babies, 48 hours to keep them in the hospital is a challenge. So if we introduce early discharge, then I don't know where the babies will be. That's one. Second, our follow-up services are not up to the mark. Not in the best of centers. So even when we say regular, we're not talking about daily regular follow-up like Natali does. Here it's maybe weekly. And we don't have proper way of transport, and I don't think we are ready for it. Keep them in the hospital, make them do well, send them home, and the post-discharge mortality, what we see in our trials is quite high. It's not small at all. So we need to strengthen all this, and then yes, we'll be ready at some point.
Dr. Shashi? Dr. Shashi will...
See, we have always said in Indian context, early discharge we divide into two different parts. One is the planned early discharge, that is the baby is discharged after satisfactorily fulfilling all the criteria laid down by the unit. Say for example, successful weight gain for 3 days or 5 days. Some of the units differ. Then baby has capable of maintaining its own body temperature. Baby is able to take oral feeds. The mother is confident that she will be able to continue this care at home. Our family members also assure you that they will give the support to mother. So whatever criteria the unit has laid down, and if those criteria are satisfied, then we call it planned early discharge. But if the criteria are not satisfied and they just leave, even the minimum criteria which the government has laid down for 48 hours, even that they don't satisfy and leave, that we call it as a random early discharge. So with this in mind, we have to take into consideration. Because in our situation right now, institutional deliveries are being promoted. Government is giving so many incentives. Only for that they come to the institutions without understanding the other parts, and then they just leave. In that case, we have to put these things. So almost 70% of our mothers are leaving randomly. And barely 20 to 30% depends on the each unit, they stay. So when we have this difficulty of making them stay in the hospital, and where so many other facilities are not available, they have their personal justified reasons also to leave the hospitals earlier. In that situation, we are talking about. So, at least in Indian situation, planned early discharge and random early discharge. That much we can. Yes, Suki wanted.
I think
It is the time that we really need to follow the babies. And we say that we don't have this, we create that facility so that they can come. We see that how they are putting on weight. We see that they become intelligent babies, which we have just now learned and we have been seeing. So it is the time that we really need to have a, so if we say, no, we don't have this, we don't have it, then we will never achieve. And that is why we need to really strengthen what Madam has said, random discharge, you can't help it. But otherwise, planned early discharge. The first person said, she did not say that she makes, if you are discharging a baby earlier, then you make space for other babies. See in KM hospital, so many babies. So then you are making space for other babies also. And so in that case, we really need to have only KM hospital in India still having after 20 years early follow-up. And in that also, we really need to establish proper early discharge and regular follow-up. That we still need to do it. And in this thing also, they have not said that how long they were keeping the babies in KMC. It is important that quality KMC so that they really will do better.
Okay, thank you, madam. We move on to the next subject. It is not safe to start KMC in home situations. To talk for this is Dr. Adi Sivam. We invite Dr. Adi Sivam. Dr. Adi Sivam, please keep to the time. We are very much behind schedule. We got 2 more debates.
Respected phonetics and non-phonetics. So, good morning.
We object to being called as phonetics.
I didn't mean phonetics to you, ma'am. So, as we are having this heated discussion on the various aspects of kangaroo mother care, the center of inspiration, the peaceful animals, the kangaroos, are blissfully grazing somewhere in Australia, tendering their young ones in their pouches, in their home conditions. So definitely, I think doing kangaroo mother care is possible and feasible for kangaroos, but not for humans. So you see here a picture of a typical rural India picture drawn by none other than DALI 3, an artificial intelligence. But it doesn't require artificial intelligence, just normal intelligence will tell you that what are the prevailing conditions in the practical Indian rural scenario. So whether you discharge early or discharge late, where do these children go? And is it really possible and practical for mothers to do home-based KMC? So that's the scenario. So there are practical issues in everything. For something good to happen, time, place, person matters. December, Ahmedabad, and Sashivani madam, KMC workshop occurs. But it's not the case with home KMC. There are issues with time, place, as well as person. So we had a study in our hospital. We have a good KMC ward. We also do bedside KMC. We train the mothers using videos and hands-on experience, the peer group counseling occurs, and subsequently we discharge them. One of our student doctors followed them up at home and found out, are they really doing this KMC at home? How long they are doing it? And what are the challenges they have been facing? So her findings have been already published. So among the 200 mothers, the mother newborn diets who were discharged, only 17.5% of mothers could not continue KMC at home. So I repeat, almost 20% of the mothers did not practice KMC at home despite priming them well in the hospital situation. And it's worth to notice that the average daily duration of KMC at home was very, very short, 1.3 hours during follow-up. So sometimes even in a hospital situation, the average duration of KMC is not that high, but in the home it is only 1.3 hours and it's as good as not doing KMC. There were other practical issues faced by the mothers. The babies were often crying during KMC, difficulty in holding the baby, small house, no privacy. Baby gained weight, so he stopped. It happens sometimes. In sweating, hot climate. And most of the coastal areas in southern India are very hot during summers and also in non-summers. Going to work, this is a very important issue, financial constraints, and there are family issues. So taking all these points as a gist of the problem, we know that KMC, continuing KMC in the home scenario is not that rosy. This picture has been taken from Dr. Sashivani's previous slide. Here also, not only in South India, elsewhere in India also, the scenario is typical and the challenges remain the same. Some of the studies done in central Uganda as well as in Ethiopia have also observed similar issues.
We have 1 more minute.
Mothers practice KMC for a shorter duration at home. They are overburdened with competing domestic chores, lack of support from husbands and family members, and lack of community follow-up support by health workers. This is very important. It's just by discharging them and sending to do KMC at home doesn't make our job finished. We need dedicated community healthcare workers to ensure that the KMC is being done properly. And of course, there are a lot of beliefs and practices. This is a case of branding which was prevalent in Pondicherry. Small newborn babies were treated with heated iron rods. Same holds good even in the scenario of KMC also. There have been continuation of dangerous practices at home compromising the care of preterm babies, like charcoal stoves for warmth as they were giving KMC, hot water in plastic cans around the babies as they were giving KMC, and herbal medications. These are findings from central Uganda again. So time, person and place also matters a lot in continuing KMC at home. Okay. There are physical challenges when the mother can have pain as well as other issues depending on the mode of delivery. There are psychosocial challenges including stress, depression and discouragement. As I said, financial challenges, not going for work. And so to overcome all this, one of the ongoing studies in our center is PTB, periodic telephonic boost, wherein the primary physician actually calls them up and boosts them to find out what challenges are there and whether something can be done about it. Since PTB is ongoing, hopefully we get good results. So actually my staff nurses are watching me and I'm playing the devil's advocate. I know I'll lose, but I'm happy that KMC will win. Thank you.
Thank you. We request Dr. Karo to come and do the...
Respected jury and my learned audience, I'm really unhappy. Even after COVID pandemic, we are not wiser. We have assumed that hospitals are solutions to all the problems on this earth. Dr. David Morley has described hospitals as disease palaces. And it is not for any other reasons that kangaroo mother care was thought about, conceptualized. We know all the problems that were existing and how it started. So let me straight away reject this argument that initiating kangaroo mother care at home is not safe. Let me tell you something more. In Gujarat, and I'm sure in India, many of the deliveries, almost half the deliveries are taking place in private sector, and a lot of newborn care is provided in the private sector, where cost of care is a very important consideration. So who is going to bear all the costs? If we are not going to do something at the community level, the solution will not be found. WHO defines kangaroo mother care, and home-based kangaroo mother care is a very important component, third component of the kangaroo mother care as defined by WHO way back. And what is it saying now? In 2022, it says that kangaroo care can be initiated at home. Now, if this statement comes from WHO, it means a lot. It cannot come after, without any consideration. It has to have some kind of evidence base. So, you please read the italics and the red font. It is coming with a strong recommendation based with high certainty evidence. Majority of the neonatal deaths are occurring away from the facility. This is the reality. And as already been pointed out in earlier speeches, even after institutional deliveries, it is very difficult to keep the babies in facilities for more than 1 or 2 days. So, forget about kangaroo mother care. Even essential newborn care is also difficult to provide, or see that they learn everything in 1 or 2 days, in the facility. Even that is also a very difficult proposition, and therefore we have to look at some alternative solutions. Indian scenario, I think already these things are very clear. Most of the babies delivered in facility, but no KMC started. And we are talking about 90% coverage, which will lend us to some kind of impact. And how are you going to achieve 90% coverage if you are going to do only facility-based kangaroo mother care? So my contention is that it has to be done, and it can be done very safely. Why look at experience of other countries? Why not do something in our country and see whether it works? There are studies from our country. Vishwajit Kumar has proved this point, and some other studies have also come. And in our own settings, in Gujarat also, we have done certain studies. This was ICMR study, which was done in 3 places in the country. Gujarat was one of them, Odisha and Maharashtra, rural, tribal and urban slum. And it was found that not only kangaroo mother care was feasible, but it was also safe, because out of 101 infants who were recruited in 1.5 to 2,000 gram, 2 kg weight group category, only 1 death was reported, and that too was not related to kangaroo mother care. And once they started KMC at home, which was initiated by the health workers in all the situations, there was no dropout. The problem was about duration of kangaroo mother care, but even with the limited efforts, during the project period, we could achieve around 4 to 6 hours of KMC at home. So there is a scope for improvement, but it is possible and it can be done quite well. The major limiting factor, barrier, was lack of family support and none of the other conditions that we talked about in earlier presentations. We have done studies, Dr. Vani and our group has done studies in very difficult areas, in rural areas.
1 more minute, sir.
Yes. Again, here also, 5 NGOs were involved, and only 1 death was reported, and that was also not related to kangaroo mother care. And in the NGO where I worked for many years, we have found that kangaroo mother care is so well accepted by the community because the community health workers are trained. Almost 2/3 of the low birth weight baby get initiated on KMC at home, even if it is not started in the facility. And we have found that if the health workers do the follow-up, you please read this table carefully. If the health workers do the follow-up, the duration of KMC is much better than the duration of KMC if it is done at clinic level. And in last 2 years, we have introduced a kind of checklist approach, formatted approach for the monitoring of the home-based kangaroo mother care. Out of 150, only 1 death has been reported so far, and that too not related to kangaroo mother care. So, my dear friends, this is the situation where we are working, and kangaroo mother care has proved very safe if we train the health workers and teach them how to keep track of these babies till they reach satisfactory weight. So I beg to differ from my friend and say that home-based kangaroo mother care is not only feasible, but it is also safe, and I'm sure all of you in the audience will also agree with me. Thank you.
Okay. So the topic for debate is, it is not safe to start KMC in home situation. So I think Madam has not given looking at continuum of KMC from facility. So if you are going to look at babies born, at least in our setting in India, nearly only 10% of babies are born at home. And even within that, how many are going to be the eligible? Less than 2,500 or preterm babies. That is the debate. And clearly situations, this community KMC study has shown us that it can be started at home. The only challenge or only thing we need to do, as sir has brought it out, is the training of health workers and to do the follow-up of those babies. And the babies who would be receiving KMC at home situation would be those babies who did not have any danger signs or need for admission at a facility, who are stable at home. So this is the thing, and I think we have to agree to this idea and start doing it in conditions where the baby cannot be transported to the facility, and if the baby is stable, to initiate KMC, of course under the intense monitoring of a community health worker who could be either an ASHA or an ANM, and also maybe a link with a primary health doctor or a pediatrician, which is now being linked according to the health system linkages, which can be done.
In some of the states like Meghalaya, still almost 40 to 50% deliveries are occurring at home. That is why I am putting.
Okay.
We won't take it further, but
I think for shortage of time, we can have all our discussion points outside court. Now within the court we have decided.
Settle outside the court.
Yes, sir. I think only one last comment from Dr. Rajesh.
Yeah, I tried to raise my hand for the last question also.
Sorry, sir, we didn't notice.
No, absolutely. Please don't say sorry. I think very interesting discussion coming up. I'm just wanting, I don't have any ready answer. I'm not saying for or against, but I think as all practitioners, let's be open to certain new ideas also. You know, there are, if I take India's context, the health system challenges is persisting. Human resource shortage is perennial. We have been dependent on ASHAs, now they are being overburdened. Okay? So start looking into alternative ways also. I think one of the big things that the KMC definition has brought is empowering mothers, families. We usually underestimate their strength, unless there are social and other factors. So let's first look into this and try to see, you know, if the mothers can really be empowered. And I think the duration of stay in the facility, if they are there, that's a huge opportunity for us. The second is, we do not use technology as much as possible. You know, digital health has opened avenues for us. I don't say that they don't need follow-up by health workers at home or wherever, but at least start using some of the
many of the states have taken ECD call centers for following that up.
Yes, yes.
Many of them are successfully doing, including Tamil Nadu, sir.
Yes. So I was coming to that. Also, there are some excellent examples from the communities where digital tools, you know, regular, you know, children with birth defects are followed regularly using that. And the third thing is, we are coming back from medicalized to a primary healthcare approach. That's the way forward, what we are realizing for India. And I think the COVID scenario has shown that wherever the primary health systems were functioning much better, there things were much better, and those countries were able to face the COVID brunt in a much better way, rather than those countries which were dependent on too much of specialized care. So just look at it from there.
Thank you, sir. We move to the next topic. The next topic is a senior staff nurse can decide to initiate KMC in the NICU or SNCU. To talk for it, Dr. Alpana Mai Bera.
Good morning to all. I have been asked whether a senior nurse can decide to initiate KMC in NICU or SNCU. I will say yes, as it is a standard protocol by WHO, UNICEF and Government of India to recommend for KMC practice. And senior nurse can decide to initiate KMC for the stable low birth weight babies. She will monitor and follow up the condition of the baby, and she will counsel the mother as well as the family members on it, and she can take the written consent for those. And she can having training on KMC and with experience, and she can teach technique of KMC, monitor and supervise junior nurses on KMC practice. Those who are having experience and working in the clinical area can monitor mothers and baby during KMC and take immediate measure if any problems arise. And she can keep the record of KMC practice, and those who are having positive attitude, experience and training can meet up the queries of the mother and also the family members. She can deal with the medical legal aspect and can take written order for KMC. And one study in Jakarta finds that nurses had good knowledge on KMC and they have positive attitude towards KMC. All perinatal nurses who are in the ward had experience on assigning and implementing KMC. Zhang found KMC-specific training increased the confidence of neonatal nurses and thus promoting the implementation of KMC. Berg also recommended all nurses who are providing mother and infant care must receive KMC-specific training. KMC decreased the nurses' workload because parents learn how to care for their babies. And nurses can introduce KMC education for the mother who are for the expecting mother. Chang in her review found that leadership is required for successful delivery of KMC. Nurses often feel like that they have to negotiate with leadership and management to get maximum space and practice of KMC. There are Government of India guidelines. Senior nurses can take initiative to provide monitoring, supervision and mentoring for the junior nurses and other healthcare workers also. And capacity building and mentoring at regional and state collaborative center is very much needed. Study in Western Cape found KMC training nurse have a positive attitude for the implementation. At Malawi, it also found that positive perception of the nurses on KMC increased the practice. They reported sharing roles and responsibility as a team member. They can support the KMC implementation more effectively. And misunderstanding, inadequate counseling contribute to difficulty in practice of KMC. So here is the role of clinical nurse who can resolve this problem with her good communication skill. Senior nurse with her competencies and counseling skill can play a role on KMC counselor for mother as well as the family members. Another study found poor access to information and ignorance on need of KMC, negative feedback had deleterious effect on mother feelings, even though mothers was competent to implement the KMC. To thwart this social situation, well-trained, skilled, and competent nurse can take challenges in implementation of KMC. Senior nurse with her support from higher authority can arrange public sensitization and awareness program. She can consult with her policymaker and prepare the practice guideline. study by Joshi also found that KMC coverage was increased after implementation of technique 95% by 5 days, but it was dropped down at the end of the week when senior nurse was leave. So here it was involved only one person. So involvement of the team leader is very, and whole team, and there is one leader who can implement the KMC. So here is the role of the clinical nurse who can implement KMC adequately. Here we can go through the theory of Papla's. Here the nurse-patient relationship theory, nurse while providing care to the mother and baby develop very good interpersonal relationship. And gradually this relationship is becoming intimate, and then mothers also depend on the nurses and come close to the mother nurse and share their feelings. And here is the good time when mother is mentally ready to take the decision of the nurses and believe on the nurse, and nurse also take action for the mother and baby.
It's time.
Okay, thank you.
Now we'll have Dr. Srinivasan speaking against the motion that a senior staff nurse cannot decide to initiate KMC in the NICU or SNCU.
So good morning. So this is between nurse and doctors. How many nurses are here? Please raise your hands. How many doctors are here? I am safe, I think. Thanks, Sashivani madam. I don't know why she has selected me, because I am the most, like Gokul Krishna, I always surrounded by nurses in my unit. I don't know why she has selected me to talk against nurses. Not against nurses. I don't use the word against. But still, there are certain studies shows that still we have to wait for the nurses to give the empowerment. Okay? See, I think this is a familiar picture. Everybody knows this, no? MS Dhoni, you have Bravo, and you have Ravindra Jadeja also. If Dhoni wants 2020 match last over, he wants 24 runs, he will send Jadeja to do it. I know Jadeja has done it in Ahmedabad last month in CSK finals also. Last ball 4. Similarly, if Dhoni wants restrict the opponent in the last over for 6 runs, he will send Bravo, he will bowl some smaller, slower ones, and he will restrict also. Jadeja is a batting champion, Bravo is a bowling champion, but the champion is Dhoni, no? He decides whom to send and when to give the ball to which bowler. So I say the doctors are the champions, the nurses are champions, I agree. But more than the champion, there is one captain is there, he decides when to initiate and when to decide also. So I will show you some of the studies what has happened here. See, this is one study done in Jordan for 220 nurses. 23 questions were asked from Jordan, and they want to know the knowledge and belief about Gangaru Mother Care, about those nurses. And you can see 47% of the nurses are still insecure to start Gangaru Mother Care in a preterm baby. And more than that, more people are worried about the babies who are on IV fluids, baby who are on intubated, babies with umbilical vein catheters. They said, no, we will not start. So I'll go to the next study. This is done in Saudi Arabia, Riyadh. Again, what they did, they practiced knowledge and perception among NICU nurses. Again, here the solution says several barriers were there. Most of the nurses were telling that the workload is more, my duty shift is not permitting me to do a continuum Gangaru Mother Care, and there are fear of birth injuries and fear of extubation when the baby with intubation is put in the Gangaru Mother Care. And this is a study in our India, in Lucknow. Sanjay Gandhi Institute Professor Anita Singh has done. And she studied about the barriers among the nurses, whether the KMC can be initiated by the nurses by own. So this study also shows that the most important barriers in KMC implementation were lack of support to the mother and duty schedule of the staff and convincing the mother, and lack of private environment to the KMC. And another study I want to go, here it is done in Indonesia. Gangaru Mother Care knowledge, this is the most important study. KAP, knowledge, attitude and practice. So this study done in Indonesia, Agartha, what they said that 92% of the nurses has got very good attitude. But only 48% of the nurses had got adequate knowledge. If I say perfection in KMC knowledge, so only 48% has adequate knowledge. That means what this study shows that you have to still train the nurses to go for further knowledge, then you can give the empowerment to the nurses. So what I want, even yesterday myself and RSR were analyzing as a jury, some of the papers, one beautiful paper presented from NHL Medical College, Ahmedabad by Jeet Patel, one PG. That paper shows that only 17% of the mother knows that KMC can be done in home care, and only 10% of the mother knows that husband can give Gangaru mother care. This is in India, paper in Ahmedabad. So that shows that there is a clear lack of communication from the nurses to the mother and from the mother to the father. That study shows. So what I am trying to say that nurses are real champions. We need nurses for Gangaru mother care. Yes, madam. I am giving the judgment also, madam. Only. We are not against nurses. I used to always say today 70% of my newborn are saved by nurses. That is my intention in Tamil Nadu. So what we are trying to say that we are not against nurses, madam. But still there is time to go. You can take, see, 33% reservation legislation is passed in parliament, but it takes another 4 hours to get implemented. Similarly, I request another 4 years for this to get implemented. Till that 4 years, you train your nurses to get adequate knowledge, let them be perfect in Gangaru mother care, then they can decide, they can put and they do whatever, anything. Till that time, it is the doctor, pediatrician and neonatalist has to decide till next. Thank you, madam. Thank you for the opportunity.
Probably Dr. Srinivasan sir argued against very emphatically compared to a person for the motion. But when we want to take the care to community, we want it to become more primary, probably the argument that yet they are not ready, then somewhere our own, we need to look at it, probably we didn't do good capacity building. So as a motion, nurses can do, but probably what most of the studies have shown that there is lack or inadequacies, they need to be bridged at the earliest. Because otherwise, probably as we want to take it more to the level 1 care, more to periphery, if we don't empower our nurses to do this, yes, the subject here has been kept as NICU, SNCU, where we are going to have more sick babies, but then their nurses alone never handle. It's always in collaboration with the doctors. So probably, and more than 50% of the job in the NICUs is taken up by the nurses. So nurses should be empowered. Probably somewhere we need to do more to capacity building of our nurses if it's not handling. Yeah. The next, I think we are reaching the last topic of... No, we are running behind schedule. We are running behind schedule.
Court has given the judgment.
The last topic that we have for debate is mother must not give KMC in sitting or reclining position, or should give only in reclining position only. Can give KMC in supine position also. Speaking for the motion is Dr. Parag Dagli, our organizing secretary. It's yours now.
Ma'am, I'm in a hurry because we have to finish the things in time. Okay. So thank you for the opportunity. Well, my case is mother can give KMC in supine position also. Friends, whenever we think about KMC, the common picture, common image that comes to our mind is of mother sitting or reclining in a chair or a bed and giving skin-to-skin contact to the baby. Even the MNICU wards or KMC wards, they have these specially designed wards where there are back supports and the mother has to sit while giving KMC. So even a baby in IKMC or a father giving KMC, all the images we have are of somebody who is little upright while giving KMC. So while giving KMC, mother can sit recline, stand or walk also. But can she sleep while giving KMC? At one end, we are telling that KMC has to be given minimum 8 to 12 hours a day and ideally up to 24 hours a day. What we target is zero separation between baby and mother. And other end, is it really feasible for a postnatal lady during her first 6 to 8 weeks, during which time she is supposed to give KMC? Can she give it without getting adequate rest? Some people say that the mother should give KMC for 8 to 12 hours and remaining time maybe some other alternate kangaroo care provider, maybe some surrogate person. But then there is not zero separation. So there is some paradox between our own mindset, and I would try to make it more clear. So ultimately what we want to say is that mother has to be for 8 to 14 hours in upright position while giving KMC. Dear friends, you are sitting in this hall for last 2 days. Are you willing to sit for another 2 to 6 weeks for 8 hours a day? If you are not, how that mother can be? I tried to search for references for giving KMC in supine condition or while sleeping. There are no references, I'm sorry to say. So I'll try to make it things clear with help of some common sense things. Probably there are two issues when mother is giving KMC in a flat or supine condition. Lateral lying we'll not discuss, we'll just discuss about KMC in supine position. One is that in supine condition of mother, the baby will be in the flat condition and will be in the prone, which we believe that could be a risk factor. There is a risk of SIDS when baby is in prone position, and baby may aspirate because of the flat level. And second would be the mother's position. We'll discuss it later. For the first thing, baby, whether it is in flat condition, whether it will aspirate or not, most of the babies in our NICUs currently, they are lying in the trolleys with hardly 5 to 6 degree of elevation of head end. Head end has practically no role in aspiration or GERD. So head end is actually out of the picture. Remaining thing is whether supine, prone, lateral positions. It's been proven that prone position is actually reducing aspiration events, and mainly because it will reduce the events of transient relaxation of lower esophageal sphincter. So actually prone position is prone to reduce the episodes of aspiration. But because of the worry about SIDS, prone is not advocated. Those prone positions are actually on bed, not on mother, not on the KMC position. As you can see in this picture, actually when the baby is in prone position, the aspiration will be lesser. There was one study also where prone position increased the risk of SIDS more than tenfold, but that was amongst the sick babies, not among the stable babies. Breast crawl is a video that we all know. Right after birth, within first hour, the baby is allowed to stay in prone position and start suckling right in that position while the mother is supine. I'll not go in detail because there is limited time. The second part is mother's position, which may induce too much relaxation and mother may sleep, actually sleep, and the baby may accidentally slip down or fall. There are no recommendations for this species, and they do on their instincts. They allow the babies to be on their body for as many hours as they want. Nobody is there to tell them, and no baby actually would be falling or die. This is one video I'd like to see. This is a mother staying in the NICU. Although it is not completely supine, she is completely relaxed, she is sleeping. We are practicing in our NICU for last almost 5 to 7 years. We allow mothers to sleep during day and night, and not hardly one incident has happened where baby has fallen, nowhere else. And not only in NICU, after the baby is in ward with the mother, mother is allowed to lie down. We have never reported any incidents of any aspiration or any untoward incidents. KMC is known to reduce the stress of the mother. We should allow that, we should permit it. So all I say is we need to support the mother to take rest and leave, which she knows. She only can decide how much rest she wants. There is no study that has yet proven that parachutes are actually life-saving. There are no double control studies. So although scientific studies are welcome, but at some point perhaps, हाथ कंगन को आरसी क्या? Thank you.
Thank you, Dr. Parag. Let us now welcome Dr. Sushma Malik, who will talk about against mother must not give KMC in sitting, reclining position alone, can give KMC in supine position.
Thank you, everyone. Just to save the time, let me first thank KMC Foundation and Madam Vani for inviting me here. And though I'm the last speaker, but last is not the least, and let me try to prove it. So mother must not give KMC in sitting or reclining position only, can give in supine position. So we do know the three components, and we've been hearing about it the last 2 days, and not only 2 days, I think it's at least 3 decades that we have been following this. And we do know that kangaroo position is the distinctive hallmark of our KMC practice, and various reports and various studies have already proven it. I don't have to prove, and just like my learned speaker before me said, that common sense really needs to prevail. But in addition to that, I shall prove it by scientific studies that how this position is very helpful and safe to the baby. The mother enjoys this special time with her baby. She's comfortable and relaxed, and it's been proven that this is the least stressful position for the mother. And this stress-free position fosters the mother-infant interrelation. It improves the newborn physiological stability and various other advantages which we have seen over the last 2 days. In this upright or semi-reclining position, it's very important that when we are keeping preterms and low birth weights, who are usually hypotonic, they need to be supported. We are not just putting them in a kangaroo bag. We could put them in the lycra bag, but remember that we are also wrapping them around. And the biggest advantage of this is it prevents the obstructive positional apneas, and the references are given below. The eye-to-eye contact is only possible when the mother is semi-reclining or is sitting upright, and this really helps in humanization. When she is in the supine position, this eye-to-eye contact, the stimulation by one of the senses is going to be lacking. So it's very important that we continue in this position to have a complete humanization of care. There is a reduced risk of gastroesophageal reflux. So the thing is that when GER entity was really discovered or known, it was empirically given as that the prone position and an elevation of 30 to 45 degrees is supported only by an empirical evidence. Studies on prevention and management of GER suggest that the head should be above the level of the abdomen. And the KMC position really actually fulfills this criteria. Current clinical studies, supported by Tovenever, by Ornstein, by lots of other studies, have favored that the KMC position is really very helpful. And these studies have shown, in fact, a lower incidence of GER. And this, we all know that in an exclusively or a breastfed baby, GER is far less. And this practice is also fostered in our kangaroo position, which is an integral part of KMC. In addition, there have been studies, a non-randomized clinical study recently published in India, which showed that kangaroo mother care versus the prone position in a preterm neonate, that is when the mother is lying down, they showed that the risk of they had a better control in the physiological indices. It was more comfortable.
Madam, half a minute, madam.
Yeah, better feeding, absorption, and metabolism. All of us know safety comes first, and in this position, the safety is ensured both by the bag and by the tie around. Even we need to have a word of caution against SUPC, though SUPC is more pertinent to skin contact, but the third type of SUPC in after 48 hours is very relevant for our KMC service. Monitoring, the mother is the human monitor, and she can easily detect in this position the early danger signs. Feeding of twins obviously is not possible when the mother is lying down. It's the most appropriate position in the NICUs. There's no doubt on this, and that this is the ideal position for kangarooing when the baby is in the NICU. It's the ideal way to transport babies. We already had a discussion on this prior to my talk, and transport of these babies ensures that they are vital signs are stabilized. Therefore, we need to ensure a satisfied and a happy mother and baby dyad, and this position fulfills this. Just half a minute more. The family participatory care is being, KMC care is advocated. So not only the mother, but even the alternate kangaroo provider can give KMC in this position and support her. Breast crawl is only for the early few. It's more relevant for SSC. And you said that kangaroo care in this position helps the mothers to talk to other mothers at the same time, and they form their own kangaroo care groups. Thank you very much.
Thank you very much, Dr. Malik. Simply stated, do we recommend the mother in supine position when we're doing kangaroo mother care? In the Philippines, most of the KMC wards have the the bed with the head part elevated, so we haven't really had any evidence or to support that supine position would be a good way to provide kangaroo mother care. Right now, I don't know, Dr. Sashi, do you have any evidence that showed that supine would be okay? So apparently we may have to do further studies on this, although as Dr. Dudley said earlier, is it common sense or should we do any scientific research on this? So also, is the prone, so the baby will be on prone position when the mother is on supine, is that the same as just prone position for babies on the bed? Because we know with AAP recommendation, we do not recommend prone position for sleeping. So these are things that we may have to think of when we recommend supine position of the mother when doing KMC.
Thank you.
Thank you all the debaters.
I think congratulations to all the ones who are pro and against. I'd like, on behalf of WHO, I think I'd like to say only one thing. We are working on the discharge guidelines. It should not be left to each facility. there is nothing called early or late. We just decide on the criteria. If the baby meets these criteria, then it can be discharged. If they don't, then we don't discharge. So I think that's one thing which I like to highlight, that we need to really work on the standard guidelines on the discharge, not only of low birth weight without complications, low birth weight with complications, those who got KMC or who did not get KMC, but also for the normal babies. Today, we say 48 hours, but then there are mothers and babies, if the parameters are not, if they measure the blood pressure, but if it is low or high, they still discharge. The interpretation at the facility level, I'm talking of even the primary healthcare centers where the nurses are responsible for deliveries and for discharges, do not measure. If they measure, they do not know how to interpret it. So I think those guidelines are something which we are going to be working on, and probably within a few years we should be there.
Thank you, ma'am. Thank you all the referees. You are wonderful. Thank you. I would like to invite Dr. Dilip Gadvi, our GMC observer, on the stage. I invite Dr. Parag Dagli to facilitate him. Okay, we'll carry on with the next session. Our next session is symposium on the theme of this conference, which is Start, Strengthen and Sustain KMC for Every Newborn Everywhere. It is supported by USAID, United States Agency for International Development, and the chairpersons for the event are Dr. Zerilma Zagad, ma'am. She is consultant pediatrician neonatologist at the State Research Center on Maternal and Child Health, Mongolia, and Dr. Nehal Patel, ma'am, Head of Department of Pediatrics, GMERS, Sola Civil Hospital, Ahmedabad. Over to you, ma'am.
So for today's session, sorry for taking up your tea break and starting this session back to back. And there is a slight change. Yesterday we missed an important parameter that we all know, that KMC is important for the newborn development, especially the brain development. We all are working on the brain development and tracking it. But then there are studies for the neurohemodynamics. And I invite Dr. Ruchi ma'am to talk about it. None other than her can do a justice in this beautiful topic. Please, ma'am.
Sorry. A very good morning, dear friends and colleagues. At the outset, I would like to thank Dr. Shashivani and KMC Foundation of India for inviting me for this beautiful, wonderful conference on kangaroo mother care. I bring you greetings from City of Mumbai and Department of Neonatology at KEM Hospital, St. GS Medical College. And I'll be talking on today, kangaroo mother care and cerebral hemodynamics. Now, as a neonatal caregivers, whether you are a nurse or you are a doctor, we should always remember that the second half of gestation and the neonatal period, that is from 20 to 45 weeks, is the most important period for the formation of cerebral pathways and thereby very much importance for the neurodevelopmental outcome of the baby.
And the preterm birth, preterm labor, which comes as a tsunami, alters this sequential development of cerebral pathways development and CNS development. And this poor baby lands in NICU. The life starts with separation from the mother. In addition, there are sleep disturbances, overstimulation of certain sensory stimuli, sensory deprivation, and the baby lands up with stress, the NICU stress, which is a toxic stress at the beginning of life, and the immature brain is not well equipped to process this stimuli. And today, all of us are aware of the magnificent work and a huge work which is done by Dr. Niels Bergman, which tells us that the maternal environment is a primary requirement for regulation of all physiological needs to attain homeostasis, and the maternal absence leads to dysregulation, adaptation to adversity, diversity, and zero separation is an answer which is achieved by KMC, which facilitates normal biology between mother and the baby, and thereby achieving normal neurodevelopmental outcome. So when we talk about KMC and neurodevelopment, these are the variety of mechanisms which helps to attain normal neurodevelopment, that is attainment of physiologic stability, facilitation of formation of neural connections, the enhancement of synaptic efficacy, connectivity of cerebral motor pathways, better quality of sleep, and even the maintenance of circadian rhythm, and improvement in the cerebral hemodynamics, which is currently the area under research. And this all, what achieves for the baby is the better neurodevelopmental outcome. So as we know that the preterms is a unique population, they have different anatomy, the unique physiology, and same thing applies to the cerebral hemodynamics. When we talk about cerebral hemodynamics, we are talking about cerebral blood flow, we are talking about cerebral autoregulation. So what is cerebral autoregulation? It's the ability of the brain whereby the cerebral blood flow remains constant if the cerebral perfusion pressure varies over certain range. And this is very limited in newborn babies as compared to children and adults. And there is an impaired cerebral autoregulation which increases with decreasing gestational age and decreasing birth weight. And this results in pressure passive cerebral circulation, which all of us know is not good for the baby. And this autoregulation is achieved by a classical myogenic reflex, where the arteries constrict when the transpleural pressure increases and the arteries dilate when the pressure decreases. And this slide shows you that when you look at a normal, what happens in the term babies, you can see that the cerebral blood flow is maintained over a considerable range of mean carotid artery pressure. This is in term babies. But in intact cerebral autoregulation is also observed in clinically stable preterm infants, and the blood flow remains unaffected by fluctuation in the mean blood pressure between the physiological range of say about 30 to 60 millimeters of mercury. But the story is not same in the preterm babies, and this slide will clearly show you the range of pressure when the cerebral blood flow is maintained is very restricted in the preterm babies, and below both the ends there is going to be the problem for the baby's cerebral autoregulation, and this is because of immaturity of autonomic nervous system, because the parasympathetic control of cerebral blood flow is underdeveloped in the preterm babies. And with this cerebral autoregulation, it is functional, as we have already seen, in normotensive, but not in hypotensive, very low birth weight and extremely low birth weight infants. And this fluctuating blood pressure, whether it is systolic or diastolic, it will have similar trends in the cerebral blood flow velocity, and the babies are at a high risk of developing intraventricular hemorrhage or ischemic brain injuries. The hypotension is associated with parallel decrease in cerebral blood flow due to pressure passive cerebral circulation, especially in sick premature babies. So as we know, the cerebral dynamics, hemodynamics needs normal temperature, normal heart rate, normal blood pressure, normal oxygen and carbon dioxide, and of course we never forget glucose in newborns to maintain the cerebral hemodynamics. And any alteration in any of this factor, the cerebral autoregulation is going to get affected. And it is very important to note that carbon dioxide and cerebral blood flow reactivity is more robust than the pressure flow reactivity. activity. And this tells us that when you are taking care of the baby, especially those who are on the respiratory support, this thing we have to take care of carbon dioxide, we have to monitor the levels, and we have to see that not only the oxygen, but even carbon dioxide, glucose, everything has to be maintained in the normal range for the baby. So what do we learn? That moderate hypocarbia, there is reduction in cerebral blood flow, and moderate hypercarbia is associated with increase in cerebral blood flow. It abolishes the autoregulatory response because of the marked vasodilatation, and it can lead to ischemic brain injury. So a very important message that the maintaining the normal levels of carbon dioxide is very, very important, because we are very sensitive to the changes in oxygen, but sometimes the carbon dioxide doesn't get detected because everyone may not have the end-tidal CO2 monitoring and invasive blood gas monitoring, and the carbon dioxide may remain unnoticed at times. So what is the effect of KMC on the cerebral hemodynamics? And this is my assistant professor who delivered a premature baby and religiously gave kangaroo mother care to the baby, and today the baby is about 2.5 to 3 years and doing very well. So when we look at the basic effect of kangaroo mother care is the KMC stabilizes the cardiorespiratory parameters, there is lesser variation in heart rate, respiratory rate, and there are stable oxygen saturation, lesser fluctuations in blood pressure, and improved perfusion index. So as we say that KMC attains physiologic stability, and there are multiple studies which we have discussed since yesterday that how this physiological stability is proved in literature. Now one of the reasons when we just had a discussion about the position is that upright position of KMC increases the efficiency of diaphragm and of a pulmonary function. And this paper, which was published in 2008, studying the cerebral oxygenation responses during kangaroo mother care in low birth weight infants, tells us that NIRS, that is near infrared spectroscopy, during, before, and after KMC showed the stable mean cerebral regional oxygen saturation throughout the KMC duration. So it tells us that how important is the KMC for the special, small preterm babies to maintain the oxygenation. Now, as we know that many times, these small preterm babies, they are under lots of stress, and because of this, there is overshooting of the, the chronic exposure because of stress, and because of that, there is a lot of higher heart rate variability, and this is because of immature autonomic nervous system. And when you give KMC these babies, the KMC enhances the parasympathetic signaling for this unstable baby, and because of this, there is better regulation of heart rate, there is better cardiac output, and there are better autonomic responses. So it helps in oxygenation, it is going to help you in having the less of cardiac heart rate variability, and it also enhances the peripheral perfusion through the mechanism of vasorelaxation. So what does KMC do? It releases, the acetylcholine from parasympathetic nerve endings, and it induces vasorelaxation by regulating the release of nitric oxide in arteries through the acetylcholine receptors on the endothelium. So again, you have that the perfusion, how it is helped by giving the kangaroo mother care procedure. And another important explanation is that we have what is called as slow conducted unmyelinated type C fibers in human skin. And when you give kangaroo mother care, it activates this fiber, stimulates the insular cortex, or what we call it as a limbic system, to produce the mediators like endorphins, neuropeptides, calcitonin gene-related peptides, which in turn, stimulate the secretion of nitric oxide and thereby regulates the cerebral microvasculature. So this nitric oxide induces the smooth muscle relaxation, regulates the blood flow, and thereby helps in maintaining the cerebral microvasculature. So how do we study this? So this is studied by using the, the transcranial color Doppler sonography. It is a bedside tool, it's a non-invasive tool, and you are looking at the color Doppler imaging of middle cerebral artery to evaluate the cerebral blood flow. Now we have this paper, and Dr. Nimbalkar is here with us. Now they have studied the effect of kangaroo mother care on cerebral hemodynamics in preterm neonates assessed by the Doppler sonography in the babies. And here the mean birth weight was almost about 1700 grams, and the mean gestational age was 33 weeks. And what they have shown that after giving KMC, they have studied it after 60 minutes of KMC, and what it has shown that there was an improvement in peak systolic velocity, there was improvement in end diastolic velocity, mean velocity, and there was a decrease in the resistive index, pulsatility index, thereby concluding that KMC improves cerebral hemodynamics in clinically stable preterm infants. So far, it was thought the effect on cerebral hemodynamics, we were not very sure, but now you have studies coming up showing that KMC is important and is helping in neurodevelopment through the alteration in the cerebral blood flow. This is another paper published in Italian journal almost about 10 years back, looking at impact of KMC on cerebral blood flow in preterm infants. And of course, this was probably one of the earlier studies, again showing the effect on end diastolic velocity, mean velocity. And the authors concluded that KMC improves cerebral hemodynamics in clinically stable preterm infants. The another study I've just added, because this was the study published in this year from New Delhi, where they looked at the changes in the cerebral blood flow parameters among preterms 30 to 34 weeks neonates who were initiated on KMC. It was a prospective analytical observation study, but they had limited it to infants between 30 to 34 weeks neonates, and it was shown that the KMC, optimizes the cerebral blood flow after initiation of kangaroo mother care. Now, we have now the study from our own institution, where again we are looking at cerebral blood flow, and we are correlating it with neurodevelopmental outcome at 1 year of age, and this is an ongoing study. Here the mean gestational age is around 32 weeks, and the mean birth weight of the babies is around 1400 grams. And as you can see here, we have seen that there is, improvement in the peak systolic velocity, end diastolic velocity, and mean velocity. And we have studied it at 90 minutes of KMC, that is the second column. We have studied it at 120 minutes of KMC, that's the third column. And we have seen 60 minutes after stopping kangaroo mother care. And these are the values which we have got. We have completed the 3 months neurodevelopmental follow-up. The subsequent follow-up is to be done still. When we look at the heart rate parameters and the lot of vital parameters, what we learned that heart rate showed the, the stabilization from 147 baseline, though it is in the normal range. After 60 minutes of stopping KMC, it was around 142. We didn't find the significant difference in the respiratory rate. It was 56 to begin with, and at the end of the 60 minutes of stopping KMC, also it was 56. But we saw the significant change in oxygen saturation, and it increased from baseline of 95, 96 to almost about 98%. So, and as I've told you that we are, following this neurodevelopmental outcome, and will correlate with the blood velocity values with the neurodevelopmental outcome at 1 year of age. So friends, all these studies, what they have told us, that there is improvement in cerebral blood flow, but all these studies have done it in a hemodynamically stable preterm infants. And in most of the studies, the gestational age is more than 30 weeks. What we need to do is that we require, because as we have said that the smaller babies are unstable in immediate newborn period, so people have not started KMC when they are on the respiratory support. Very few centers are doing that. So that is one group which is not included in these studies. The second thing, sick newborns, we don't have answers. Extremely low birth weight babies, we don't have answers for that. So I think, the future generations of neonatologists, with the guidance from the, all of you sitting here, we should be looking at these research opportunities in future. So in conclusion, I would like to say that KMC improves cerebral blood flow in clinically stable preterm infants, and the further research, as we have discussed, is the need of the day. And I'm sure that, coming KMC conferences under guidance of Dr. Shashivani, we will probably get answer to these difficult questions also. Thank you very much. This is our Kangaroo Mother Care Follow-up Center at KM Hospital, Mumbai. Thank you very much.
Thank you so much, ma'am. So you have even though told us that there are many unanswered questions, but you have given many questions answered also. Because many of the places where there is no tertiary care NICU, like SNCUs, we also have a FOMO to not have this point of care. Yeah. So we can have an answer that if the stable preterm is there, have KMC and forget about FOMO.
Yeah, I think that's a very important. Yeah. Thank you so much.
Comments to this?
Good morning, ladies and gentlemen. It is my pleasure to introduce our guest speaker, Dr. Kim Chi Yang from Vietnam. She's a professor neonatologist, and she's working at the neonatology department, Ho Chi Minh Hospital. From 2019, head of the neonatology department, and her area of special interest is KMC, including breast milk feeding and extremely low birth weight babies. And welcome, Dr. Kim Chi Yang.
Thank you. Good morning, everybody. First of all, I say many thanks, Dr. Sajivani, invite me come back here again for after 11 years. And why I come here for present IKMC? Because I worked in 26 years ago in Lake KMC unit. I feel boring. And so now I change another hospital for apply the IKMC. I would like to tell you my story about my work. Talk about there some thing you discussed 1.5 days ago. And that's my story. Why I applied the immediately KMC? Because I recognize it's a very benefit for a preterm baby. And I asked Dr. Neil. Dr. Neil encouraged me, you should do that in your country. And behind me there, my mentor, Dr. Natalie, encouraged me too. And I would like to introduce my hospital. My name hospital is General TWG Long An Hospital. It's level 2. It's new built 3 years ago. And it's far from Ho Chi Minh City, 6 kilometers with 300 beds, and especially the zero separation, even coronavirus. And how to establish my work? Plan, do, study, and action. And I have to manage and everything for IKMC in NICU and neonatal department. And especially we have to collaborate with obstetrician. That's the important thing. The man in the slide, he's my friend, my close friend. He's my director. He is an obstetrician. At first, he refused that I applied immediately KMC because I asked him, I will get the mother after birth, after C-section, go my unit. He said, no. Who will take care of the mother? I told him, if you don't agree, I say goodbye with you because I come here for do that. And my plan, I have to repair everything, facility, equipment, material, and prenatal care program. And train for the staff, the new staff, every young people and no neonatologist coming. And just pediatrician, a new one. I have to train in C and RB and KMC program for the whole staff in the hospital. And including, I have to train for the staff in district because the district will transfer to me. If they don't know how to skin, they cannot transfer with skin to me. And my study, what the question, if there's immediately and sustained KMC after birth and discharge, improve the survival and reduce the morbidity rate in infant less 1.8 kilo. Why I choose this figure? Because I follow WHO. Because Natalie, she said I don't need separate for randomized because she know it's good, I cannot separate. And primary thing, survival mortality and length hospital stay and breastfeeding and fluid transfusion and respiratory support. That's the population. I applied for the whole baby after birth for C-section, spinal anesthesia in operating room and local general anesthesia in operating room too. I follow up SpO2, heart rate, and temperature because it's very cold in operating room. If the for extremely baby, I have to cover in a warmer and above. And even the baby with C-section in the operating table, I give a breastfeeding according to the baby needs. And for twin, give a colostrum with CPAP, colostrum immediately after birth. It depends on the baby needs. Sometimes 15 minutes, 30 minutes. I according to the 1 hour after birth for give colostrum. And with CPAP, the baby 25, 26 weeks, even the less 1 kilo with the zero separation. Even coronavirus and baby with pneumothorax, I drain the air, I put the baby in the skin-to-skin contact. It's quickly to disappear the air. And watch the video, you can look at it. This baby, 29 weeks, 1 kilo. It's a new one. It have just graduated from the university. And after 2 hours resuscitation, the baby can suck well, even 26 and 4 days. Now she developed very well.
Em đậu suy kìa.
Đang 40. Vậy đang mất bóng hơn.
FBO2, for this baby 26 with IVF, IVF 26 weeks and 800 grams. And this baby 29 weeks, 800 grams too, because the mother with preeclampsia for C-section. In the recovery room, after 1 hour after birth, after delivery C-section.
Biết 56. Tiếp đi, đó. Sanh hồi 9 giờ 48 phút hả? Dạ. Bây giờ là 10 giờ 40 phút. Tức là 50 phút sau sanh.
This is 30 minutes after birth.
Rồi, dắt sữa ra ăn nè. Đó nghe. Mẹ kêu con ăn đi. Mẹ nói con ăn đi.
Hết nổi rồi.
Mẹ nói được không? Mẹ mệt không? Rồi, chờ chút.
This is baby 29 weeks, 1 and 1,100 grams. This hyaline membrane level 4. He needs a lot of pressure and oxygen after birth for hyaline membrane. We didn't use the surfactant for all of baby. With the 48 hours after birth, she stopped CPAP 3 days after 72 hours. Stop CPAP.
Giờ nó mắt rồi.
This baby 100 grams. 1,000 grams. Resuscitation on the mother belly. That's everything I show you. And this picture in the NICU, the parent take care of the most of things. The parent take care of the baby. We only behind them. We really take care of. At first, the staff, the nurse, they afraid that they have to more work. But after I applied, they said very happy because they don't do anything. They only beside the parent. The father give a baby breast milk, clean baby, change diaper, everything, and follow up baby too. And this is a step down for the baby more stable with skin to skin with phototherapy. And transportation with skin to skin and follow up until 2 years. We have the 17 baby alive for 27 baby less 30 week and less 1 kilo. They alive 17 baby. 17 baby go up well and follow up until now 2 years. And we discussed about the mortality. Mortality I compare with the WHO. It's different because my 72 are the baby died. The most of them less 1 kilo, and for 1, 2, and 1.8 kilo, that 1.6%. It's different with WHO. Maybe because we have a good resuscitation and keep warm with warmer above for the extremely baby, very low birth weight baby, and with very early colostrum and massage for baby 2 times per day and close follow up the baby. Maybe it's less than the WHO, I don't know, maybe more resuscitation, research. And for the 28 days, it's no baby die with baby 1,000 kilo and to 1.8. No baby die in 20 to 28 days. And how about oxygen supply for the baby, extremely baby, that 1 month, that 1 month, and the group 1 to 1.5, 2 weeks, and a half of which for the baby bigger. And this CPAP, the maximum 5 or 6 days. 5 or 6 days, maximum CPAP for baby, even the healing membrane, level 3, level 4. And the baby bigger, the 3 days, mean 3 days, and baby bigger 2 or 7. And hospitalization period of time is 2 months for the extremely baby, 1 month for very baby extremely, and 2 weeks for the baby bigger. Maybe it's longer than, I don't know, because our private hospital, we keep the baby longer in the hospital until the baby feel confident. Sometimes they ask me go home first before the discharge dysteria. Sometimes they ask me stay longer for confidence. And breastfeeding 100% after birth until discharge. And as IV just maximum 2 weeks and 1 week for the baby bigger. And antibiotics is very interesting. We didn't use more high antibiotics, just ampicillin, cefotaxime, and gentamicin. And maximum 2 weeks, sometimes rarely baby with meningitis, 3 weeks for the baby with meningitis. And most of them with for the baby extremely 10 or 4 weeks, because we use antibiotics longer, because we have to transfuse TPN, give fluids for feeding. Feeding, we have to keep the antibiotic longer, but no baby infection severe. And for the baby bigger, 1 to 1.8, just 1 week for antibiotics.
Excuse me, time finished.
Yeah. And less cost for the baby, maximum to mean for $1.5 and 800 and 300, but the family just pay a half. And conclusion, KMC immediately after birth resolved the mortality rate first 72 hours and 28 days of age. Further good rate for exclusive breastfeeding, reduce the length of stay and reduce the time of respiratory support, and thereby reduce the hospital costs. Because our private hospital in Ho Chi Minh City, for private hospital, is a very high cost when the baby 2 2 months in the hospital, they have to pay the 500 million dong. It's been about $25,000. $25,000. It's 2 months. It's 3 months. It's 100 million. $100. $100,000. It's terrible. It's been 1 billion Vietnam dong for the 3 months in the private hospital in Ho Chi Minh City. Thank you very much for the acknowledgement.
Thank you very much, Professor Kim Chi, for your wonderful lecture.
Yes, yes. Ma'am, you convinced us all that KMC is possible with the immediate care and with any newborn, with any preterm. You convinced us. Thank you.
I hope I open the door in the KMC case. I open the door, the KMC case for you, research next time in Vietnam, 2025. Thank you.
Thank you so much. For the next talk, I'm inviting Dr. Socorro from Philippines to talk about the recognition and accreditation of KMC centers of training and excellence in the Philippines, a strategy for sustainability. As in India also, we are having the accreditation system. We want to learn something from Philippines also. Thank you, ma'am.
Thank you and a pleasant good afternoon to everyone. Thank you to the organizing committee for inviting me and giving me the chance to share with you the experience of the Philippines in recognizing and accrediting KMC centers for training and excellence as a strategy for sustainability. So the objective of this presentation is really to share the Philippines' methodology and experience in establishing and sustaining a standardized facility-based KMC practice. We have utilized a programmatic approach to KMC. We all recognize KMC as an intervention and a method of care for mothers and babies. But in this instance, we approached KMC from a programmatic point of view in order to sustain the practice in the facility. Aside from the programmatic approach, which includes monitoring, evaluation, and accreditation, we integrate KMC and packaged it into relevant newborn care programs. A private-public partnership is prevailing in the national implementation of the program in the Philippines. And of course, we had to adjust to a post-pandemic situation because we saw an incipient rise in neonatal mortality rate after the pandemic in the Philippines. So just a brief history, we trained in Colombia in 1999, and from 2000 to 2006, we established the first comprehensive KMC program at Fabella Hospital, which includes an efficient network with the city of Manila. From 2008 to the present, it is Kangaroo Mother Care Foundation Philippines that assumed the lead organization in promotion, training, advocacy, and monitoring of KMC programs in the Philippines. From 2010 to the present, we have engaged regional health facilities to establish their own respective KMC programs. And from 2011 to 2014, we were the one monitoring, evaluating, recognizing, and accrediting KMC facilities. However, beginning 2015, the Ministry of Health adopted the process that we did with national recognition and accreditation and assistance from development partners, particularly WHO Philippines. From 2018 to the present, KMC facilities contracted by the National Health Insurance System, which is PhilHealth, for Z benefit package for premature and small babies. As I said, we approached kangaroo mother care from a programmatic point of view, and in 2005, Natalie Sherpak and team classified KMC into several stages. It was said that you are doing a kangaroo method if you did kangaroo position and breastfeeding alone. If you did early discharge and ambulatory or follow-up care, you're doing a KMC intervention. But when you have a trained KMC team together with the administration monitoring everything, you are practicing a standard KMC program. So we took this approach further because we know that the trained KMC team will need to establish her own program in the facility. This core team of trainers went back and trained other healthcare staff. They did their own strategic planning of action for their facility, piloted their implementation, generated evidence, and adopted as a policy of care for their facility. Thereafter, they apply for external accreditation from the foundation. This is how we did the stepwise approach in order to assess them on a regular basis and apply and give them due accreditation. Of course, also in 2005, Anne-Marie Berg and team published this progress monitoring level, which is also a scoring system, wherein the stages of change within a health facility can be classified into a pre-implementation phase, implementation phase, and the institutionalized phase. And it also takes up a scoring system where you can say that the facility is able to sustain the practice. But number 6 stage, by experience in this paper, showed that it will take 1 to 2 years of audit evidence before they can say that they have sustained the practice. In the Philippines, we assumed a more detailed approach using scoring the 4 core aspects of program implementation. We believe that there is a role for the administration, there is a big role for training, the service provision, and of course, research and quality implementation. We scored these 4 aspects on a 0, which is not done, 1, it is partially done, and 2, completely done. And we qualified the total scores for recognition and accreditation. So just to show you, this is our Care for Small Babies program monitoring checklist. We, by the way, KMC has been integrated with EENC and newborn resuscitation programs beginning 2015 with the support of the Ministry of Health and WHO. So since then, we are monitoring small babies in EINC going into the kangaroo mother care program. So immediate KMC has been done since 2015 in our country. So we do a Care for Small Babies program monitoring checklist in order to recognize and make sure that all the aspects are being assessed. So for the administration, we make sure that there is a committee or a team that leads the program. There is continuous feedback with administration. The audit evidence of practice is presented to us, and normally we would ask for 1-year evidence. But if you're a new program, we will have to look at the audit evidence from the time you started practice. The Care for Small Baby policy is written, approved, and disseminated. The protocols are integrated into hospital protocols, not just in the newborn care unit. Inclusion of the 3 aspects of the Care for Small Babies in the orientation of new employees or hospital staff. And we include the CSB program in the hospital budget. Because we feel that if it is not in the budget, the program will not be sustained. And on the side, we put notes to the monitor or whoever is accrediting the hospital on what to look for. Of course, reportorial, they will say, yes, we do that. If you don't see the document, our mantra, if it's not written, it is not done. So even if we go and visit the hospital and they say, yes, we have it, we have to see where the policy is. And wherever we go, for example, we visit the outpatient department for the KMC clinic. We ask them, do you have a protocol for the KMC clinic? Yes. Where is it? It's in the nurse's station in the NICU. No, that is not acceptable. It has to be where it should be. So in other words, the monitoring is done face-to-face. So you can just imagine, during the pandemic, we relied on their self-monitoring using the same tool. So that's administration. And then we look at training. We look at all healthcare staff in the obstetric ward or delivery room, OR, all healthcare staff involved in newborn care. That means doctors, nurses, midwives, even social workers. And we look at certification of training. And we ask for the proportion of those healthcare staff that are trained. So you get a score of 0 if no one has been trained. You get a score of 1 if some of them are not yet trained. And we give a score of 2 if over 75% of that staff has been trained. We recognize that there will be some staff that are not yet trained when we come and visit because some of them might be new in the area. But then they should have heard about it in their pre-employment orientation. Okay, so there is another category of staff. These are the medical nursing staff that are not in the OB and pediatric areas. So they should be oriented as well, and all other hospital employees should be aware, pretty much like breastfeeding. The security guard must know that this is a mother-baby friendly hospital. The janitor should know that there is kangaroo mother care in this hospital. So the awareness should be there as well. And then we look at the resource mobilization, and that looks at space, personnel, equipment. And there is an area there that requires staff reorientation, meaning if they go from one area to another, they should be reoriented to what CSB is all about. We looked at logbooks or computer-generated encoded data. All small babies enrolled and logged in. All babies in KMC unit are in KMC position during sleeping. And we look at the charts. We look at the records. And we look at those charts vis-a-vis the audit evidence. So we put all of that together. And then, of course, there are inpatient monitoring sheets that are filled out, and we look at that as well. We make sure there is a discharge planning mechanism that includes assistant for KMC at home is trained, the feeding strategy is applied, follow-up schedules are given, subspecialty consultations are available, whether in hospital or in another hospital. Emergency consultation system, meaning we give them the hotline numbers where to consult if something happens, and the discharge procedure is also outlined. All of these steps are graded accordingly. If 0, if not done, 1, not partially done, and 2, completely done. And all of those are verified with documents. KMC clinics similarly, and network with the community. In areas of research and quality, we have divided into clinical research and implementation research, and the score is separately given at stages of research. Data is encoded in the hospital management information system. Many of our hospitals are unable to completely comply with this, and the quality management system is in place and implemented. So for 38 items, we have to do this visit. Now we have resumed physical visitation of the hospitals after the pandemic. and we grade them accordingly. The perfect score, of course, is 76, but you must achieve 75% of that score to be accredited as a center for training and excellence if you are a training hub. But if you are a center that is providing and you're not a training hub, then your accreditation is, as stated, the score can be a minimum of 44, which is 75% of 58. The MBFHI status is also verified during visit. All of this are discussed in an exit interview. We meet with the team after the rounds and monitoring and discuss what we have found. And we make sure that we all agree, so there is a conformist signature at the end. If indeed they qualify for accreditation, we give this assessment to the Ministry of Health in the region so that they can appropriately accredit the center. Why adopt a monitoring system to sustain the program? Simply because behavior change takes time. Whenever you introduce something new to a person, these are the stages of the mind or the psychology or the humanity is, this is how we are when we see something new. Oh, I won't do that. I cannot do it. Maybe I want to do it. But how do I do it? Okay, I'll try to do it. Yes, I can do it. Then I will do it, and then yes, I did it. So, please, when you train a team, don't expect them to do what you taught them tomorrow. It's not going to happen. And so, as this behavior change takes time, we must ensure that communication channels are continued. Our words and actions are very important. We conduct advocacy activities in the meantime. We can incentivize, but also we encourage them to what we call a brag board. You know, be proud of what you have achieved and make sure you have an inclusive attitude. And so important in this is the topic of my talk. Recognition is important. People do something not only because they learned that the evidence is good, they found that it will be good for mothers and babies. There should be some kind of recognition that they are doing it for this purpose. And so we value this as human beings, and also how to show impact of the change on outcomes, and of course, collaborative leadership. So when we started, we were issuing an accreditation certificate like this. Is it my time?
1 minute left.
1 minute? Oh no, okay. So before we were doing this on our own, and then later the World Health Organization joined us, and then later the Department of Health or Ministry of Health were the ones giving the recognition and certification, which lasts for 3 years, by the way. Every 3 years they must reapply. Okay, so why sustain the program? We all have goals. Our common goal is that we want to decrease neonatal morbidity and mortality. But for private hospitals, they also want to acquire a reputable standing in the community and attract more clients to their and families. The benefits of the program can be short-term, but in the Philippines, this is the pathway for them to be contracted by the PhilHealth Z-Benefit Package for preterms and small babies. In other words, your accreditation can benefit because you will be contracted by the National Health Insurance for this particular package of benefits for preterm and small babies. The long-term benefits, I think we all know this already, and we've heard a lot of that. But also, let us not forget, we are leaving a legacy of a program that will help all of us achieve SGD target 3.2.2, and that includes nation building. So we don't only want to sustain, we also want to ensure quality. And you've had a 2-day very important workshop on quality in KMC. But let's not forget, challenges really happen along the way. And important, therefore, to define the dinosaurs and the problems that haunt your program, identify the solution, adopt the solution, but most important, number 4, 5, 6, 7 is document, 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 because quality is not coming and sustainability will not happen if you don't document. So last 3 slides, if you don't mind. As I say, there is no elevator to success. You have to take the stairs, meaning when you see something, propose, process, project, etc., etc. There's always no magic bullet. You think big, start small, but act now. Sometimes we get stuck with starting small and not doing anything about it. And always, always, there must be a solution to what we are being challenged, and we cannot solve our problems with the same thinking we used when we created the problem, according to Albert Einstein. So, collaboration, collaborate, integrate, recreate. These are very important terms, but really very challenging to do. And this is what happens with with our KMC in the Philippines, which my colleague will talk about after me. So this has been a collaboration between partners, and this is a 3-level training course, provider course, trainer course, and program managers course. It's a multidisciplinary healthcare team of trainers in each facility. So this is how we looked like pre-pandemic, but post-pandemic, we have resumed retraining. So we're using an online course now, and making sure that the facilities which used to be accredited will be re-accredited in the next couple of years. So efficient program management requires teamwork. But to be in a very good team or to be able to participate in teamwork, we must have these 3 important values of spiritual and in healthcare. And that's humility, patience, and generosity. I leave you with this slide. When you run alone, it's called race. When God runs with you, it's called grace. Have a grace-filled morning or afternoon, everybody, and thank you.
Thank you so much, ma'am. So we have accreditation system of the SNCUs. In that, one of the component is KMC, but we are not there with the full-fledged KMC accreditation. And thanks for giving us a light and road. Thank you.
Now I would like to invite Dr. Jacqueline, and she's a National Professional Officer of WHO Philippines. Welcome.
Ma'am is going to tell us the care of small babies in KMC and EINC, the Philippines experience. So, welcome, ma'am.
Good morning, good afternoon, everybody. Firstly, in behalf of World Health Organization Philippines, allow me to thank the organizers, the very efficient organizers of this conference, especially Dr. Shashi, the very able, honorable Dr. Shashi Bani. Our highest honors to you, Madam. And thank you for inviting us to present the Philippine experience of KMC, where we combine 3 strategies: the kangaroo mother care, early essential newborn care, but we call it in the Philippines early intrapartum and newborn care, and basic resuscitation, which we call care for small baby, which helps them survive. Not only survive, but to thrive and more importantly, to transform into healthy infants. My presentation will follow this. I'll give a very brief introduction. What was the problem? Why did we think about care for small babies? And the solution, which I will focus on CSB, or the care for small baby, and what have we gained from this intervention and the sustainability measures. How were we able to sustain? So, let me walk you through the birth of the care for small babies. So, Dr. Socorro Mendoza mentioned about this, and she has always been the partner of WHO and the Department of Health in this program. So in 2014 and 2015, KMC training was conducted in disaster-stricken regions in the Philippines. In 2013, by the Haiyan, the very super typhoon Haiyan, which practically washed out Region 8 in the Philippines, and came after that the earthquake in Region 7, and then the internal war in Region 9. So because of those disasters, the newborn mortality rate practically increased so much because mothers were giving birth prematurely, or they were not gaining weight, the babies were not gaining weight. They may give birth normal within the gestation, but these babies were low birth weight. And in 2015, through 2016, the Philippines fully adopted the care for small babies, which is the combination of the three strategies. And because of this, in 2018, the Philippine Health Insurance, which is the primary health insurance of the national government, launched the Z benefit package for small babies, or the premature babies. And in 2022, because of the we cannot do a face-to-face training on KMC and CSB, we developed together with, in collaboration with the Department of Health and with technical assistance from the KMC Foundation, headed by Dr. Suki, we launched the online module on CSB, and which was adopted by the Department of Health, Human Resource and Development as an online e-learning platform. What was the objective of CSB? The main objective was to help accelerate the reduction in neonatal morbidity and mortality in the Philippines by reducing neonatal deaths due to low birth weight. But why did we think of this? What was the problem? 15% of under 5 deaths then were due to prematurity, and 45% of these 45 deaths occurred during the neonatal period. Almost 50% of these neonatal deaths were due to low birth weight. So why do we have to go to why we just look straight, where is the problem? And that should be what we will solve. Another problem was the neonatal mortality in the Philippines was waxing and waning from 1955 through 2021. There was no steady decrease, nor there was no steady, it went up and down, okay? So that was the problem. But what was the greater challenge? A 2014 assessment shows that KMC has not been moving well. Dr. Socorro, after her training in Colombia, immediately in 1999, after her training, introduced KMC in the prime maternity hospital in the Philippines, which is the Fabella Memorial Hospitals, where almost 1,000 give birth a day. So, and there are almost 30% of those were low birth weight. So that's where Dr. Suki introduced KMC. Okay. So, but then, despite that, only 4 out of the 17 regions had KMC facilities. Okay. So what was the proposed solution? Okay. First, we had the, oh, sorry. Can I go back? Let's have a closer look in the small babies. The kangaroo mother care, we developed the care for small babies, and we trained hospitals, we trained the regional child coordinators who will be the prime trainers per region. And after that, aside from that, we also introduced KMC. You can see in this slide, there are seven interventions which helps save lives. And we can see that out of the 921 lives saved, newborn neonates, 531 was due to kangaroo mother care. So suffice to say that kangaroo mother care is an effective intervention. And we have been fully, the Vietnam showed that that is true. With KMC, we can save newborn babies' lives. Okay. As I've said, we had extensive community, a building of hospital staff, development and promotion of the CSB strategies in 2016. Aside from training, we did post-monitoring training. Actually, before we came here, the week before we came here, we just came. Dr. Suzuki and I came from a post-training monitoring, coaching, and mentoring. We don't only go there to monitor, but we coach them. Where did they go wrong? And we teach them. It should be done this way. And the monitoring tool that Dr. Suki showed earlier was very helpful. They will realize, oh, we have not done this, we have to do this. Okay? And most importantly, we convinced the hospital administration on the benefits of care for small babies. Okay? Aside from that, most importantly, we engage the community. This is where the role of the social worker is very important. In our training, we train a team of doctors, pediatrician, and obstetrician, neonatologists. These three should always talk together before even the delivery of them. They have to agree with each other that KMC should be done. Okay? This should be done. And then in the training team, in the team that is trained, we always have a social worker. I don't know in other countries, but if we have this. But because the role of the social worker is very important for community engagement. They take care of the follow-up of these patients, of these babies and the mother when they are in the community. Okay. And then, what were the results? These were the early gains. Of course, through the CSB, which is a requirement of the accreditation for getting the Z package, the C package was launched. And the NMR stabilized, and despite the COVID-19, maybe if we hadn't developed the online training, online module, maybe more babies, more low birth weight babies could have died during the COVID-19. So this is, I think, a very important results or an early gain of the CSB. Okay. So, how do we sustain? How did we sustain and how do we plan to sustain? First of all, the online module, which was taken on by the Department of Health, is very helpful. It will ensure continuous capacity building of health workers and facilities. And of course, the regular monitoring. This is very important. Because if you train and then you forget about the people you train, they will also forget what you teach them, right? So it's very important we go back to them and we follow up, we monitor, coach, and mentor them which if ever they forget what we have taught them during the training. Especially on online training, will always benefit from visiting them. Okay? And we have the performance accountability system. This is very unique in the project sites. We have 4 regions with performance accountability system. In the Philippines, when you say it's health, it is only Dr. Shashi's responsibility, Dr. Suki, or the pediatricians at the name. The local chief executives or the leaders of the community would say, oh, that's your problem. That's a health problem. It's not my problem. But we educate them that the health of the community, including the low birth weight babies, are their responsibilities. They have to do something about it. And because of this, they include it in their breakthrough. We make them have a breakthrough plan, which we audit every 3, 6, and 9 months. Okay? They come up with a breakthrough statement saying, we will help by end of 3 months, we will be able to provide transportation for mothers who will be giving birth prematurely. That's just an example. And then after 3 months, we go, were they able to do it? And because of this pass, three regional hospitals refurbished some of their wards into a kangaroo mother care ward, spending as much as 8 million. One governor allotted 8 million to refurbish that. It used to be very small, with no toilet, no sink, but then they refurbished it into this beautiful KMC ward. And last but not the least, as I've said, engaging the community, doing IEC. We have an IEC toolkit. You can see on the right lower part. This is a flip chart with very simple words. It is laymanized. It is a laymanized way of teaching the mothers. At the upper side is a community health worker using that flip chart. Using them, talking to mothers, it is used for a minimum of 7 home visits. Because in the Philippines, there are a lot of areas that you cannot reach easily. So with the help of the community health workers, they help them. As early as antenatal care, there will always be a possibility of premature birth. So they teach them what to do in case they give birth prematurely. So these are the lessons learned. Engaging national and local officials help in better solving health problems. Health problems is not only our problem, it is their problem also. And community leaders' involvement helps solve health problems. And lastly, policy support ensures sustainability. So thank you very much. Are there any questions? But I would like to have a last word, because listening to the many debates, I would say, this should be a take-home message. It is only when we decide that the life of these small babies, these low birth weight babies, matters, that we expound every possibility. We make everything possible to save their lives, because if there's a will, there's always a way. We don't need to debate about it. Thank you very much.
Thank you very much for your wonderful presentation.
Thank you so much.
That was a great session. Thank you to the chairperson. Next session is on KMC transport of newborn. The chairpersons are Dr. Rekha Udani, Dr. Arasar. Dr. Rekha Udani is Professor of Neonatology, KEM Hospital, Mumbai. Dr. Arasar, Director at Institute of Child Health, Chennai, Tamil Nadu. I welcome you, ma'am. said it 10 plus 2.
How many minutes?
10 plus 2. And 10 minutes limit, you announced that we have 2 minutes left. 2 more minutes.
Okay.
For the 3 sessions.
3 sessions.
10 plus 2. So I'll give you the clue.
Okay, yeah, please. Doctor? Acha. Good afternoon, everyone. Now, we will start with the session, which is very much important in our setup, the KMC transport of newborn, whether it is full term, preterm, whatever. And we have here, and I'm thankful to the organizers for giving me this opportunity, we have here the need to implement kangaroo mother care transport in Mongolia, and we have here Gerelma Zag, who is a consultant pediatrician, and she has received in, of course, Mongolia. And now we will start with the need of implement KMC transport in Mongolia.
Good afternoon. Thank you very much, Professor Sashivani and organizers of this wonderful conference. I am honored to have the opportunity to address such as distinguished audience. It is my pleasure to present you the need to complement KMC transport in Mongolia. Mongolia is the 18th largest and least densely populated country in the world. 1/3 of the population live in rural areas with a traditional semi-nomadic lifestyle. Our country administratively divided into 21 provinces, and also these provinces divided into 334 counties, and capital city is Ulaanbaatar. The climate is defined as semi-arid, continental, with long, severe winters and short summers. Geographical conditions and very low population density make communications, transport, and health service provisions difficult. On average, 74,000 children were born nationwide, and the 99.9% of all births were attended by skilled health attendants. The percentage of mothers under 20 years was in 2022 was 3.7%, while mothers aged over 45 years was 20.4%. The percentage of low birth weight babies are not so high. It is about 5% of all births. The national average preterm birth is 6.5%. Although in our country, the prevalence of low birth weight and prematurity are not high, they are important contributors to the neonatal mortality. Perinatal and neonatal mortality rates in our country are steadily decreasing. In 2022, perinatal mortality rate was 10.8, neonatal mortality rate was 7.8, and decreased by 1.5 compared to the last decade. Our neonatal mortality rate is low compared to the world average and slightly higher compared to the WHO Western Pacific region's average. In this chart shows where births take place in our country. Out of total births, 42% were in province, in Ulaanbaatar city, and 40.5% in provinces center. Only 5.5% of deliveries occur at counties and village hospitals. Home births are very rare in Mongolia. In 2022, home deliveries take up only 0.3%. Because of better outcome for inborn infants, regionalization of perinatal care with in-utero transport is common when special care is needed immediately after birth. In last year, more than 6,000 mothers from the 21 provinces gave birth in Ulaanbaatar, in capital city, at the National Center for Maternal and Child Health. Many rural herdsmen mothers come to the provincial central hospital for rest 2 weeks before giving birth. Healthy newborns are discharged after 24 to 72 hours. Babies born outside their home regions travel long distances by public transport, airplane, train, public bus, taxi, or private car. Because our country has extreme continental climate and rough roads in rural areas, there is a high risk of children catching hypothermia. A newborn transported in the mother's womb returns home after a few days of life through many kilometers in uncomfortable environment. This slide shows the number of births that came to the Regional Diagnostic and Treatment Center in Hovd province. This is Western province, which covers 5 western provinces of Mongolia and how far they came. Last year, 119 babies from Zauhan, Oz, Obi-Alta, Bayın-Ulgi provinces were born in the Regional Diagnostic and Treatment Center in this Western Regional Diagnostic and Treatment Center. Also, more than 1,000 babies born in Regional Diagnostic Center from counties from this IMAG. In our country, the transportation of newborn is not well developed, and there are no dedicated ambulances or helicopters, so it is difficult to transport sick newborns who need to be transferred to a reference level hospital in Ulaanbaatar. In this picture, you can see the neonatologist from one province transporting premature babies with their mothers to Ulaanbaatar by airplane, and you can see in this slide the babies are swaddled. I prepared this slide based on provincial neonatologist's Facebook, and this baby was born in October 23 in country hospital, which is located 425 kilometers far away from province center. The gestational age was 30 plus 5 days, and birth weight was 1.8 kilogram. And at 10 hours of life, the baby was transported by car and traveled 425 kilometers to the Western Regional Diagnostic and Treatment Center for food treatment. And this is a 32 years old prime gravid mother. She delivered her first child at 31 weeks of gestation in Manghan County's hospital in 2019. Birth weight was 1.3, and after birth, the baby was transported to the general hospital of the provincial center by car, 80 kilometers, by a rough road, and then it was necessary to transfer to the referral hospital, and was transported by airplane. And now the child is growing up healthy. The situation is the same for all regional hospitals. Kangaroo mother care transport and the skin-to-skin contact and the zero separation practiced early after.
You have 3 minutes, huh?
After birth, the biological normal that can improve quality of survival for the newborn infants. Several studies have shown that KMC transport infants can be performed over a short or long distance without compromising the physiologic stability of the infant. Kangaroo care transport might be considered as a safe, effective, and inexpensive method of transport in our country. In 2011, with the support of HOPES, the first kangaroo mother care training was held in Mongolia, and Professor Socorro de Mendoza and Professor Ranjan Pejavir from India, they are first people to teach this KMC method in Mongolia. During this training, we tried to use Mongolian national costumes in kangaroo mother care. Our people wear the coats lined with sheepskin in winter and thick cotton coats in autumn and spring and thin coats in the summer, and we have very wide belts, and maybe our costume may be suitable alternative for kangaroo mother care. And thank you very much for your attention.
Very nice presentation. You really made a point. In utero transfer is the best, and all the babies were discharged. Number 2, you have shown before what was happening, and now it is started with kangaroo mother care transport, and the results are really very encouraging. Thank you very much.
Okay, we're going to move on to the next one, which is neonatal KMC transport, the Vietnam experience. Dr. Kimchi is going to share with us the Vietnam experience.
I officially invite Dr. Nalin Singhal ma'am to chair the session, complete session.
Thank you.
Now, I would like to tell story again. And why I transport with skin to skin? Because I had followed the WSO zero separation, even transportation. It introduced the overview and transport rule and successful transportation and conclusion. It you know that my hospital zero separation, even transfers, and it's my department. And we are private hospital level 2, but we have to transport the baby from our hospital to level 3, and we take care of the 10 districts, level 1, level 2, transfer to our hospital, because our hospital is the maternity hospital in province. It's far from the district, 10 kilometers from 10 kilometers to 100 kilometers far from our hospital. And overview in Vietnam, in province in the north, mortality rate for transfer 18%. And in Ho Chi Minh City, a big children's hospital is 23 for the preterm baby. And in Hanoi, children's hospital, and 22% for transportation. And in our hospital, we have I forgot to give here, and we have the 75 baby for transport to my hospital to Ho Chi Minh City. There are 20 baby preterm,
and 55 baby term with the congenital heart disease. And the most of them, I have to transport to the high level because I need the surgery or the disease, heart disease. We cannot kill, we transport. And about 15 baby preterm from this transfers to me with skin to skin, most of them stable. And our hospital transport to the Ho Chi Minh City, no reflect about unstable. It means all of them stable and they stable on the way. Except the one baby very preterm transfers because intestine floor. We have to surgery on the way with the tracheal tube and bleeding and so stuck because of bleeding. That's just one case on the way. That's I'm so sorry with that baby, but we managed the baby alive when after surgery. He died after 5 months in the hospital. And how is a stabilization for reparation? We will discuss about stabilize before transfer, making decision, and reparation for transfer. In the developing country, transfer they have enough equipment. But in Vietnam, we on traditional transfer, we take a baby on the hand. And that's some problem for transfer because why they die a lot. Because of two communication, BPD and SIE. And aims of the prepare for transfer stabilization for optimize the baby condition and minimize the risk for the baby. And make decision to transfer depend on the sources, ability, safety, baby condition, etc. And stabilization, it means we follow the systematic approach, airway, breathing, circulation, fluid disability, and exposure antibiotics, ABCD antibiotics. And transfer process, first we have to call for consult, and after that stabilization and check-in and go on. And the other thing is very important for communication. Communication in and out. In communication with director board, with the obstetrician, with the family. And out, we have to call the high-level hospital. And if the district hospital want to transfer to us, they have to call first for the reparation. Reparation, oxygen, CPAP, drip, corn, and everything need in drip or not. That's the reason why I have tracheal drip a lot, because we don't have the CPAP for transfer. And my director from Philippines will supplement for me in the future with the CPAP transfers. And what the baby needs, that's A, B, C, D, A, F. And transfer rule is when warm, pain, sweet, or stable care. Stable, sugar, temperature, airway, blood pressure, laboratory work, emotions, support. Special transfer, mom and baby. If the district transfer the baby to me without the mother, I refuse. I pretend refuse. If they don't have the mother, I refuse. I don't receive. So they have to send to me mother immediately after that. Yes. If the baby is shocked, I have to give some medication. And let's go. And which one is better? I would like to answer me, incubator or skin to skin. When I set up the hospital, the boss asked me buy the incubator. It's very expensive, 1 billion Vietnam dong. It's very expensive. I said, no, I don't need it. I need the mother chest just like that. It's very expensive. And go ahead, we have to check in, we fill checklist. Checklist, we have checklist for check-in on the way, on before we go, and on the way we have to check everything. Plan, do, and action. Remember, we do not want to break down problem. We do not want. And expressing the truth, we have to tell the truth what we do. And good communication, checking, processing, and continue training again for experiences. Information, have assistance, guidance, competence, solution, direction, and advice. And for support. Summarize adequate stabilization, it's very important. Is the transfer appropriate or not? Preparation for transfer, good communication is vital. Determine the urgencies, choose the right team, check our equipment carefully. Now we can look at the video. It's transferred in the hospital. It's our hospital, from our hospital to the high level.
For your coming to this world.
This baby with stuck the jacket of tip. From Ho Chi Minh City transferred to us. Little baby born on the way.
You burst into tears. My eyes are red. Thank you for coming.
Transport in the community. Thank you. Please do like me to have smile. Thank you. Any question? Thank you.
We might be able to do interstate transfer or really sick babies. I just have one quick question for you. Are there, whoever goes, are they comfortable taking care of the mother if the mother gets into trouble? Thank you.
I limited the transferred baby to high level because without the mother, I know without mother the baby will worse. So if we don't need transfer, we have to wait the mother stable, the mother discharged from the obstetric ward, I transfer with mother. And if the baby needs the transfer after birth, I have transfer with the relative, father or grandmother or some aunt. Yes, yeah.
Very nice presentation.
Yeah. So that's the reason why 100% with the transfers. Yeah. Thank you.
So now we have the third paper, which is Innovations in KMC Transport of Newborn Babies by Dr. Daisy Evangeline Gracia. He is a neonatologist and researcher in Philippines, head of neonatal unit, and his interest is KMC transport of newborn. Several research papers have been published and many innovations are included and being studied critically in KMC transport of newborn. Welcome. Welcome, Dr. Daisy.
He's from Philippines. He doesn't have his slides up.
Can you start without the slides? Would it be possible to start saying something to us? Because we are really running short and have to be out of here in another 10 minutes.
She is champion in transport. Yeah, but she's a researcher. She should be used to it.
Test, test, okay. Is it okay? Anyway, thank you for this opportunity for inviting me. Thank you for the organizing committee. My topic is on neonatal transport, my experience in the Philippines. Although at the risk of being misrepresenting Philippines, this is my own experience from the area where I come from, and it's around 365 kilometers, which is around 5 hours from the center, which is Manila. So I come from a country where there are 7,600 islands. And 2 days ago when Suki said there are 7,100 something islands, it was less. So again, it depends on whether it's high tide or low tide. So when the islands are covered because of the high tide, some islands get lost. But see, the geographic distances will make neonatal transport a major gap in the holistic approach of the newborn care. And majority of these babies are actually delivered in low resource settings, and where the health care and even the necessary equipment are lacking, necessitating the need for transfer. So regionalization of medical centers, because it's very expensive, the way forward or the way to go is actually to regionalize regionalized medical center. I'm sorry, I'm just so disturbed. But I had this transferred here earlier, but I can use my laptop if I can.
LCD
Pardon?
So this is my topic, overcoming challenges in neonatal transport with innovations. It's a Philippine experience, but actually it's from the area where I'm coming from, and it's around like 4 to 5 hours from Manila, which is the center in the Philippines. So I'm going to discuss the challenges and how we continue to overcome the challenges and the innovations that we did in order to address these challenges. As I said, I come from an area where we have 7,600 plus islands. In Suki said there are 7,100, again, depending on whether it's high tide or low tide. I come from Luzon, and my place is farther north, and that's 5 hours from the center of the Philippines, which is Manila. So the Philippines actually was one of the 194 countries which became a member in 2014 when the World Health General Assembly met to generate the Every Newborn Action Plan, which is actually a roadmap to bring about the strategies in addressing the unending or the increasing neonatal and even maternal mortality. And in this roadmap, the Every Newborn Action Plan, as we all know of, has a coverage target of up to 2025. And these are the targets which I'm going to go briefly. 90% coverage of 4 or more for antenatal care contacts. And then during the birth process, every birth should be attended by a skilled birth attendant. And target number 3 is at least 80% early routine care within 2 days after delivery. And I'm going to zero in actually on target number 4, which is on the care for the small baby, every newborn care for small baby, which is the target is 80% of district hospitals should have at least a level 2 inpatient care for small and sick babies with provision of CPAP. And this is actually considered the new frontier in the evolution of accelerating, controlling the birth, neonatal mortality, and even the neonatal mortality. So, because statistics have shown that of the 194 countries which are in the ENAP, or the Every Nation Action Plan, 66 are not on track of the 2030 SDG target. And 55 countries, they have to double up in order to be able to catch up with the target of 2030 SDG. And these are my actually jumping board in coming up with this neonatal transport. And as you can see here, the WHO and UNICEF model of care for small and sick newborns came up with a content of care, and you can identify what we're going through, the services that need to be given, like KMC, breastfeeding, etc., and the 10 course components in order for us to scale up in the delivery of our newborn care. So here we can see that there has to be a vision, and you can identify with me political commitment, national plan, which I did not have when we started the program, financing, human resources, we did not have, but we focused on KMC and the, KMC and the financial, and the linkages or functional referral system. So that's where I started on. And I come from a hospital which is a level 3 neonatal intensive care unit, and we have 7 referring facilities to us, which are level 1 and level 2. And our hospital can do ventilators, insert central lines, we can do ROP, laser surgery for ROP, we do point of care ultrasound for PPHN, hemothorax, hemorrhage, and all. But as I sit down in a relatively comfortable neonatal intensive care unit, and see these babies come into the center and so sick with pneumothorax, with hypothermia and all. So I thought I should go out of the confines of my unit and capacitate these 7 district hospitals, which are like, 2-3 hours away from our center. And I did not have the resources. I did not have the national plan, financial, so it just started within our unit. So what I did was actually gathered. What I had was maybe political will, and because I did not have the human resources. How can I have a human resources when our unit gets busy? We have like 50 babies who are ventilated, who are sick, with only 3 nurses. So you can imagine the ratio. And the 3 nurses addressing the deliveries in the labor and delivery and in the OR. So you can imagine how busy our unit is. So I threw back the problem to the local government, in the public government. So I capacitated them. So we did training. I gathered them, did training and on the devices, how to do care for small babies, resuscitation, the stable and all. And then we visited each of these facilities and again checked on how they manage all these babies. I think one of the strengths that we had was, or continue to have, is the linkages that we established in this area. So we did not have to wait for national plan to come in because that's going to take some time. By then I will be already retired from my clinical practice. So that's what we did. And the second one that we did not have was the other one that we did was actually establishing the clinical pathway for our referring facilities. Remember, these are sometimes general practitioners. It's good if we have pediatricians in these level 1 facilities. So we had to educate them on the signals and when to transfer. We want these babies to be transferred immediately. Our goal is to really, especially babies who are small and in distress, to really start the CPAP immediately after delivery. So we taught them how to score the respiratory severity index score. A score of 5, they should start initiating CPAP in these facilities. And that's why the ENAP provision for CPAP on level 2 hospitals should be the way to go in our country because they don't have anything except for the free flow oxygen. So that's what we did. And the challenge that we faced, the second, was the equipment, and we continue to do that. We don't have, even in our level 3 hospitals, we don't have transport incubators. And actually it was nice because that made us do the KMC transport. We didn't have ventilators. So if the patients are transferred, they get intubated from the level 1 or level 2 facilities, and then they come in with pneumothoraces. So that was a big problem to us. And so we have this, the Vayu CPAP device. And this was our first transfer from Baguio City, which is around 2.5 hours from our place. And you can see the mother in a kangaroo position and the baby on a nasal CPAP. Of course, this one looks much better now, but this was our first transfer months ago when we started this. So I will like to discuss the Vayu CPAP. It's actually an innovation by the Vayu Global Foundation, which developed ultra low cost, high quality medical technologies to address the world's most pressing health challenges. And if I can present this.
5 million children die annually before their 5th birthday from preventable illnesses. Respiratory distress is a leading cause. With appropriate care, many of these babies can be saved. Bubble CPAP is a highly effective treatment for respiratory distress, and Vayu makes it accessible to babies around the world. The Vayu B CPAP system is the first low-cost, high-quality newborn and infant CPAP system that does not require electricity, compressed air, or advanced bioengineering support. The VIU-B CPAP system uses an external oxygen source, such as a wall source, oxygen cylinder, or high-pressure oxygen concentrator. From the source, oxygen tubing connects to the VIU blender. The blender innovatively blends pure oxygen to an adjustable concentration with atmospheric air by the Venturi effect. This ensures the patient does not become hyperoxic and helps prevent consequences such as bronchopulmonary dysplasia and retinopathy of prematurity. The blended air is then filtered using a reusable filter, which removes viruses and other pathogens. The gases are then humidified in a bubble humidifier to prevent the patient's airways from drying out. Now that the gases are blended, filtered, and humidified, they are ready for the patient to breathe through a pair of silicone binasal prongs. The gases then flow into the pressure generator, which generates pressure to keep the baby's lungs open. This can provide from 4 to 10 centimeters of water pressure, depending on the depth of the wand. The device can be seen bubbling, which means that it's working and the patient is receiving respiratory support. VIU Bubble CPAP.
So these are the countries which started, and it's actually, again, as I said, supported by Bill and Melinda Gates Foundation, endorsed by World Health Organization and the rest. And there's one from India, and I've been wanting to meet him, Dr. Manish, but I heard from Dr. Shashi that there are 3 doctors Manish in India. So he was exposed, so I don't know, but I'm going to leave one device here for India to look at it, and even the VIU blender. So we don't deliver 100% oxygen, but we deliver blended oxygen from 30 to 40%, 30% to 100% FiO2. So the same thing with the VIU blender CPAP device. So I'm going to skip this. FDA approved, and it has been in 2015. And this is our neonatal intensive care unit. As you can see, we still use it even if we have ventilators. So we still use it initially until we have a CPAP failure, and that's the time we transfer the baby to a VIU CPAP, a ventilator. And our future directions, we would like to have this VIU. This is my last slide. Yeah. So our direction is to have this, hopefully, to our Philippine Society of Newborn Medicine, be locally available in our country, because as of now, it's only our hospital. So I started this thing, and and as in any birthing, there is pain in birthing. But I'd like to get encouraged from your great leader. You may never know what results come of your actions. But if you do nothing, there will be no results. Thank you.
So right 2:10 we'll start our next online presentation. So all are requested to come here in the hall by 2:10. So we'll start with the next agenda. Yes.
अडेप्टर निकाल लेंगे.
Thank you very much for inviting me to
Good afternoon, everyone. Okay, just. Good afternoon, everyone. I am Dr. Sonita Trivedi Dalal, your MOC for the post-lunch session. To chair the next session, I would like to invite on stage Dr. Nitish Vora, sir, pediatric neurologist and epileptologist at Royal Institute of Child Neurosciences, Ahmedabad. And Dr. Vaibhav Patel, the next session. Okay, okay. And okay. And Dr. Vaibhav Patel, pediatrician, Ahmedabad, a neonatologist. Dr. Vaibhav Patel, pediatrician and neonatologist, Synergy Chain of Hospitals, Ahmedabad.
Very good afternoon. So post-lunch first session. The president is Dr. Niels Bergman. He's at the moment in Peru. He is not able to present in Zoom, but he has sent the presentation. So he's a KMC champion and researcher early working in South Africa. He's now working in Karolinska University in Sweden. And he has many original articles and research papers, particularly in promotion of neurodevelopment, zero separation, early child development, and first 1,000 days of life, and others. So, shall we start Dr. Neil's presentation, please?
Thank you very much for inviting me to the second regional conference. I'm sorry that I'm not able to do this live. As you're listening to this, I hope to be in Patagonia. But you have this wonderful theme: start, strengthen, and sustain KMC for every newborn, everywhere. And so I have this title that you've given me. I'm grateful for it. Kangaroo Mother Care. Zero separation, a strong foundation for early childhood development. You're familiar with my credentials, I'm sure. I'm recording this from Sweden. So, I have spoken to you before, as you well remember. Earlier this year, I spoke about reaching the very sick and small newborn with immediate KMC. For reaching the unreached. Previously, I've spoken about the neuroscience of zero separation, and I've also spoken about nurture science. And nurture science and zero separation is the same coin with two sides. It's really just the same thing. So, nurture science, I have expounded in a broad picture. Some of you may have seen this diagram before. I don't have time to detail much from it. The critical thing is, the most important thing is resilience, stress resistance, which is the capacity to maintain healthy emotional functioning in the aftermath of stressful experiences. And this comes from emotional connection, and it leads to resilience, health across the lifespan. This is the strong foundation that is necessary. The capacity to cope with stress and to restore healthy emotional functioning. That is the strong foundation. And I have the opportunity now, as you're inviting me with this title, to elaborate some particular detail at birth, how this resilience starts. And the key thing is, resilience was my first key message. Second, am I safe? There's a science of safety. And the determination that the organism, every organism in existence in biology determines about safety, determines behavior. So threat appraisal is the highest level of being, of staying alive. Am I going to stay alive? Am I going to be eaten by something else? From threat appraisal, I can regulate emotions or I regulate stress. I have these two choices. So emotion regulation requires that I am safe. Stress regulation is what I do when I'm unsafe. Everything goes to this highest order of hierarchy. That applies to every single thing we do right now. It can be called neuroception. There's a science of safety. There's a lot written about this. The more emotion regulation there is, we call this buffering. And it's the buffering that mother-infant interaction creates that makes the resilience. This is in my nurture science, mind map. And the less buffering there is, the more stress the baby has to cope with by itself in development. And this leads to vulnerability. This I have described before as under the work of Meyer and Hofer. And it's the parent-infant interactions which are the buffering, the nature of buffering. So if there's something that is stressful, the parent buffers it to make it something the baby copes with and becomes stronger as a result, resilient. Separation makes the baby cry, calling, you'll see here. And then the buffering that was regulating all the physiology is gone. Therefore, cortisol is produced that is a substitute for maternal buffering. This cortisol is good, but when it's prolonged, it becomes toxic. And this toxic creates a dependency on cortisol and permanently expects cortisol to do the regulation. That's where the toxic stress comes from. So the more buffering, the more regulation, the more resilience. So what is the exact nature now of this early, detailed regulation and sensitization? This is my introduction. So here we are. What is the strong foundation for early child development? The answer is there are critical periods. When I was at medical school, they were called sensitive periods, you see, because it didn't really matter what we did to small babies because their brains grew so, and therefore it doesn't really matter. And nurture science says it does really matter. And I'm going to detail those things. They are critical periods, and you'll see these white bubbles here. We're going to look at colostrum briefly, hormone signaling, regulation, microbiota, and the setting of clocks. And these begin in the first 1,000 minutes. When we speak about early child development, we often think of ECD, and that is 1,000 days. And I want to emphasize, it begins in the first 1,000 minutes. Even more, the first 1,000 minutes begin with the first 1,000 seconds. I am making a statement that it matters. That's 1,000 seconds or 16 minutes, but let's just call it the first hour. There are critical things in the first hour that really do matter, that are built on zero separation. So, immediate at birth. And so I've got some topics here. What is the regulation, sensitization taking place? It requires being in the right place. The right place tells me that I am safe. And therefore, the connection between regulation and sensitization can take place. Here is the beautiful image from your theme and invitation, the right place. If you look at the right place in a heat camera, the chest of a woman, same as a man actually, is yellow, is 33 degrees. A lactating woman's chest is 37 degrees. It's warmer. It's biologically prepped to be the right place. Where the place warms the infant, the place feeds the infant, the place protects the infant. And this is raw science. Alberts is another one of my icons. These behaviors are intricately, inseparably linked to the right place, and they are infant behaviors, not maternal behaviors. The mother is the place. The infant is doing these things. And so very briefly, I don't have time to describe, I only have time to relate. Every degree of temperature loss increases mortality 10 or 20 times. Feeding. You want to stay warm. When you're warm, you will feed. And there is a lot of colostrum in the breast, only in the first hour. If you go there after the first hour, there's nothing left. And if you take out the stuff that was there in the first hour, the colostrum, you'll get 2 or 3 times more volume at 6 weeks of age. Suckling, and if the baby can't suckle, expressing, which is our theme in terms of small babies, should start very early and should be continued frequently. Part of the reason, colostrum contains oxytocin. And oxytocin is protective against the stress that the stomach may be experiencing. Colostrum also feeds the microbiota. And the microbiota we need to acquire in the first 1,000 seconds immediately must not compete with any other microbiotas. There's a race for the skin. And if you're in the operating room, the operating theater lamp is going to be giving you microbiota before your mother's microbiota. And then it displaces maternal microbiota. And it's not just the vaginal passage that we refer to, or the fecal. There are many, multiple microbiota habitats. All of them colonize healthily in the first 1,000 seconds with zero separation. So being born vaginally is actually the expected biology. What happens if you're born differently? Being born vaginally also makes signaling hormones. Birth signaling hormones are very, very high when you're born by vaginal delivery. Here is just the 4 mentioned: oxytocin, cortisol, epinephrine, there's also prolactin, and there's many others, endorphins that are working through here. All of them are very high. That high expectation signals the body to be prepared. When the birth experience also now is influenced by cesarean and other interventions, analgesia, antibiotics, microbiome, those things are a critical early period adaptation, maladaptation. And here you will see that the mother's risk in 5 and 10 years' time of various morbidities is profoundly increased. And the offspring risk is very much more higher later on in life. So this is called tocosomatic signaling. Toxic stress signaling is taking place in the first 1,000 seconds. Here we have a study by Ruth Feltman. And she studied some babies at 32 weeks gestation that got skin to skin in one hospital. And they weren't allowed it in another hospital. And when they were 40 weeks, corrected age at term, she found huge differences, significant differences in their stress reactivity, cortisol reactivity, in the autonomic functioning and sleep functioning. The autonomic nervous system is how we cope with stress. 10 years later, when she came back to look at the same groups of babies, those differences had increased. Actually, we would think that it wouldn't matter what happened at birth, because if you did the early period right, then babies develop slowly. Actually, the differences increased. What kind of underlying physiological mechanism at birth in the first early period is going to be working 10 years later? And here's one part of the answer. They are oscillators. They are biological clocks. They are regulation settings. And they have to do with heart rate variability, which is millisecond speed control of my autonomic nervous system stress management. They have to do with cortisol. Remember, we've already been to cortisol. The reactivity of regulation is a 15, 20-minute kind of clock of saying, how do I regulate my emotions? And state organization. Sleep is when the brain is wired, and sleep is when I rest and recover, and that's a 1-hour clock. So there are clocks that are set, a setting of clocks. So regulation was also a heart rate variability control of stress. And connection, I already mentioned, was the critical factor. So still looking at the deep science. When we look at the early connective biological processes, Panksepp identifies that they are somatosensory. They are body feeling. They are skin-to-skin contact. Olfactory, smell, and auditory is hearing. So this is the schema. And the objective at birth, the very first objective, and this applies to all living organisms, is to integrate emotional systems for social affect. And it requires a place attachment mechanism, right place. Pain is the opposite side of this, and the core is temperature regulation. Then the emotional brain and the social brain connect. But they needed also sound and voice. So let's look at the safe environment. There's a smell of mother. The smell of mother makes me want to approach. And that I can measure with infrared spectroscopy. And that infrared spectroscopy shows an approach to the smell of the colostrum and the breast, but only in the first 1,000 minutes. After that, the baby does not approach the breast by the smell. So in the first 1,000 seconds, the baby is wiring its connection. Olfactory. In the first 1,000 seconds and minutes, the baby learns vowel sounds. Babies are born with perfect pitch, and they learn this in the first hours, 1,000 minutes of life, because they couldn't hear it quite detailed in utero, but now they get the utero fine-tuned to learn sounds because they're safe, because they're regulating. And separation is toxic stress. The definition of toxic stress is the absence of the buffering protection of adult support. So safe, if I'm unsafe, I do not integrate emotional systems for social affect. When I have connection, emotional connection, I connect dopamine. Social, I connect oxytocin. And oxytocin, dopamine, and cortisol are a single system that governs, am I safe? Threat appraisal, neuroception, how will I respond? I fear, I get an overriding strengthening of the fear system, if that's my first system that I ever use. I would rather first ever use my oxytocin dopamine system and get resilience. It's one system, and it's chosen in the first 1,000 seconds. in the first 1,000 minutes. And here you can read a scientific treatise on these differences of the capacity to maintain healthy emotional functioning in the aftermath of stressful experiences. This is resilience. Preterm birth, adverse experience, exposure to high levels of stress, and altered buffering effects of maternal care. And this becomes hardwired in the DNA epigenetic settings of glucocorticoid receptors, of oxytocin receptors, even of immunity and metabolism. And therefore, mother-infant touch is an epigenetic protection mechanism to the epigenome. But notice, glucocorticoid, cortisol, and oxytocin was my resilience factor, can be sabotaged by separation. And therefore, we do not want infants to become vulnerable. So if I'm concluding now, kangaroo mother care, zero separation is a strong foundation for early child development. In the first 1,000 seconds, there are critical periods. I did not mention delayed cord clamping, so the mothers will be hearing that from you today and sweat. Colostrum, signaling, regulation, micro about 1,000 seconds is how we start. We strengthen this by continued frequent expression of colostrum and protecting the sensory environment and sleep protection that I mentioned only very briefly. We sustain this by making the frequent expression of colostrum become breastfeeding support, including family support. And really, I've motivated in my last year or two, dedicate a health worker to make sure that these things actually happen, because that in the first 1,000 days will lead to a strong foundation for early childhood development. Therefore, we want KMC for every newborn everywhere. Thank you very much. And I wish you the best for the...
I think you are not there physically, but we all thank for that fantastic lecture, especially what was said yesterday by Professor Paul, that we have now good survival, intact survival, but beyond intact survival, we need stronger children, better development, good IQ, and that's cohort for our, from developing to developed India. So I think this is very essential, that first 1,000 minutes, first 1,000 days, very helpful. Thank you.
Yeah, so to proceed further, to talk on the barriers and enables of the KMC in Canada, I request Dr. Majida Kamaluddin Madam to please come on the dais. Madam is a neonatologist and the clinical professor of pediatrics at University of Calgary, Canada. She's a director, Albert Surgical and Clinical Assistant Program. And now stage is yours, Madam, please.
Did you lose it? Yeah, I should be fine. Yeah, okay. Good afternoon, everyone. I hope you're all awake after a sumptuous lunch. I would like to thank the organizers for giving me this opportunity. My talk today has been made very, very easy because you have heard a lot about enablers and barriers in many countries at multiple levels, and it's almost universal. So this is just a recap of what you've all heard in the last 2 days. My objectives would be to identify factors which impede the implementation and practice of KMC and those which promote the practice. And then also to look at strategies to improve the uptake of KMC. We don't have much of evidence or literature from Canada, from our part of the world. There's a lot of literature from other countries and other parts of the world. I do have a paper. This is from British Columbia. This study was set in 11 NICUs. The NICUs were a mix of either level 2 or level 3 tertiary care. The number of beds varied anywhere from 6 to 70. And the units were either all single family rooms or all open bay units, or a combination of single family rooms and open bay units. The members who participated in the study, this was a qualitative study. It was more like an implementation science study, included nurses, doctors, nurse practitioners, nursing supervisors, lactation consultants, occupational therapists, physical therapists, midwives as well. They conducted 35 semi-structured interviews, semi-structured because they gave the participants a chance to voice their opinions, what they thought about kangaroo care. So they did give them a chance to talk to them about what they thought about kangaroo mother care. They also looked at field notes, any medical records, and some observations were made. So what did they find in terms of barriers and enablers? They identified 4 broad themes, and within each theme, they identified barriers or enablers or both. In some of the themes, factors which functioned as a barrier may play a role as an enabler in another setup. So the 4 broad themes were NICU physical environment, healthcare providers' beliefs about kangaroo care, clinical practice variation, and presence of parents in the unit. Space was always at a premium. Even if space was available, sometimes there was lack of privacy. Staff shortage was a big problem. It was not just the space, even resource limitations, such as simple kangaroo care chair, was not available in some of the units, or even if it was available, it was quite few. So that was a major deterrent to practice kangaroo mother care. NICU design also played a big role. Single family rooms obviously was a best thing to have, but not all units can have single family rooms. So when they transitioned in some units from open bay unit to single family room, they did find an increased presence of parents, but this was not 100% though. What about healthcare providers' beliefs in the value of kangaroo care? If nurses believed that kangaroo care was valuable, in this study they used the term kangaroo care instead of KMC because the care was provided by family members other than mother as well. It was not just the mother. So if the nurses believed in the value and benefit of kangaroo care, then the uptake and practice of kangaroo care was much higher. The nurses were always concerned that the parents did not understand the importance of kangaroo care, and the parents knew that they had to reorganize their life to provide continuous kangaroo care, and they were also concerned that mothers or family members may not be able to voice their problems or issues if they had any problems with kangaroo care. There was a big confusion about the terms kangaroo care and skin-to-skin care. This was used interchangeably. The staff was more comfortable using the term skin-to-skin care instead of kangaroo care. As for the duration, if you told the nurses the babies can get kangaroo care for 1 to 2 hours, they were willing to help out. But if it was prolonged or continuous, they did have concerns because they were worried that mothers, especially in the post-delivery period, may be in pain. They'll have some family commitments, personal commitments. They'll have to be at home to take care of the other family members. Then the babies themselves may not be able to tolerate this prolonged KMC or kangaroo care. And then the question they had was, does this even make a difference at all, providing prolonged kangaroo care? In some units, I've depicted the barriers in red and the enablers in green. In some units, they had what is called kangaroo care champions. These were healthcare workers who, despite not having any help from the unit, from other personnel, even if policies or guidelines were not available, these guys were champions. They trained the nurses and helped the mothers provide kangaroo care. And some of the NICUs also saw that when they inducted or recruited new staff members who worked in units, other units who practiced kangaroo care, or they came from countries who practiced kangaroo care, then they supported the local healthcare workers, and the uptake was much higher. There were big challenges in staff education. In some sites, staff was paid to undergo these training sessions. But in other sites, they did not get paid, and some of the staff nurses, they had to come in during the off days to get some training. And this was, of course, not a big favorable thing to happen in Canada. They do like to be paid for this. And although nurses had basic understanding of kangaroo care and its importance, they lacked the knowledge of scientific evidence and what impact it could have on the mother and the baby in the long term. According to a medical lead, it is a big barrier. If you're looking at medium to long-term outcomes, we rely on bedside nurses to lead and communicate. This is to the family members. But I'm not sure if they know what they are doing affects medium to long-term outcome. Again, there was lack of documentation, so we could not, so the sites could not really understand if it was practice and if they could understand what kangaroo care model was all about, the healthcare workers. Nurses function as gatekeepers to providing patient care and to allowing family members to provide care as well. They believe in what is called cluster care. Cluster care is they coordinate care around the feeding times every 2 to 3 hours. They coordinate checking weight, checking temperature, checking vital signs, changing the diapers, feeding. All this takes place around the feeding time every 2 to 3 hours. The reason why they do is the nurses want to leave the babies alone to sleep between the feeding times. So if the mother or family member were to come in during the sleeping times or restful period, the nurses are quite reluctant to allow the parents to provide skin to skin because they worry that they're going to disrupt the sleep cycle of the newborn babies. And in many institutions, especially in level 2 NICUs, nurses who are less skilled, they do not have comfort in moving babies in and out of the out of the incubator to provide kangaroo care. So this becomes a major deterrent. Again, this lack of consensus is many of the institutions as to what the eligibility criteria is as to when a critically ill baby or a baby with long lines or intubated is allowed to have kangaroo care. Again, lack of kangaroo care clinical policies and guidelines is a big problem too. There's a lack of consistency in the offer of kangaroo care. Some of the healthcare workers, they think kangaroo care is one of the best things that can happen, and they allow all mothers or family members when they come in to provide kangaroo care. But the other staff members, for them, kangaroo care is not a priority. They have to finish all the other work that they have, and this is low down in the totem pole. So there's a big variation in the practice or offer of kangaroo care. What happens in Canada is babies, once they are stable, they get transferred from tertiary care units to level 2 units or special care nursery units, which are closer to the family homes. So the babies who are transferred to the level 2 NICUs, they may go to sites where they do not practice kangaroo care, or they practice kangaroo care and the practice is so different. So this causes a lot of frustration in the parents. Again, Canada is a multicultural society. Many languages get spoken there as well. In some cultures, they have this restriction where mom is confined to the houses for about 30 days. They're not allowed to go into the hospital, so they cannot provide kangaroo care. Of course, this problem can be circumvented by sending family members to provide kangaroo care. Again, multiple languages are spoken in Canada, and not all of them can speak English, but the kangaroo care resources are available only in English. Then, according to a healthcare personnel, there's a lot of separation which occurs. One after cesarean section, we did hear about it this morning, and on admission to the NICU. Even otherwise, there's a lot of separation, and some of the separation is unnecessary, according to a healthcare personnel. Okay, the use of recreational drug use is on the rise in pregnant mothers. So this results in babies getting what is called neonatal abstinence syndrome. But the symptoms and signs of neonatal abstinence syndrome is severe. The babies get admitted to the NICU. So this is the first step of separation between the mother and the baby. And if the NICU has no private space, or if there's no space, then these mothers cannot provide skin-to-skin care. And the other problem is, because of their lifestyle, some of these mothers lose guardianship of the babies are apprehended, which means the mothers cannot visit the units or provide kangaroo care. It would help if we come up with policies and guidelines to address this particular problem involving this particular group of babies and the mothers. And nurses also felt if consistent information about the short-term and long-term benefits of kangaroo care is provided using multiple modes of communication, not just verbal, putting up posters, that would increase the uptake of kangaroo care. So some of the enablers that were identified by the healthcare workers were paid accommodation close to the NICUs, providing meals, paid parking, giving them transportation vouchers, and providing family room for siblings when the parents or the family visits the NICU, and providing them with social worker support because the NICUs have social work support in Canada. As per the study, what they think is provincial and local healthcare systems should prioritize family-centered care and kangaroo care practices. They do have to develop and disseminate provincial guidelines and indicators, educate and support the healthcare workers, create educational models in different languages to help parents who cannot speak English, create a welcoming and developmentally supportive environment for the entire family when they visit the NICU. And the question should not be, why should we do kangaroo care? As we do have the evidence, the question is, what is holding us back in making this a standard of care? Do I still have time?
Yeah, 2 minutes.
Okay. This is a busy slide. I'll just tell you the salient points. So if you want to increase the knowledge of parents, you could make use of the healthcare workers. You can have online sessions, independent learning. You can use social media, have radio campaigns, TV campaigns, put up brochures and posters in clinics. And you can also include high-profile celebrity or community champions. Example is the polio campaign in India where Amitabh Bachchan played a big role. So that will be really good. And then for improving social support of parents, come up with parental support organizations. Ask them to help you out. Develop some parent support groups in the NICU itself and ask parents of former NICU graduates to lead these meetings. Get the help of social workers, psychologists. For the staff, you can use different modalities. You can have web-based training, simulations, include this in the medical and nursing curriculum as well, and have regular ongoing KMC audits. For the healthcare systems, come up with guidelines, provincial guidelines, any guidelines for the local centers, local sites, distribute these guidelines, and have benchmarks. Make sure KMC coverage is happening, have target levels with ongoing monitoring and reporting. So take-home message, every NICU will have unique barriers and enablers. You cannot use a one-size-fits-all approach at all. When you look at strategies, look at barriers and enablers which exist in your particular unit and look at all the stakeholders, different people, multidisciplinary team members who play a role in kangaroo mother care or kangaroo care. So I think that's the end of my slide. Thank you.
Thank you, ma'am. It was very well described the points towards the barriers and enablers of the KMC. Everywhere is the situation. But at the end of the day, what we need is the zeal and intent to start the KMC. So if there is a will, there is a way.
Definitely.
Thank you,
Thank you
ma'am.
so much. Yeah.
Now, I request Mrs. Supriya Bansal to share the experience on the efforts to start the KMC as a part of the ANS experience. Madam is ANS co-founder and the director of the research and the partnership. ANS is a new global health charity that is building the healthcare capacity to enable the mothers to provide the kangaroo care in the public hospital. And they have done very fantastic work during the second COVID wave in India. So now stage is yours, ma'am.
Hello. Good afternoon, everyone. Thank you so much for having me here, and thank you, Dr. Vani ma'am, for inviting me to speak. I'll tell a bit about myself. Just to clarify, I don't have any medical background and I'm not a doctor. Less than 2 years ago, I graduated from Cambridge, where I was researching child trafficking. So I don't have any experience in kangaroo care either. And I worked with a lot of NGOs, including one called Suvita that tries to increase uptake of vaccinations through SMS reminders and immunization ambassadors. So what am I doing here? So this year, the start of this year, I joined a program called Charity Entrepreneurship in London. What they do is they research a lot of ideas, more than 100 ideas, for thousands of hours to try to find the most cost-effective and impactful ideas that could save most lives. Their top ideas include HIV and syphilis stool testing, fortification of flour to reduce rates of anemia, ORS distribution, increasing vaccination uptake like Savita, and kangaroo care. So kangaroo care is an idea they researched for thousands of hours, and they found it to be extremely cost-effective at saving lives. They also talked to a lot of experts in the world, where they also reached out to Dr. Vani ma'am and talked to her about kangaroo care. And that's how I ended up with Ansh. So Ansh is a 8-month-old organization. It's also a baby. We got incubated in London. We received a seed fund to come to one of the high priority countries, which were Nigeria, Pakistan, and India, to increase the uptake of kangaroo care in facilities. So I don't think I need to talk about why kangaroo care. I think everyone knows why kangaroo care. There's strong evidence that it reduces mortality by 33%, and that's compared to incubator care. It's neglected. The coverage of kangaroo care in a lot of areas is close to 0%. And you can scale it up. There is a need. There were 2.4 million children in 2020 who died in the first month of their life. So there's a clear need, and it can easily scale up. So what have we done in less than 8 months? So first thing we did was to figure out where we want to work. And that required us doing intense geographic assessment. We looked at all the priority states, and then we looked at district-wise neonatal mortality to figure out what districts would be the most impactful to work in. Once we had finalized a location, that was Rajasthan and Bara and Pali districts of Rajasthan, we started reaching out to partners who are already working in these districts to do the implementation. We have 2 partnerships, one with Action Against Hunger in Bara district and one with Sehat Sanstha in Pali district. Other than that, we have established an advisory panel which includes top executives and advisors from Gates Foundation, Stanford University, and the most impactful organizations in the world like New Incentives and Fortify Health. We have government approvals to implement in these 2 districts. We are almost done with setting up with the pilots, which are set to start this month. We have a strong M&E system where we are partnered with Dimagi, the social enterprise based in Boston. We are developing a software with them on ComCare, where we plan to collect qualitative and quantitative data. We have also hired M&E coordinators who would dedicate full time in these facilities to observe the facilities and collect information on the quality of care. We have also talked to Dr. Vani ma'am to help us out with training of the healthcare nurses that we plan to that we have hired. And finally, we have set the launch dates for this month. So a bit about our pilot districts. Bara is one of the aspirational districts with district NMR of 35.7. Average monthly births in the district hospital, the public district hospital, is 550, and the KC coverage that we have observed is close to 0%. For Pali district, the average monthly births is around 908, with the district MNR 29, and with KC coverage again close to 0%. What we are thinking of is to start with district hospitals, then go district-wide by setting up referral systems or training in CHCs and PHCs. Then once we have a proof of concept of our model, replicate it to other districts, and then finally start focusing on other priority states of Bihar and Madhya Pradesh. Now, what are we exactly planning to do? We are planning to address these barriers, which is lack of equipment, staff shortages, lack of training, and perceptions around kangaroo care. And we are doing this by repurposing PNC wards. So we have talked to the facility that can we have some specific beds in the PNCs that would be dedicated to these low birth weight babies. We are hiring healthcare workers. In one district, we are hiring 11 nurses, and in one, we are hiring 9 nurses. We are providing very good training to these nurses and how to support and manage kangaroo care. And then finally, we are establishing a follow-up system, a phone follow-up system, where nurses will call these mothers after discharge at 2 days, 7 days, 14 days, and 28 days of age. Other than that, we are working on infection prevention and control. When we visited these facilities, the bathrooms were extremely dirty. There were no protocols around IPC. So on our side, we are establishing portable hand washing stations and sanitizers on every bed. And we are also talking to facilities to have their cleaners follow the IPC measures established by the Government of India. We are also working on behavior change with a scientist based at Northwestern University and with another organization, Noora Health, where we are incorporating multiple behavior change strategies on the resource side and communication side. On resource side, we have things like privacy screens, and on communication sides, we have case studies of babies who have successfully done kangaroo care. And then finally, we are working on strong M&E system that I've talked about a bit with Dimagi. This is our theory of change. This is a bit deeper look at our theory of change. I won't go in detail because of time. And finally, what we are planning to do. So we do have international advisors. What I'm here for is we need more advisors who are KMC experts. We need people and champions with like decades of experience in kangaroo care, doctors, pediatricians who can help us talk to these public hospitals. It's very difficult to sort of convince the administration in these hospitals. They're very resource constrained. They don't really want to believe in something like kangaroo care. And if people like you, people with decades of experience would come help us out in talking to them and sort of convincing them, it would make it very easy to provide these resources and services. And yeah, any questions if we have time? Thank you.
Ms. Supriya, that was fantastic because Ansh doing great. And it's learning and sharing. That's what you said. You are looking for help, and there are experts who can help. And we all should join hands together to have better care. So it's public-private partnership, and I'm sure good success for Ansh and all the newborns.
Thank you.
I'm sure Dr. Parag Daglin Vanavan will be very happy that we saved 10 minutes in last 2 sessions, madam. So saving time, saving brain, saving babies. Thank you very much.
Yeah, of course. Thank you. Thank you so much.
Thank you so much. I would request our chairpersons and speakers to proceed for felicitation. Now for the next session, I would like to invite on stage our moderators, Dr. Ashish Mehta, sir. He has done Fellowship of Neonatology from Australia. He is the Director of Urban Newborn Care, Ahmedabad, as we all know. And he conducts courses of fellowships in neonatology for NNF and IAP. He is the founder trustee of KMC Foundation India. I would also like to invite as a moderator, Dr. Jatin Mistry, sir. He is an intensivist in newborn care and neonatal transport. He is a consultant in Neonatology UK, founder trustee of KMC Foundation India, and national trainer NRP KMC Newborn Transport. Over to you, sir.
તો ક્યાં ત્યાં છે અહીંથી જ કરીશ ને ભલે ત્યાં બેઠા અહીંથી કરી દઈશ
I would like to invite our panel members, Dr. Kamal Parikh sir, consultant neonatologist, Kamal Hospital, Ahmedabad. Dr. Nitin Trivedi sir, consultant pediatrician and neonatologist, Shiv Shakti Hospital, Amreli. Dr. Manan Parikh sir, consultant neonatologist, Lotus Hospital, Baroda. I think Dr. J.R. Gohil sir and Dr. Jatin Unadkat couldn't be here.
Good evening, friends. This is post-lunch session, and I understand that last part of the conference. So we are all eager to wind it up, but I will not let you do that. Believe me. And I can see the face of Parag and Shashivani, madam, that you are not following the protocols. Okay. Okay. Anyway, so we have heard a lot about kangaroo mother care, advantages, the hardships or the difficulties to get that into the practice, IKMC, transport, everything is there. But when it comes to the reality, yesterday Professor Paul said that yes, part of the healthcare and major chunk comes from the private setup. And I'm happy to see here that the panelist here is purposefully selected that they are coming from the private setup. So would like to understand that what is happening in the private setup as far as KMC concerned. Is there a difference between public and private? That is first question. And I would like the panel to interact on that. Why there is a difference? Because right from beginning, I keep on telling the organizer that there should not be any difference in the private and public as far as KMC or any for that, but any in modality is concerned. So why the panel first of all? Why you are talking about that? How can you improve the care in private? Nitin? So challenging basically the title of the panel.
Well, of course, Ashish bhai, this is a very important question because I bet that many of the private practitioners are still not on the road of KMC. That is why it's different than what the government is doing and what our national policy and what WHO has recommended. So every time the sensitization of the health workers, especially the pediatrician, is required. Not only it's a question of obstetricians, but it's ours which is required. I think so.
What do you think, Manan? Why you say that in a private practice, how can improve? The improvement has to be public and private both. Why the question is about the private practice?
I understand what you are subconscious mind pointing to. But the thing is that KMC itself needs to have a big motivation when it comes to the practices. Like if I am a fresh pass out and I want to start NICU, કયું વેન્ટિલેટર લેવું છે, કયું વોર્મર લેવું છે, કયા ઇન્ફ્યુઝન પંપ લેવા છે, what will I do for KMC? How will I train my staff? How will I encourage my mother and family member that nobody thinks? And just this question.
All question will come in the public also.
Yes,
Sheila Ben and everyone will be doing the same question. Shwetal Ben, everyone.
So
why private?
That is what I'm saying. But when it comes to the patient chunk, nowadays they have become very much sophisticated. I'm just quoting one line of my mother when I was explaining her about KMC. I explained everything and she asked, "एक कलाक में मन मोबाइल जुआ मर से?" So the mentality of the people which we are dealing in private is little bit different from the public sector. But as you said, the challenges are at both the levels, private and public both. We need to be little more aggressive because at community level, at community hospital level, there are a lot of people doing it, and when they see like this thing is happening, they understand this the importance. While in private, there is a limitation of numbers, and then they don't realize that importance, and that is why we need to motivate them to do such beneficial strategy?
Kamal.
The major difference is in government setup, the deliveries are occurring and the babies are in the same hospital. Most of the setups in Gujarat had different place for delivery and different place for the baby care. And the mother and baby are separated. That is the major issue. And when the question comes of the admission of the mother, the hospital don't have space for the mother. So that is the biggest issue for implementing KMC in private setup.
Jatin will agree with me that actually everyone is eyeing because there is no money, the private setup will not do this. Am I right or wrong?
Absolutely, sir. And I think that is what the question I asked Nitin Bhai. What are the challenges of KMC in private? Because he is practicing in Amreli. So, Nitin Bhai, if you can enlighten, what are your specific challenges when you encounter on this issue?
Well, the first challenge is to sensitize the, as I initially said regarding the doctors, but it is regarding the parents also. Because once we say kangaroo mother care, so they become very funny. हमारी पास सेवा पण वीडियो है, I have so many videos. Their parents says, "Oh, what is kangaroo mother care?" So everybody laughs on that also initially, but then we have to explain them regarding the benefits of kangaroo mother care. The doctor's part constraint is the counseling. Sorry. Doctor's part constraint is the counseling, because a good counseling, paramarsh, je apne kahiye chhe, one-to-one discussion with the parents, especially with the every family member, and it requires a lot of time. It requires a time of the reception person, it requires a time of the KMC champion sister, and not only our staff, but once the doctors come into the action in the consulting chamber, he also put some time, then only this can be. So for a busy pediatrician, for a busy neonatologist, where he has to run for many calls, he is not able to explain properly, counsel properly regarding the kangaroo mother care. As far as the mother...
You have written first line, just I will try to elaborate.
That is what I said initially, pediatrician.
And obstetrician coordination.
That coordination, because as IKMC is now a concept, so when we ask the obstetricians regarding the immediate kangaroo mother care, they are also a little bit scared that what the parents will think of it, because they must not have explained them properly before the cesarean section, and many of the cesareans are happening in the emergency. So mother is not ready to accept that my child can be put on my breast while my cesarean is going on. So that coordination with the parents and with the obstetrician is also required. And as far as the other doctors concerned, they feel that when we ask many of the other pediatricians that are you practicing kangaroo mother care in a low birth weight baby, so they said we had a fear of infection also. So that is also a myth, but it is there.
Okay. Yeah, but then see, the discussion is that all this problem would be the same, questions or hurdles would be same in the public setup also. In fact, I strongly feel that it will be more in the public setup than the private setup, because the number of mothers that you are going to see or the total number of admissions are less in comparison to any major hospital in public. So I think the actually problem would be more in the public setup than the private setup. That is what I believe.
Kamal bhai.
Yeah, it should be, but major is a motivation of a doctor. If the doctor is motivated, he is willing to implement, he can do. In private also, we are also doing for at least 6 hours of KMC most of the babies. So it is possible. So, but the major problem is of the space. Previous slide.
Okay.
Of is the space. There is no space in the most of the NICUs we sometimes visit, and there is no space for that. There is no comfortable chair for providing care. So they should do on that aspect. And mother, they also feel that the babies on respiratory support or on CPAP, their chances of apneas or central line or venous line displacement and mother related. Cesarean mother is not available for first 4-5 days and so.
So I think it is still true that most of us, many a time we come across where staff or parents believe that KMC can cause infection. Is that you have found in your practice that, Nitin bhai, you wanted to say? Patient is also saying that KMC can cause infection. Is that a barrier?
No, I don't think so. Once we explain them properly that it's beneficial, they are ready to do. Okay. So a good counseling again and a good dedicated team is required. And as we have already now facing every pediatrician is all this PMJ and Ayushman Bharat Yojana, where the parents are not allowed in the NICU and the babies are kept for 5, 6, 7 days, or even for the 28 days. I have seen that NICU graduates who stayed there for 28 days, not given a single time breast milk, when they come to us and they are being intentionally discharged, then that now the 28 days period is over, you can go to the other NICU. When they come to me, I asked them regarding the breastfeeding. They said, we haven't given at all. We immediately start KMC. They lactate, the mother lactate, and successfully they finishes the initial 6 months for the exclusive breast milk with a good growth development. So I think as these all government help to needy people, but simultaneously there must be, as we said, accreditation, and there must be some monitoring on these all sectors which are providing facilities.
One important thing we all private NICUs face that we receive a lot of patients from periphery and other obstetric hospital of the city, and then nowadays the trend is each obstetrician keeps mother for at least 3 to 5 days. Come what may, whatsoever is the condition of mother, and even if the baby is stable, we want to start KMC, mother is not available, other family members are not willing. So after doing everything, due to this issue also we face, we constrain our babies from getting KMC.
Okay. One another issue is when the cesarean deliveries and the mother comes, they don't allow to bath the mother for first 6-7 days. And the staff says that the mother is smelling so much, so we ask the mother to go home and take a bath. Then when I asked the obstetricians, they said we don't allow them to bath for 7 days. So that is also an issue that the staff feel that the mother is not healthy or.
So again, the staff education is the solution probably.
To me, it is more of a nursing challenge. Yes. Explanation is all right, place is all right, consultant is explaining, so many softwares are available these days. But Dr. Manan, do you think that is a nursing challenge, and what kind of difficulties they will face, nurses particularly, in offering KMC in private setup?
So, nurses, first of all, they need to know, as Dr. Majida also said in one of her slides, that nurses are not properly told that what is the intervention and what are the benefits of intervention. If they don't understand the benefit, then they will not offer it, the benefit. Second thing, proper training, proper method of providing KMC. It is not explained to the nurses. Whenever any new fresh nurse come to us, we explain her IV sampling, ventilatory care, but how many of us on the first day ask her, do you know how to give KMC? And then how many of us train that nurses to provide KMC? So that is, I think before the nurses, it is onus is on us, we educate our sub-staff, and not nurses also, but even IMRC can also explain the importance when they are there with mother of KMC. So we need to educate our staff about the benefit of the KMC, and then the process is throughout the hospital, and everybody is coming to the hospital to understand the importance.
Okay. Goyal sir is there with us. Sir, we have been talking about the KMC in private sector. I would like to ask you about, you have been long time in government facilities. Sir, can you share what are the challenges of a government setup in providing KMC?
The challenges are almost similar because the same commitment, first of all, the doctor needs to be convinced. We have seen the new APs or associate professors coming here. Like, it may seem strange to people like in Baroda or Ahmedabad, but in smaller towns or newer medical colleges, then we need to convince each one that this is the thing to be done. It's not like you are getting a high frequency ventilator. They think it is like that. It's not. So it is a part of that normal newborn care. So for that to occur, first the doctor should be convinced.
Okay.
Once he is convinced, then he will tell the nurses to get committed. Because nurses always think it is an extra work. Pint chalu kar diya, that is easier. Warmer niche rak diya, that is easier. Then, but here they have to see, to actually do something, even for 3 minutes. They have to instruct and counseling, and they always fear that counseling will take more time. So the only constraint which is probably less is the space. But here also, the space is available in NICU, clean and septic, clean or inside, outside. But to find out a space for another room, what we call in the government is now calling, instead of using the kangaroo word, the mother and newborn care unit. So in Bhavnagar, we had to build a new MNCU. So that we got it. Otherwise, in an existing NICU, like in Junagadh, we got a very small room. And yesterday we were talking about parental involvement, paternal involvement. Now father will not bare his chest in front of other ladies. So we need a separate room. So space is there, but getting the space, for that the administration has to be convinced.
So
basically it is commitment, conviction and education. And the fear of this, because infection rate is much more in government setup, there is always this fear. So they will not allow mothers to go inside. So
we understand the strategies and hurdles, but when you look at the total advantage of offering KMC to any newborn babies, now we talk about biggest thing is about establishing breastfeeding and that to exclusive breastfeeding. So which are the hurdles to reach there, and how can you get to the final point of exclusive breastfeeding and maximum number of babies on exclusive breastfeeding? How can you do that to all of them?
The one thing which I have found in Junagadh particularly is that the privacy in the postnatal ward is not available. They're all two male relatives for each mother are there 24 hours inside their power. So a postnatal ward should not have allowed fathers or male persons, because one mother is breastfeeding, or we are trying to breastfeed by putting the baby prone onto the chest of that mother, of a cesarean mother who is supine, and we are exposing her breast. And the other relatives may be looking at it, and this mother's husband will not like it.
I understand that we do that, but how will you deal with that kind of situation? What is your
administrative
what would be
support,
your advice for this kind of problem?
Administrative support is very crucial, and we need a special counselor, I believe. Now the current level of counselors are not sufficient. Even the lactation counselors are so-called lactation counselors. What they do is sometimes in our setup is that they just take the data, how many are breastfeeding, how many started within how many hours. So they are data collectors rather than actual counselors. So like we did in ORS, switching from IV to ORS, it took us 6, 7, 8, 9 years. And then we sometimes left out the seniors. वो नहीं सुधरेंगे, वो उनको जाने दो. So ongoing constant education will occur, and then only the switch.
Sir, in private what we do, that as soon as the delivery occurs, either the normal or a cesarean, we start breastfeeding, and I myself stay over there for at least 10, 15, 20 minutes. And now it's a pattern for each and every gynecologist that this doctor is not going to run away after attending the call. He will stay here for 10, 15 minutes. And the all nursing staff of the obstetricians feels better that, oh, there is somebody to look after the baby for the breastfeeding. And as soon as I reach to my hospital, I tell one of my staff member who is a KMC champion or a lactation counselor, I ask her or him to go to that particular hospital. They will go again, they will stay there, they will explain the kangaroo mother care again and breastfeeding practices, all latching and everything. and they will offer the number, and whatever times you want to call us, you can call us for the breastfeeding. One of the staff will go even at the midnight to explain regarding the breastfeeding. So this is what we are doing to overcome and to facilitate. This is our strategy, how we can facilitate exclusive breast milk to each and every baby.
Two parts. First of all, the delivery, whatever I attend. What we have found that I have trained my 4 or 5 nurses for one NRC and one KMC. And I go with one of them to all the delivery places where I go. And after the delivery, as Dr. Nitin told, the nurse stays there. The nurse explains the family and the mother about the breastfeeding, KMC, do's and don'ts. And then whenever they are needed, the number is given, helpline number. So on that number they can call. Second thing, we have earmarked few staff of the obstetric hospital. Like from around 10 hospitals which I am going to, 2 staffs from all the hospitals, total 20 staff we have trained, again for NRP and KMC and breastfeeding practices. So there is somebody there whenever, till the time mother stays there, this one support staff is there to explain then about exclusively for feeding and KMC. This is about the places where we go periphery. Second thing now is NICU. And this is a little bit challenging when we want exclusive breast milk, or if the child is sufficiently hemodynamically stable to start KMC on breastfeeding.
For private setup, we visit on second day and third day, and our nurse will go there. They give vaccination also, and they will see that the baby is taking feeding or not. And once the latching and attachment is proper, then only we ask them to go home.
Now I want 100% transparent answer. What is the reality?
The reality, most of the deliveries, they don't call. Or gynecology hospital, they start powder milk. So that is the biggest issue. We ask them, we send sister for sometimes, but the gynecologist feels that for 3 days the milk will not come. Don't feed. That is their answer. So obstetricians also needs to be motivated. They also needs to learn that the initial few drops of colostrum is sufficient enough for the babies, but they don't want to understand this phenomena. That is the issue. Yeah, they must be. Mita Ben and
you can.
Yeah. Parul Ben is also Parul Bhai. Koteda wala sir.
See, the gynecologist, rather every obstetrician, immediately start the breastfeeding. But yes, what you are saying is the myth among the society. Myth is among the lay people. They feel that colostrum is hazardous. Yesterday I was telling that in my talk as well. And quite often they say, we'll have to just throw out that colostrum. Don't feed that colostrum. Especially old, actually the grandmothers, they always tell that. Or they say that there's no need, patient should take rest for some time. But OBGYNs, I will tell you very positively, each and every OBGYN, we are around 40,000, we always promote immediately breastfeeding. Thank you.
Sonal Ben feels that baby keeps on crying and the Kamal goes and explains about exclusive breastfeeding. Within 1 hour, the grandma comes and says, Bena, baby chup karo, and feeding out nathi. So what is answer to that problem? The reality is here. We understand everything here, but the reality... Okay.
Sir, you have opened Pandora's box, we should go ahead with the next, I think.
But as today's lecture, post-lunch session, first online lecture says that first 1,000 seconds are important, where the newborn smells, and that 1,000 seconds we don't miss, then the success ratio and the amount of breast milk will definitely increase. That was the key message of that lecture, I think so.
And to put the baby on breast even after cesarean. Even yesterday only, Sonal Ben, we put the baby on breast for 1 hour. And baby started feeding, then only they sent the baby to the mother.
And in this time...
And we discussed yesterday, there was a slide that newborn's capacity is only 20 ml on day one, stomach capacity. So we don't need to push to give more than 25 ml, 30 ml every too early.
But
so that was the
yeah.
very
And
valid
nowadays
point.
we are also
Yeah.
experiencing that the mother also, due to the social media and the education, sometimes they from themselves they asking after just delivery, after baby, they before call they inform us that this mother needs immediate KMC and on baby on breast. So the time is changing. So we
Yes,
are
yes, agree.
also experiences this.
Yeah, I would like to add, sir. Yeah.
Means the first star is important. First star, that continuously there is advertised on that. That's rather documentaries on that on television as well as radio. And this is the effort of government of Maharashtra. I'm very sure it must be applicable in many other states as well. So it is the first star which is very important, that continuously bombarded on the parturient mother.
I think.
Thank you, sir.
I think.
Yeah, he wants to make
One more comment.
See, the obstetricians are feeding the baby. But the problem is when they say insufficient, they agree with that. That's the problem. That's the problem. Now, we are not blaming the obstetrician, but the mother says insufficient. But everybody should understand the hiccup is nothing but enlarging stomach every day.
Yeah.
The newborn hiccup is, the stomach is going and hitting against the diaphragm. The hiccup comes, when more hiccups, more feeding is needed. In fact, one of my radiology professors used to say that the first day stomach capacity is 0.2% of the birth weight. The next day it becomes 0.5, 0.8, 1.1, 1.4, 1.7, 2% on the seventh day. That is, suppose 2000 gram baby. First day the baby need only 4 ml per feed. That is good enough for the colostrum. So the problem starts in the second day in the obstetrician ward. Because many mothers complaining that my feed is not adequate, baby is crying, then they switch over to something. That's the point I want.
Yes.
Yeah, I would like to add one small comment. Personal experiences. When I went to Junagadh, 100% of babies were receiving powdered milk. Vaginal delivered and cesarean delivered. One was the privacy issue. And second thing is there was no conviction among these things. Then I asked, in private sector also I found, I asked the obstetrician, why are you not telling the pediatrician that don't prescribe powder milk? He says, it is your subject, how can we interfere? So obstetrician need to be proactive and find out when the pediatricians are not committed enough to tell them.
So let's stop blaming obstetrician.
One more.
Let's move ahead.
I think we should move ahead because it can
one
go
more,
on
one
and
more
on.
comment. My sister is a gynecologist, and she would call me for the calls whenever the relatives are there. Her relatives are admitted, so she doesn't have to pay from my side. So, so now after I want to immediately put the baby on the chest and start breastfeeding. The another advantage, mother would say, in the second delivery, they would say, "Apna bhai nathi aaya aa vakte?" Because then I was in Bhavnagar. So then, because they said, ki, we like it that we are the first person to see my baby's face. Otherwise, the baby's cord is cut, dried, given to the relatives. They all see mother only listening to the cry. So this is also another thing.
Okay.
Yes.
Okay, I think we will move on because Parag Bhai is looking at me with the watch. So Manish, Dr. Manish is with us. I have a very question for you. How can we enhance KMC coverage on babies who are on CPAP and with the invasive lines, since you are practicing a lot of intensive care babies?
Yes, first of all, we need to educate and our staff in NICU staff, because baby, if is on CPAP or in any support, respiratory support or lines, those are not the contraindication. And KMC, we have to educate the staff that it is not any complicated procedure. It is as simple as we are putting the baby on weighing scale. So the sepsis or sick baby, the lines, all are illogical things. So it is very easy, and we have to make sure that our staff is educated for that in day-to-day rounds. Okay, this is very simple, and we can offer KMC, and also the benefits also we need to explain to the staff. So it is very easy.
I have a practical way. Do you use KMC while umbilical lines are there?
Yes, it is very well. Yes, if, lines are there, but we have to just we have to just check. It is not any the fix.
Sorry.
We had published a paper on KMC with CPAP. Just a moment.
Dr. Parag also wants to contribute.
Parag, bhai, ek minute. We had a paper published on KMC with CPAP lines.
Right.
So we found it feasible. Only thing, mother will be inside the NICU. So the pediatrician should not object to that. fear of infection.
Yes, but
Otherwise, it is possible. That is the main objection.
Most of the times when you are going to put a line, you know that this baby is going to need a line, so you can keep the cord little longer. Try with a 5 centimeter cord, dry it immediately, and before it dries, keep it flexed. So after coming from the umbilicus, it's curved, and in that case, KMC is possible without any intervention. I mean, it's very easy. I would have shown a video also otherwise. But that's one
But
separate
I will tell you,
innovation.
there is a genuine fear of dislodgement. Because if you have a dislodged UAC, baby will bleed like anything, as we all know that.
What we do is we counter fix the line. From coming out, it will be fixed again at the leg, so that any stretching will happen only at the distant dressing. This thing will not be disturbed.
And I think this will be a point of discussion when we
Basically, bottom line is that there is a huge learning curve. From the first day, you can't put babies with lines and CPAP on the breast. Important part would be to make sure that which baby needs which care. If I have got a very sick baby with high ventilator setting and all kind of support going on, I will not put that baby in the KMC to begin with. Baby has to be stabilized, and your staff has to be around. If at all something goes wrong, he need to do whatever intervention is required immediately. Otherwise, that will break the confidence of the parents in you. That you are offering a therapy where the complications are expected, and which we are not bound to do that. Yeah, it's a learning curve, that's what I'm saying. So, absolutely, they are peripheral lines.
But, ma'am, still I think it's okay to do with the peripheral PIC lines.
Yeah.
But I think umbilical line, it will be little hesitant.
You'll be
Umbilical
careful
line,
about
will
it.
be very-
Absolutely, absolutely.
So we should move on to next question. Sorry, ma'am. Manan, since you have done a lot of projects, I would ask you this technical question. How do you conduct QI project to improve quality in kangaroo mother care? Since we had a workshop also on QI, so I think we should know about. We should all know about this.
So the first of all thing starts from administration. There has to be an administration will for doing that, and KMC has sufficient evidence to start a QI project. Now for every QI project, you need to understand your indicator. Like as Dr. Ashish Mehta sir said, that from day one you cannot start KMC with umbilical line and ventilated babies. So suppose if my QI indicator is what is the baseline KMC my babies are receiving right now, and I want to give KMC of let's say 6 hours a day. So this is start with some basic quality indicator. This is the first thing, that for your staff and your ICU you are doing this thing.
Okay.
Second thing, now evaluate the strategy. Like if I have decided 6 hours, now review your current practice, that right now how many patients are getting KMC, and how many patients are getting how many hours of KMC. Like when we started, my average patient was receiving only 1.8 hour per day KMC, and we set the target of 6 hours per day. So this is one indicator that we have to set. Then when you review your strategy, there will be challenges. Like challenges at the front of policy making, at the front of place, and at the front of the people, and at the front of the procedure. So at each and every step you note down, like all QI project PDSA chart. Like these are the challenges. Like people, we have to start with a team. So this is the team, one nurse, one doctor, 3 staff. They are dedicated for this work, and then train them and make a video that this is how we will do, and this train mothers and relative according to that video. Second thing, the place. Like as NICU in private sector, nowadays there are a lot of space available, and we dedicate few beds like this. These are the beds where we will give KMC and where we will keep the babies who are receiving KMC. Like in our hospital till now we are giving KMC with HFNC. Above that, like on ventilator and umbilical, and till date we are not doing that. But now staff is confident to give KMC with HFNC and invasive respiratory support. So earmark few beds, that these are the patient and these are the beds where we will give KMC. The third thing is the policy. Have a written policy. That these are the things, these are our patient. Less than 1.8 kg we will give KMC. Less than 1 inotrope, less than 2 inotrope we will give KMC. Less than ventilator support we will give KMC. So your unit policy, then review that policy. Second thing, ask your staff to record. Then my patient today received 4 hours of KMC, my patient today received 4 hours of 6 hours of KMC, and then at the stipulated time period like 6 months, you review all the patient from where you started and then where you have reached. And that depending upon that, again your PDSA cycle goes and go into phase of implementation according to your experience and analysis.
I think, thank you. That is very well explained, Manan. Thank you very much. Next question, sir, Dr. Goel, sir. We have heard in last 2 days that there are a lot of people, but I will ask you, when sometime it happens, mother is not able to perform KMC. So how can we encourage other people, or who else can perform KMC, and how do you encourage other people in the members? So if you can.
Well, it is obvious from these 2 days, 3 days discussion that anyone can do the KMC. And the other benefit is when the other people give, mother would get the rest. And mother can give, of course, father, their sisters on both the sides, parents of the mother on both the sides, and younger siblings who are more than 12 to 15 years of age. Earlier, community volunteers, older people, senior citizens were free time. They were reported from Europe and USA.
You want to add?
But after the COVID, of course, it is not happening or cannot happen. And
I think
example of other mother is the most used method and useful method. Photographs. When one father sees other fathers giving KMC, then he is also motivated. Of course, we have to educate that it can be done, it is safe, and it is your family's babies. All the family members have to be committed, because otherwise, and family knows, otherwise it is another cycle of 9 months of pregnancy and stress for the family and the careful looking after the mother.
Dr. Somsekhar sir wants to ask a question.
Counseling sessions.
So this is other than mother who can give KMC. Will you, because it says community volunteers reported, and I have been asked this question by a father, ki why don't you hire someone to give KMC, we'll pay for it. So what is the panel's opinion?
I think in the COVID era, the skin to skin
surrogate
contact.
KMC provider is the well-known concept.
Now I see some money in KMC now. Not at all. I don't encourage this kind of the volunteers for the KMC. I personally strongly suggest it's not the business. It is more of emotional things, and so many things goes along with that. One should, you are right, but I'll discourage the practice.
Nowadays, that infection risk is real strong.
Okay, so we will move on actually to the next question, because we have only 5 minutes left. So, Kamal sir, how do you perform KMC counseling? Because we have said that throughout all the discussion, we have a counseling is a main part of covering quality, improving quality. So, can you highlight?
Yeah, once I come first time to the mother or family, I see it's a love warmth you are giving it to the baby. Don't consider it as a physical therapy. And once you see that your baby is in discomfort, how much love you give to the baby, with that intention you go. And baby will have all the benefits of weight gain, infection, no infection, taking feeding early, discharge early from NICU. But if you are motivated, if I motivate the mother, I also motivate other nurses, and that nurses will educate the mother. And other nurses which are or mother which are in the NIC, they teach the new moms that, see, we are giving KMC to my baby and my baby is gaining weight, and then they will adapt KMC and they will have less pain and no discomfort. That's the way we motivate the mother for KMC.
So I think you are, as we have been discussing, creating more and more champions. That's
Champions.
the way forward towards,
I think the last point is very important, what he is saying.
So, Madam, recommend.
First of all, we have to get convinced.
Yes, ma'am.
And we got convinced because we studied on it.
Yes.
And now we have got many, many studies to say that it is really helpful. Now, number 2 of his, that whether I can employ somebody. In Bogota, we had gone for training for 3 weeks, and we were supposed to keep, including Dr. Anil Narang, we were supposed to keep baby in skin-to-skin contact, somebody's baby, and after 2 hours, we were asked, how did you feel? And somebody's child also, I felt so nice. For me, it is not all 5 senses are satisfied. For mother, for father, for mama, mami, your patient said that mama, mami, dada, dadi, everybody had kept. So for them, it is their own child. And you, all five senses are satisfied. Touch, then smell, then hearing, all that is satisfied. So in that case, it really helps you in growing as well as it, then nobody wants to give the child to somebody else. Actually, in small baby, nobody would like to give that.
And I think that was highlighted in public awareness meeting by the mothers who visited here on Thursday.
So before we wind up, one quick message from each panelist about this KMC in private practice. My whole, I will say, the contention of this discussion is why private practice has been separated from the public practice as far as KMC is given.
Well, my message to everyone is KMC karke to dekho. The second one is KMC for all the newborn, not to limited to a low birth weight, but to every newborn.
Everybody said here, but I just want to say in the terms of NICU practice that as a doctor we have to start writing orders KMC 6 hours, KMC 7 hours, KMC, and we have to tell our staff that this is my order, you have to follow it. And second thing, make your team and review your records of KMC given to the baby.
We should teach more and more nurses, and what Manan said, we should write down how much hours it was given yesterday and today. It has minimum should be 6 hours, so till not achieved, we should target it at least.
What we practice in our unit, like the other gadgets also, like we use iPad also. We are not only teaching in lectures, but for pictures with baby. Mother can see the iPad, sister can show her the benefits and procedure of KMC, and we just encouraging all mothers to see the during rounds also get to see that, so they motivated for same educate and educate.
I have one message sir, yes sir.
Mother should be, while giving KMC, there should be, we were keeping audio-visual entertainment. They would usually see some movies or this thing. And nowadays, mothers 17 to 25 years of age, so they would see, so that entertainment should be available to the mothers. So any serial or this thing. And we should ask the message is, we should ask the mother who has given the KMC. And we should ask those mothers to talk to the doctors, that how they felt. And they will say that we find better, then the doctor will be encouraged to do it in more ways.
Message only.
Message, let the mother who has given the KMC talk to the doctor. Because that, to the doctor, other mothers of course, but doctor should be convinced.
Message is only what Rekha ma'am said, believe in KMC, rest all is done by itself.
Yes, so public or private, KMC is KMC.
Yes.
That's the message. Yeah.
I think before we wind up, I want to ask just Dr. Nitin Trivedi, he is doing some procedures in KMC as well. So sir, this last question I will take.
Well, all the newborns who are in NICU, we have started giving vaccination and doing all heel prick methods or blood sugars whenever they are in KMC. And the second thing, now what we are planning to do after this conference is to create a KMC desk, and simultaneously even the normal newborn who are coming for the vaccinations, ask them to sit in first for the KMC. Once they start feeling better, then vaccinate. That should be the strategy.
Thank you.
Yeah, of course, breastfeeding while vaccination.
Okay, thank you all the panelists. Thank you very much.
Thank you for enlightening us regarding so many doubts which we had in our day-to-day practice. Now for the next session, I would like to invite on stage moderator Dr. Haresh Doshi sir. Yeah, I will read them.
Civil do that. Civil do that.
I would like to invite on stage panel members Dr. Sonal Kotdawala, India. Dr. Ashma Rana, Nepal, Dr. Milind Shah, and Dr. Nehal Patel, ma'am.
And Dr. Mita Adroja.
And Dr. Meeta Adroja, ma'am.
Please come. 5 तो है ना? Yes. है ना 5? खुश. बैठो. यहाँ दिखता है. बैठो आ जाओ. क्या छे यानी? यानी आवाज. I will stand there. Will I introduce you? You are going to introduce these people, no? So there is some problem in, okay, no issue. I will introduce in brief all my panelists. Normally the obstetrician comes first and then pediatrician. Here the pediatrician panel discussion was first and now it is going reverse. Well, it is important. Yeah. Ladies and gentlemen, I must thank Madam Dr. Sashivani for inviting me to moderate this panel discussion. And as I told, obstetrician role is, though limited, is very important. I will start with my panelists from the left side. Dr. Ashma Rana, she is an international faculty. She is professor and head of the department from Nepal. She has come. She was CEFOC president. She was president of Nepal Obstetric Gynec Society. She was president of Nepal Perinatology Association and chief editor of the Journal of Perinatology. Dr. Sonal Kotdawala, she is a very active member of Ahmedabad Obstetric Gynec Society and more than 3 decades of practicing on both sides of the river, East Ahmedabad and West Ahmedabad, and she has many credits, 30 papers to her credit. Myself and Sonal has a genetic correlation. What I mean is academic genetic, because we are the students of same teacher, PG teacher, Dr. Narendra T. Wani, late and great personality, husband of Madam Sasi Wani. We call it same blood group, Wani group, V group. Dr. Meeta Adroja, again a senior gynecologist, more than 3 decades of practice. East Ahmedabad, West Ahmedabad, 2 private hospitals she runs. Then Dr. Nehal Patel, she could not find the chair in the previous panel discussion. So she was pushed to gynecologist group. She is the head of the department and so many, laurels to her credit. She, executive member of CIAP, AOP Gujarat, joint organizing secretary and organizing secretary of West Zone Pediatric and Neonatology Conference, National AEFI committee member, Young Researcher Awards, State Academic Coordinator. No, I must read, madam. I was impressed. And last, my friend, only male obstetrician, Dr. Milind is an international faculty, again so many, post to his credit, past president of ISOPAP, president of IMA, Secretary General, of Solapur, Asia Oceania Federation of Perinatology, member of Fetal Medicine Committee of AOFOG, president-elect of ISPAT, ex-vice president of FOXY, professor and HOD, head of the department of Gandhi Medical College. Fine, ladies and gentlemen, please feel relaxed. As I told you, obstetrician has a very less role. This first slide. Okay, madam, I have to agree. Madam is like my mother figure. These are my facts, my personal points. Don't go in detail of this. More than 5 decades passed once this was introduced. Kangaroo mother came from Bogota, Colombia. but still the implementers is less than 5%. You know, 5 stakeholders: obstetrician, pediatrician, mother, baby, and any family member, caregiver. 5 organizations now recommends it: WHO, UNICEF, Government of India, Indian Association of Pediatrics, and our Gynec Association. 5 major advantages for premature and low LBW baby. I need not mention, right, from exclusive breastfeeding and growth, further growth, good, right, of the body warmth, no hypothermia, cardiorespiratory development. In short, less morbidity and less mortality. There are 3 components only, but to make it figure 5, I would say 5. Say skin to skin contact, exclusive breastfeeding, timely discharge, and then home KMC and close follow-up. These 2 I have added to make the number 5. We start with ball rolling. First question to Dr. Meeta. KMC is now well proved by evidence-based medicine and recommended by WHO and Government of India and all other organizations. What do you think about the current scenario in our city of Ahmedabad? Meeta Ben.
Very good afternoon to everybody. Our city is a big city and we have a variety of hospitals, like small nursing home like we run. We have private small nursing homes, we have private corporate hospitals, and we have public hospitals. I don't know what is happening in private big corporate hospitals and public hospitals, but scenario in nursing homes like myself, when we deliver a premature baby, before we get free from the mother, pediatrician takes the baby and go away. So, so we don't have any chance to treat any premature baby.
It's very true, very true.
So there is, and after 2 or 3 days when mother gets free and we discharge her, I don't know what pediatrician and mother and baby must be doing. So this is the fact, what we are facing in today's scenario. And though I feel that if we have a chance, we would definitely like to practice this KMC because it saves so many lives. And it is very beneficial to mother, baby, and family.
So it is a joint effort. Naturally, pediatrician has a role that then only you can implement it. Yes, sir. Yes, yes. Okay.
We give term baby in the immediate breastfeeding, immediately.
The point I want to draw is for obstetricians, he has not mentioned, but it is still not all obstetricians are aware of this. We were aware because my teacher and Madam Vani last 10 years was telling us and we are started practicing, but otherwise obstetricians are not much aware of this. What they know? Kangaroo is an animal in Australia. Australia is a nice place to visit, foreign tour. When you took a Australia tour, you should combine New Zealand with Australia. That's it. That's it. So kangaroo mother care is not that right much obstetrician know truly, and that is required to be right change. That part is to be changed.
So sir, from the next time, every Foxy the conference should have one session for KMC.
Good suggestion. Must be. Then only, right, we should start from that. All conferences, workshop, there should be one, at least, right, session, workshop, poster, everything. Okay. Now, this is there. Less than 5% are practicing. Obstetricians are unaware of KMC and their benefits, reluctant to practice. They consider it is a pediatrician's responsibility. Wrong thing. Sonal Ben, it is only a neonatologist to counsel for mother care after birth, or obstetrician facilitate that? What is your opinion?
No, on the contrary, I think obstetricians have a big role to play here. That is what I am doing in my practice, because I am working, practicing at 2 places.
Good.
In all those places where they are socio-economically backward, I always tell them that if you do this, we will avoid admission in neonatal unit, and then you will have, you'll save this much amount of money.
Yes.
Whereas in those cases where the women are really, very educated and all that, if I just inform them that this is the best way possible to improve brain development and they do not have any problems, and you will have that, we usually, when we explain them about anesthesia, we tell them that general spinal is better because you will be the first person to hear your child cry. So same way I explain it to them that you will be the first person to hold your baby, to keep your baby with you. So they really are happy with that. And usually, once we have explained it by 7th or 8th month, they are, on the contrary, they remind our nurse when we have done normal deliveries, they remind them, give the baby to me, madam had told you.
Correct.
Like, if you are busy.
So you,
they'll tell them that madam had
great.
told me that I am going to feed the baby.
You have
So
9 months contact with that patient, and that's why it is very easy to prime them from that time onwards, right? So that at the time of delivery, when the new pediatrician, new doctor comes in, he has no difficulty to implement that.
Your previous question, that also I have tried to tell all my neonatologists, like for each and every delivery neonatologist comes, right? So I tell them that even if like you are taking the baby, at least come to our OT first, like they have taken the baby for the warmth and all that outside. So we tell them that you come, bring the baby first to the mother, show it to her, just let her touch the baby and then you take it. That is
So
what we have already
it is
done.
logical also for this obstetrician to start, and only thing it is a science. We obstetrician now treat the patient preconceptional, folic acid, diabetes control, health control, then they become pregnant. So why not pediatric part starts from the pregnancy, obstetrics, simple, right? Okay. Now this is there. Obstetric must counsel for KMC for 9 months, is in constant touch with the mother and responding and treating for her unborn baby. Every pregnant mother, when she asks to miss my baby, how is my baby is growing well, everything. So at that time I should counsel. It is better and easy to implement if obstetrician facilitates from pregnancy onwards. Dr. Milin, if there is a role of obstetrician, what is the ideal time of counseling? Antenatal, during labor or cesarean section, or after delivery?
Yeah, a very good question. Nowadays, another thing which is very commonly happening in every obstetric unit, could be the private, could be the government, that is of antenatal classes. So I will give you just one example of that sort. For example, my setup. What we had done, we had appointed Rohini. Rohini is a dietitian. We appointed Sumer, who is a physiotherapist, and myself and my staff. What we do, we conduct one class in first, second, and third trimester, whereby we tell them about all these things. And the third trimester, we'll tell them about the kangaroo mother care as well. Not only that, we all tell our obstetricians, which is commonly happening as well now. Immediately after baby comes out, the baby is put directly to the breast of the baby, so that to the mother, so that that from that process itself the KMC starts. Regarding the showing the baby, what Sonal told is very true. It's media has changed our obstetric practice. Now the childbirth is celebration. So every patient, every couple wants to have a reel for that delivery process. And in that, one of the important photography is showing that baby to the mother. So which always gives a promotion to not only mother, but also to the obstetricians. So all that is acting so effectively nowadays that this bonding is increasing. Yes, but as we discussed in the previous, the discussion, the myths, there are still myths. The old wives' stories need to be dispelled very effectively. And that's why the public awareness is important. But this process starts from the antenatal period itself and of course continues during or the after delivery.
You assign it to your dietitian or physiotherapist, or you yourself do it?
No, they tell the dietitian's role, they tell the physiotherapist's role, and we tell them about the other care in the pregnancy.
Got it. Yes, Dr. Nehal, madam.
Sir, one comment
Yes.
Sir has a good team. Sir is there. Madam is also counseling in the prenatal. So one thing, I have observed that Maharashtra is having very good setup, that one-to-one counselor to each and every obstetrician with the lactation counselors.
Right.
I'm trying to develop it in the Gujarat also. I am a certified, international board certified lactation consultant.
Correct.
And I try to develop this, but still I'm not getting into it. So now I'm going to contact both of you for the same.
Yeah, your question, madam.
There are online courses for the, this certified courses on the counseling also, as well as lactation by Symbiosis Pune. So whoever wants to avail that, no need to travel also to Pune, but you can avail that certification or ask your staff to get those certification. That motivates them because they become certified counselor, and it becomes very easy for the research also. For all our research studies, they require that position in the hospital to incorporate. Even ethics committee asks for it. So all that can be done effectively, very true.
Dr. Nihal, what according to you is the biggest challenging convincing obstetrician for KMC? And in your practice, how many obstetrician? Tough question.
Sir, actually, the hospital I work is a medical college. And in a medical college, I am fortunate to have both the HODs very nice.
Great.
So what I think, if I go with the boxer gloves in my hand,
Yes.
that you are doing this and I am doing this, he is going to give me again the box
Yes,
hand
yes,
also.
yes.
Okay, but I am going with a flower.
Yes.
So I am also receiving flowers. So they are giving me a free hand
So-
that yes, you can do. But the only thing in the government hospital is you use your HR.
Okay.
Don't ask me to provide my HR. So that is what the concern. But yes, we are able to do.
Your story is different. I don't think the pediatrician sitting here will be have that. They have challenges. They have challenges from obstetricians also, right? So, okay, we go to next question. Sonal Ben, what are
Okay, I'll forget it. I'll just talk on the context.
I'm sorry.
Never mind.
What are the advantages to obstetricians from KMC?
Actually, the obstetricians have a lot of advantages because, if the baby is put to KMC, then half her burden is gone. The baby becomes sick, mother becomes relieved, and she will see he will find a smiley mother, and also the baby will be active, happy, and will be gaining weight, and that is the advantage to obstetrician. But I wanted to add something from the first session. Actually, we talked so great, but nowadays, like institutional deliveries in the institution, it is only the resident in first year, not even second year resident, who receive the baby. Most of the time, it is only sisters who receive the baby. Neonatologists are never seen in the premises, or they will only
Situations are different in different setup. In our setup, only residents does it, as well as neonatologists are called for all deliveries, and we have that respectful maternity care, right? White ribbon, and also Lux approach by Government of India. So kangaroo mother care should be implemented or introduced, involved in that. That type of is there. You are right. In a busy setup, busy medical college hospitals, the nurses may be conducting the deliveries.
And other thing is that when we want that KMC should be fruitful, like
Yes.
I think we never have this system. I don't know about yours, that you see the patient with the husband together, like that during antenatal care, in normal hospital. Okay, we never see the women, the mother, and along with the father is never there. We only have female patient, male are not allowed inside. This is the routine practice in the obstetric setup. In the C institution also.
Privacy, yes, naturally.
Privacy is not there, and we cannot involve the husband right from the beginning.
Because other patients are there, yes.
Yes, and also about that KMC, we cannot explain to the husband because we have never teamed husband and wife together when we are doing antenatal care. We only look after.
We must, rather we should start that. That is there. The point is there that antenatal period and even family member, even husband should be involved.
And one another thing is, nowadays most of the husbands are going for work outside the country, and she's the only one. Now, when people are coming for father kangaroo mother care, father kangaroo care, it's not there because in Nepal I've seen this trend presently.
Yes.
Most of they are all alone. We never get to talk.
Yes,
also.
fine.
This is a reality.
Sonal Ben, what are the practical challenges during cesarean section in implementing KMC in private practice, and how to overcome that? But you are champion, you are KMC champion, so you will not have much problem. But otherwise, we all have problems, yes?
No, not champion, but we have been doing KMC, and at least immediate giving it to the breast of the mother.
Yes.
But what I have seen these days is, on the contrary, our normal deliveries patients are really exhausted. They are not willing for that. On the contrary, cesarean patients are happy. And our anesthetist role is very important in this. That's what I feel.
Yes.
Because my anesthetist, she immediately puts that screen and we bring the baby baby over there.
Okay.
I think Dr. Kamal said right now that he was there before 2 days only. So that is good. But let me tell you, when we are giving general anesthesia, I think that is a problem.
Yes.
Because and sometimes, lots of painkillers are given. Sometimes spinal effect has not come and they've given immediate general anesthesia, or they've given ketamine or something. At the time when that baby is not very strong and it's not going to suckle immediately, these are the problems of cesarean.
What do you think? The upper part of the patient's body, we are not painting, draping, breast, and then you put the baby on the breast.
That is not a problem.
Infection.
No, see, in our hospital, all mothers, once the sister is giving them feeding, they just wipe it with saline and then give it. That's what
Baby is
they're beginning.
sterile. That's why there is
Baby
no
is sterile. No,
much
but mother's
risk of
breast-
infection.
mother's
We are
breast
worried of that. During surgery, we are involved in that, bleeding, suturing the uterus, and then infection. Two major complications of cesarean section.
In fact, we give only
Yes,
saline
but
because
now that should be changed, that attitude, that thinking, because it's a sterile baby. So you can very well put it without the painting, draping of the breast.
Not
You
about
can
the
put
baby.
it.
What we feel is that, like when we say that why vaginal delivery is better, because there are lots of steroids which go to the blood, but that is good for the baby. Same way we say that the amniotic fluid and the colostrum, they have the same smell and the flora is same. So baby is on the contrary getting a good flora when it is directly latched on the mother's breast. So I feel that is better. One more point.
Yes.
Like immediately after delivery, when we give it to the mother, like mother is already shifted to the room. At that time, sometimes they complain of pain because they are coming out of spinal anesthesia.
Yes.
So at that time, we usually advise that somebody holds the baby horizontally
Don't give
on the
strong
mother
sedation.
instead of giving the vertical
Okay.
position. That helps.
Can I take 5 minutes more? Somewhat fast. Okay. No, sorry. This is the question for the audience. The right answer will get the good prize. First prize is visit to Australia. No, it is a Cadbury. Definitely Cadbury is there. Size of the newborn kangaroo baby. Joy is the name of the newborn kangaroo. 1 centimeter, 1 inch, half foot, 1 foot, 1.5 feet, 2 feet. Right answer will get the B. A. B. Okay. Sir, B, sir, and madam gets B is the correct answer. 1 inch is the answer. Sir and madam 2. I will give you Cadbury, sir. Time is there. I will give you. I will not. Okay. KMC in cesarean section already discussed, right? KMC no infection, baby is sterile. Very well. Advantages to the mother by KMC, right? Mita Ben.
Well, my mother is quite.
Madam Asma has told, but you can repeat, yes.
Yeah, mother, first of all, bonding between mother and baby is very much established, and mother gets satisfaction. Early breastfeeding is
very good.
And
not early, also prolonged breastfeeding will be there. That is good. Amount also.
Successful breast
correct.
feeding
So
is established. And skin flora from the mother gets transferred to the baby, so baby is getting a protective good bacteria.
Yes. So all this you know very well. Mother advantages.
So one more advantage.
Is there any disadvantage? Yes, madam.
One more advantage.
Advantage.
Yes. The Canadian group has studied, and there is established fact that there are 30% less postpartum depression in the mother.
Psychological, and lots of breastfeeding advantages we know as such. So breastfeeding is increased. Yes. So all these are there. Breastfeeding advantages normally BFHS, we know all advantages to the mother. Undergraduate question. Is there any disadvantage?
Sir, 1 minute. About obstetrician's role, let me tell you, I tell my patients about that also. When they go for they are discharging, at that time we ask them about postnatal exercises. There I always explain it to them that breastfeed your baby as much as you can, and for longer time, then you will have a flat stomach earlier than others.
And no need to use contraception, no early pregnancy. Many advantages, many. Any disadvantage? Mita Ben.
Well, I don't see any disadvantage unless the mother is having...
Perfect answer. Some other babies may be there at home that should be taken care of by other family members. Milin, father KMC.
Yeah.
You are the only father.
Yes. Yeah, it has created a major difference in the clinical practice nowadays. Yes, very true. That previously we used to call it KFC, but I learned from Dr. Vani that we don't call it the KFC now. It is the father KMC. And now, yes, we incorporate that in the clinical practice because, see, all said and done, the motherhood is a rich experience for the mothers. And then they always, in literature, in the cinema, and everywhere, it is explained so much. And the husbands who are taking responsibility of everything otherwise feels that way that nothing is coming to his credit. So we tell the father to take the baby for the father KMC, and it makes a major difference. It creates a lot of bonding, responsibility, and the family involvement in the upbringing of the baby, which is a great advantage we find. Yeah.
Point. Question. WHO recent guidelines.
Yes,
We
so
can read it. We can read it.
WHO recently they came up with the IKMC and they told that the requirement is now MNICU, and with the immediate KMC there is 30% less mortality in the preterm. So everybody should come with this concept only, that each and every baby, especially the stable preterm babies, they should receive the IKMC.
So thank you very much, all ladies and gentlemen, panelists. Key message is, we all should practice KMC. We can practice KMC. We all will practice KMC.
Hello, ma'am.
We require more KMC champions in obstetrics. And madam, आपके लिए, Sasi madam, आपके लिए, right? Please engage this big boss like pulse polio vaccine. ये भी आपको help कर सकता है KMC में. पहले इस्तेमाल करें, as Nitin told, फिर विश्वास करें. Thank you very much, ladies and gentlemen.
Thank you, Harish sir, for a very vibrant session, and sorry for rushing you so much. I would like to invite all the nurses for... Yeah. Please, all the nurses, I would request them to come over here for a photograph.
I don't know. आधा ही डाला है, आधा सोच.
Okay, while the photograph is taken, may I invite the rest of the panel members to please come up on the stage? Oh, no. Please change that. Sir, just change that, sir. Sir, change that. Change that to the slide. Okay. We have our panelists, Rekha Samant, who is, Rekha Samant and Marianne. We are the moderators, and on the panel we have Selvi, who is a senior nurse from St. John's Medical College, NICU. Then we have Sneha. Thank you, Selvi. We have Sneha, a senior nurse from KEM, NICU. Thank you. We have Shashila, who is a sister in charge of Apple Children's Hospital. Thank you. We next have Princey, lecturer, or I don't know what your assistant professor from the College of Nursing, Karamsad. And then we have Ravina, who's also assistant professor from the College of Nursing, Karamsad. Thank you. We will be speaking about quality KMC, and I think you all have already been bored with how KMC was initially started for stable babies and recommended for stable babies in health facilities. It's moved to stable babies at homes. Also, we've got documented evidence about its benefit, and now we also have evidence of our IKMC for
sick babies. What do we understand by quality KMC?
Good afternoon, everybody. First of all, I would like to thanks to Madam Shashivani that they has given such opportunity. So now we are going to talk about the quality of KMC. So what is the KMC quality? KMC quality means implementation of KMC, which has a safe, effective, then patient central, and timely, effective, efficient, and equitable. So now we are going to ask some questions to panelists. So in this picture you can see the KMC duration, that is timely, near the patient, that is patient center, and it is safe also. Everything, whatever 6 dimensions are there for the KMC, it is in that picture, you can make out that also. So we are going to start. Question first. Right. Is quality KMC important? Why? And what do you think are the biggest challenges for providing the quality KMC? So Sister Sneha has to give the answer me. Please, Sneha.
Good afternoon, one and all. Yes, quality KMC is definitely important. By giving quality KMC, it maximize the maximize the benefits of KMC to baby, mother, family, and community. By these benefits, reduces the risk of hypoglycemia, hypothermia, apnea, and infection, sepsis, and mortality. This also increases the height, weight, head circumference of the baby achieved in achieved baby in intrauterine life.
Okay, so you want to add anything?
What do you think the biggest challenges are in providing this quality KMC, Sneha?
Sneha, what are the challenges for that?
It might be the healthcare workers itself.
Yeah.
I mean, we've seen it. Might be the doctors or the nurses themselves. Anybody else would want to answer from the panel?
Hello.
Yes.
Good evening. First of all, I would like to thank Shashivani ma'am for providing this platform, this prestigious platform. We have been hearing from 2 days so many speakers from various countries regarding various researchers on KMC. So I think almost all the things have been heard, but when we come to the real scenario where the nurses are dealing with the patients in the postnatal wards or in the NICU, in the labor room, so they play a very critical role with the care of the patients. And there are a lot of challenges which also comes there when it's about KMC. Even if she wants to give KMC, she has a lot of other things like some barriers we can say, like the work shift where she needs to also handle about some other patients. And the other thing which is a main barrier is the lack of privacy. And this is actually it is not seen in areas where there are KMC units, obviously. So everything will be provided in a KMC unit. Basically, the first priority is given for privacy there. But when it comes to a postnatal ward where you have at least 15 patients there, along with a nurse's unit, along with a family member, sometimes a male family member is also there, maybe a the father. So it becomes very challenging situation for the nurse to tell the patient, the mother, to give the KMC effectively. Even if it is told, even if it is demonstrated to her step by step, she feels it inconvenient to do it properly in front of everyone. So that is a very big challenge. And there I feel that, which is actually connected with my question again, motivation is needed, which should be constantly given to the mothers through the healthcare providers, especially the nurses. So there again, when we talk about constant motivation, the nurse's role is important there, and that can be done by capacity building
things where the nurses should be taught about how to give the KMC, how the KMC can be given in a prolonged duration, how the mother should be brought into confidence, which is actually very important. And again, family members' role here, which is again a challenging situation for the nurse to make the family members understand the importance of KMC and to make it prolonged, not only in the institutional setup, but also in the family setup. So I feel these are some of the challenges. Apart from that, there are many other challenges.
So we need continuous meetings for the families for important of KMC.
Thank
for
you.
the family members.
Yeah, thank you very much, Sneha, as well as Princey. We'll move to the next question, question 2, which I will direct to Selvi. How do you think KMC will affect your workload as a staff nurse? And also, what steps can you take as a nurse to improve the quality of KMC?
Good afternoon to everyone. First of all, I would like to say thank you to my ma'am, Dr. Suman Rao, my HOD, and inviting me, Dr. Shivani, to be a part of this, member of this, to participate in this. How do you think KMC will affect your workload is, first is, for, as a behalf of nurses, I'm talking in the practical scenario. Poor nurse-patient ratio is the first one point I would like to say. And then next, dedicated KMC nurses are not available. That means they needed training. Sure. And then lack of awareness, lack of training, and there is no the proper clear-cut guidelines in each hospital setup, institutes, wherever it is. So these are the points I would like to say. And how to, the steps, what we can take as a nurse to improve the qualities. First thing, we need a counseling and education, motivation to the healthcare worker, first of all. And then we would like to increase the number of nurses and training and see the maternal concern, which mother can able to come and give to the NICU setup as a things. And when the mother is not possible and that particular place, father also involved in for the KMC and the other family members also involved. We have to motivate, counsel and educate them.
Okay. Thank you very much for that. But one point we would like to definitely bring out is probably even, I mean, we've heard this from day one. Everybody thinks it's extra workload for the nurse, etc. But we do have definite evidence of the thought, the feeling, and our behavior. So if we change the thought process and probably say, mothers can take care of the baby and monitor the baby, my workload will not be less. So I automatically tend to feel less stressed. And in which case, I will teach and assist mothers to provide KMC. So that could be one way that we could definitely help in our own selves. I've used the word gates to get updated as nurses and upskilled, advocate for policy change and facilities, teach mothers and surrogates, which Selvi has definitely mentioned, evaluate the KMC quality. How many hours are we providing per day and support from doctors? Definitely nurses would require the support from doctors as well as the managers in the healthcare facility. Thank you.
So, what support do you need as a nurse to improve the quality of KMC? Ravina? Acha, Princey, then Ravina already has done. So, Princey, can you explain that?
The mains, I think the last discussion which was done by panelists of obstetricians and pediatricians, so which they have described and they have told ki obstetrician comes from first, pediatrician comes first. But when we are in a labor room, also there is a nurse, like she's also there, I mean. But what I want to say that there should be a collaborative approach between the doctors, the nurses. Because once the baby is delivered, like one of the madam has told that the baby is given to the pediatricians. There itself, the stoppage of the nurses come. The nurse is actually out of the scene. She can't do anything there. So if there is a chance that the obstetrician is giving a chance, like the baby is directly after delivery of the baby, directly the baby is put on the mother's stomach, and the baby is allowed to crawl to the breast. So the nurse can assist that. So that is a support from doctors for improving the KMC at the first site itself. So this is one thing. Apart from that, once the mother goes to the postnatal ward, there are various research studies which I even had shown that they have done in PDSA cycles that they should, when the doctors come for rounds, like when the obstetricians come for round, they can give a prescription of KMC, that this much duration KMC should be done, and that should be in front of the nurse who is taking care of that particular patient. Because sometimes what happens, the doctor comes and they go away, and when the nurse comes and tells the patient that you need to perform or you need to do this KMC for a duration of at least, let's say at least for 1 hour, when we say, they will say that why should I do, this is not prescribed by the doctor. So when this is in front of the doctors, the nurses are also taken in confidence there, and the patient also knows that they need to do it because it is being told by the doctor. Because ultimately in Indian setup, the thing is that the patients give priority to what doctors advise, and they give their ears are very much open to the instructions which are given by the doctors. So this KMC duration should be prescribed. When it is prescribed by the doctors, it is known to the nurses, and then there should be a sheet, a KMC sheet, which should be attached to the a chart, we can say, like which describes the duration of how much the KMC has been done. And even there are studies which has shown that how much KMC duration has affected the weight of the child. So this can be done, and this can be done by the nurses once it has been prescribed by the doctors.
Okay. So one more thing I want to add you, that whenever mothers we are keeping the babies for KMC, that time mothers have to give these some facilities. First is there a reclining chair, because she has to take the rest, she can sleep easily. Second thing, that whichever we are keeping that reclining chair, that place should be well ventilated. It should be, that mother should be thinking that this is a homely environment, so it should be lighted, means dim light. Soft music.
That is what I wanted to say, that the mother is always comfortable once she comes to her home.
Yeah.
And that is also, she is comfortable when she comes to her own home. So we need to create a setup in the hospital which is actually a setup where the mother feels comfortable like her home.
Yeah, like
so
that only.
There actually the members, the healthcare, even we know that the healthcare can be optimally given to the patient when we are actually collaboratively, as a team approach when we are doing. So this is only possible when we have a collaborative approach between doctors, nurses.
Yeah, again, but that is a developmental supporting here. There are just some things that we have, a dim light should be there for the babies. So we can put that homely environment we can prepare. Okay, and for the mother's rest, because she can't keep the baby continuously, that's why we want to change some other alternative, or the attendant should be there, that they have to take the bath and they have to come, so mother can take the rest for that. So we have to educate full family. Before KMC, we have to educate full families, they can support, and we can improve our quality KMC.
Actually, in our hospital, in Sri Krishna Hospital, we are practicing that. We have a KMC unit where the nurses are educated and they support the families, they educate the family members. And as us, if the mother is tired, like maybe because of cesarean section or like that, the fathers take a role, or the maybe other grandmothers, they used to take the role.
Sure, thank you. We have the next question, just might be 5 minutes more. Will quality of KMC be affected by mothers and family members? And if based on how family members and mothers feel? Ravina, can you please answer this question?
Sure.
And how could this be improved?
Okay. Good afternoon, one and all. I thank Shashivani ma'am for providing me this opportunity. I would like to talk about the quality of KMC and how it affected and how the family member feel. First of all, there is obviously a gap of KMC only because there is a gap in the counseling. So I believe that this thing could be improved. This challenge of how mothers and family members could feel could be improved by appropriate counseling practices. So I believe that first thing that should be done is simply call mother and family member, and then just not start with the KMC counseling, but first thing that should be done is greet them
first tell them the purpose, that what is the purpose of the meeting, and then after start asking questions that how they are feeling. And then you can initiate with the questions, like first ask that what are their concerns, what they feel about KMC, and then initiate. First, make sure that the family members and the mothers gets the reassurance, and if there is a need, nurses should definitely record all the points, so that if there is any problem that the nurses are identifying, then they could give information about it. So that should be done. And then later thing is, obviously as a nurses, it is important to consider the listening, because nurses should use the language which family members and the mothers understand. Because if they are counseling and if family members are not understanding, then again it is a problem. So that would arise a problem. So I think that is very much important to consider a good listening practice. Wherever possible, use a touch and make a gesture, like nodding could be helpful. So that should be done. And instead of asking questions directly, the nurses should ask the question that restate what I have just provided the information, so that the nurses could understand that where re-information should be provided. So that should be done. And at the end, check the level of understanding of the mother and the family. So that should be done. That way we could improve the quality of KMC. And obviously the advocacy is important. In there, we could understand, we could check the social support and emotional support and provide the confidence to the mother and the family member. And praising is very much required, because we could able to identify that mother would feel that what she would get a reassurance that whatever that she is doing is beneficial for the baby. And if it is good, then obviously by praising she would be motivated more to do it more often. And obviously the support from the staff, peers and the family member is required wherever it is essential.
So how do you as a nurse support a mother, family members to improve the KMC quality, especially while feeding? Sushila?
Yes, ma'am. Good afternoon, and thank you to my dear Dr. Parag Dagli to invite me on this stage. I want to say that how do you as a nurse support to a mother? First, mother, when mother comes in NICU, that time we make comfort. First, we have to comfort to mother, to talk, greet. First, we greet the mother and make her comfort to sit and sit on the KMC or chair, wherever, because that time mother will not able to stand up, or so that we make her sit and to advise her if baby is sick or can't feed, then we ask for mother to express the breastfeed, and we make her learn to how to express the milk. And about the KMC, continue KMC and expressing breast milk, how to continue the KMC. In KMC, how to express the milk. And educated, if mother says that not comes in milk, then we educate mother and advise her to take diet, fluid, what fluid she can take, how much, and then using other mother's milk. If mother is surrogate, then surrogate mother can give KMC and give KMC and milk bank. We can advise mother to milk bank and support. And about the mother's awareness, we are provide support group, and we are using one word about this all, GALPAC. So much.
Okay.
Thank you, ma'am.
So if the mother is sick,
One minute. Conduct in-hospital adaptation session regularly. This is also necessary for that.
Okay, thank you. And for the first,
I
what
would
about
like to
colostrum?
I would like to add one point in that. The last one, which is the support group, that is the GalPAC. So this is actually a very effective way of communication, and that needs to be done step by step when we are communicating with a postnatal mother or a mother, especially where in case of primary mothers, where they are new to the situation, they are first time handling the baby. This method of communication, where first greeting the patient and then asking her like how she is feeling, how she is with the baby, what are the current emotional things which are going inside her, then listening to her, like what are, maybe she may having a lot of emotional turmoil inside. So all this listening capacity of nurse is very important here. Then we should also focus on how it is done. We can describe it. It's like demonstration and re-demonstration by the mother. There may be areas where she may not be able to understand. She should be given opportunities to ask questions and clarify her doubts then and there. She should not be like, simply we should not regret her questions or just give a smile to that. So these questions and this curiosity of mother should be solved. So this can be done by the method.
So
Express colostrum.
that whenever a baby is in KMC, no need to take out the baby from KMC. That is the most important thing. Baby will remain in KMC only, and we have to ask the mother to express the milk. Okay, if the babies are twins and the mother has to express the milk, another caregiver or the another person alternative should be there, and mother has to express the milk. Most important is that the colostrum, where after the birth of the baby, that baby should get the colostrum. Okay, and for that mother is sick, baby can't suck on the breast, that's why we have to express the milk. That is the most important thing for the baby and the mothers while feeding the baby.
Okay, we do have a few more questions, but with respect to the time, we will be stopping over here. And yes, the PPT is there available for those of you who are interested. You can please look at these questions. Thank you very much, each one of you, and thank you for your patience listening.
Now I would like to invite Dr. Parag Dagli sir to give the vote of thanks.
So guys, there comes the end of last 4 days. Well, the work has started almost 1.5 or 2 months back, but last 10 days have been really hectic. I don't know. Sorry. Mic चालू? Hello. So, thanks. No. Yes. Yeah, I would like to call upon stage Dr. Suki, please. So I'll start saying thanks to people. First of all, thanks to Himalaya Baby Care who have supported this entire program at several levels. Besides them, there are several partners of us, namely WHO, USAID, UNICEF, Government of Gujarat. Everybody has helped us to organize this entire event. We had total of 5 workshops, 1 public meeting and this 2 days conference. This entire thing was possible because of so many persons. I probably will not be able to name each and everyone, but I'll try to enumerate at least those who really deserve it. Uh, First of all, I'd like to say thanks to our support staff. I'm sure they are over here. Minesh bhai, please stand up. Please, आगड़ आवी जाओ. Please come ahead. I would request Dr. Vani madam and Dr. Suki to facilitate these guys. These guys have been backbone of this entire event, silently doing each and everything at the speed nobody can understand. Mukesh bhai, he was there for designs. Please come forward. आगड़ आवी जाओ. Prakash bhai, besides photography, he has been helping at several other levels. Anita, Trupti, Avni, please. Then Dhruv, Jagdish, Donald from Apple, he's gone. મુકેશ ભાઈ રાત્રે 12 વાગે ડિઝાઇન માટે ફોન કરીને હેરાન કર્યા છે.
Now, Anita, please. No, I know it.
Okay.
Anita. She has helped us with all the registration and everything. Thank you very much, Anita. Now, where is Trupti?
Trupti ben.
Okay, sir.
Avni ben.
Jagdish bhai.
Jagdish bhai.
Dhruv bhai na.
પ્રકાશ ભાઈ તમે પણ પ્લીઝ લાવ ફોટો પાડી દો.
મુકેશ ભાઈ ક્યાં છો? આવો આવો. તૃપ્તિબેન નથી. આવો તમે ફોટો પાડી. દિનેશ ભાઈ તમે ફોટો પાડી.
પડ્યો બોલ ઝીલવો એવું જે કહેતા હોય છે એકચ્યુઅલી આ લોકોએ કર્યું છે. હા.
Yes, madam, thank you. Yes.
And not only this event, actually these guys have been always there to support in each and every event of Kangaroo Mother Care Foundation.
From the very first meeting, these people are helping us.
Yes.
That is more important.
To an extent, they have come to Orissa, to Chennai, wherever we have gone, they have always been there.
And they have never asked us a single question. કે મેડમ ક્યાં રહેવાનું છે, શું કરવાનું છે, nothing. Really great.
We are really grateful to them. We would also like to thank the nurses from Karamsad, the group who had performed very nicely during the entertainment event, as well as those people have also set an exhibition. You must have seen the exhibition in the room, hall number 3 and 5. I would like to also thank people of AOP Ahmedabad. Dr. Unmesh Upadhyay, I doubt whether anybody of them is over here. Dr. Unmesh Upadhyay, Dr. Mitul Jasani, he has helped in designing of everything very well. Dr. Nirav Benani has been phenomenal in choosing food that you people have enjoyed. Dr. Nehal has been always supportive at multiple levels.
And Nehal, I must say, she has helped us a lot with the UNICEF funding. And within a short time, she was ready to prepare the project with us, everything. Special thanks, Neha.
Dr. Manish and Angelica, Dr. Chiragi, Dr. Shwetalben, these people have been phenomenally arranging those entertainment
Chiragi,
events.
all of you had seen.
And
Today
the
morning
KMC
walk
walk.
also. Last evening entertainment also they had. And all the participants for the entertainment, I must mention.
Every person.
Everybody.
They have been-
Shwetal, she had taken the lead from there. I just told her in Nagpur, Shwetal, can we not do it? Why can't we do it, madam? Immediately she started ringing up, then video here, video there, all that they did. And from many people could not attend our conference, but still just for this cultural evening they had come. All the way from Anand also they came.
Yes.
So that is really specially thanks. And Nitin Bhai's son, he came all the way from Baroda. So all our people had come and they made it like any other.
They were absolutely
professional
performers.
And Parag also supported them, right? Give
Thank
him
you,
a
ma'am.
good hand.
I would also like to thank the MOC team, Dr.
Yes.
Pratna, Dr. Shruti, Dr. Sucheta Ben, Dr. Sonita, Dr. Curie, and Dr. Nischal, who had been there at...
And we had a father-daughter duo. So Dr. Kharod was there.
Yes.
And then mother-daughter for the dance, they were there. So we had so many special things. Right.
Yes. I'd also like to thank Dr. Gadvi. I hope he has just left. He was the GMC counselor for this 2 days conference. He was an obstetrician, so he attended it also. I would like to thank office bearers of AOP Ahmedabad, AOP Gujarat, AOGS, NNF Gujarat, and several other bodies who have pledged to support KMC at next whichever level possible. Would like to thank all the international and national faculties. Some of them have came.
I'll just again repeat, Dr. Sokora, she was the main person instrumental in bringing out this network. And she had, confidence in us that we will do some work. So she entrusted us for 2 years. Because of the pandemic, everything was happening in vitro, virtually. So, naturally then she thought that she will give us a chance to do something personally also. And here I must mention, please I request all our KMC Trust members to rise up. Please. Yes. And unless these people had helped us,
Yes.
this would not have been possible.
This was an entirely a team effort.
Team event.
Each and every person has been standing wherever required. Just
Special thanks, of course, Parag, of course, he is a secretary, he has to do. I won't tell him that way. But Ravi took up the most difficult job.
task. Yes.
For organizing all the transport, accommodation. Not seen anywhere. He did not come on the stage at all, but backstage he organized everything. And a very, very difficult job, but he handled it very well. Ravi, special thanks. And of course, thanks to each one of you. But he had taken a very difficult job for us. We had done something academically, but he has done this. And of course, give a special hand to Parag. In the end, I have to tell him, though he described me as his wife's mother-in-law, but still.
But that's actually fact, madam. I am not saying.
I am
not
mother-in-law.
exaggerating.
I am mother-in-law to many, so I am used to that designation. So don't worry about that. And then I must say another things. Behind the scene, nursing college people. Of course, here Karamsad I mentioned. But nursing college in the BJ Medical College, they also helped us a lot. Nursing council people from Gandhinagar, they also helped us a lot. Midwives group, they had also helped us a lot. And of course, Ahmedabad Municipal Corporation, they helped us a lot. in deputing people for the parents group meeting, deputing people for the different workshops, everywhere. So all these also, give a special hand to Dr. Bhavin Solanki. He really immediately responded and given us a hand, his whole team worked. Then the audiovisual group, thank you very much for all that.
We should not forget the chairpersons, moderators and
Yes.
panelists also. They also have been conducting the last 3 years very actively, and everybody was awake because of that, I must say. And yes, we would like to thank EOK Network for delegating us last 2 years of job. We have been very happy doing it, and in future, wherever needed, we are always there to help.
And Dr. Kimchi, special thanks to you coming all the way. And Majida, special thanks.
Would
And
also
convey
like
to your
thank
whole
all
team
the
also.
delegates
right?
also who have attended this conference for last 2 days. Thank you all.
One. Yes.
Yeah, all of us need to stand up and give big thanks to them. Thank you very much. Thanks a lot.
Thank you.
Yeah.
May I say something? May I just to congratulate the entire Kangaroo Mother Care Foundation of India for putting up such a wonderful 4-day meeting on Kangaroo Mother Care. We really, we did not make a mistake in trusting KMC India to be able to put together such a wonderful learning experience for everyone who came. We look forward really, and we will put this on the map and our news that you have done such a wonderful job in keeping KMC alive through the pandemic and culminating your coordination years with such a good conference. Congratulations, everyone.
And of course, last night we did convey for all our dignitaries who visited us. Dr. V.K. Paul, who had come here, Dr. Neena Raina, Dr. Shobna Gupta, then Prashant Saha, Narayan Gaonkar, all of them, they are all very, very busy people, but still they took time to come here and encourage us. And of course, our KMC champion family is there. Whenever we call, immediately they come. They treat us like family members. So all the faculty members, one and all, thank you very much and hope to meet you all again. Thank you.
Please enjoy the high tea before leaving. Thank you. Can we have everybody just once over here for a big group photograph, please? हाँ, तब चालू करो. You start.